to the society, especially the underprivileged and who are not empowered enough to understand what is health, how it will help, and how the economic is also, the economics of the country is also, health of the person contributes to the economy of the country as well. So I will just say that we should also go a little beyond our sphere and see how we can help these people. Thank you very much and congratulations everybody, and it is really nice and a privilege to be here. Thank you very much.
Namaskar, मैं Dr. Umesh Kapil. I work as a secretary, National Academy of Medical Sciences last 4 years. I would just like to make one statement. Fellowship recognition is for the most eminent medical scientists, biomedical scientists in the country. That's number one. And number two, we have a very transparent system of conferring the fellowship. Okay, 90% of the people I do not know who have been conferred the Sharma sir, upar aa jao. We do not know who are they. We don't know their face, but because of the marks which have been allotted to them, they have been conferred the fellowship. So please disseminate this word to all your colleagues so that more and more people can apply for the fellowship. This year we had 260 fellowships, out of only I think so 58 have been conferred the fellowship. So my again humble submission is, please disseminate this. We are very transparent. We do not take any recommendations and we are honest. Right? Thank you very much.
So the members actually, some of our EC members are also here. So any comment you like to tell, sir, anyone of you?
Well, I'm Professor Anil Jain. I'm Editor-in-Chief of Annals of National Academy of Medical Sciences. I think welcome to the elite club of researchers, scientists, clinicians. Please feel honored, feel proud to be a part of this elite group. And now your onus lies on you not only to conduct but to stimulate others also. So please do stimulate others and please research environment to the country, because that is what is going to help our common men for their pain. I think please contribute and continue to contribute to the research. Thank you.
I echo the sentiments by our colleagues here. Truly it is a great honor. It's a very niche kind of status that you have been chosen through a very rigorous and very strong process of selection of being a fellow. You have earned it, honestly. It is not, it is not easy to be a fellow, to be very honest, as our Honorable President has said that how every year there is a fixed number and everybody has to compete for it. So I want to congratulate you. This is in fact, fellowships like this further empower you to further your academic pursuit, academic endeavors. I hope you will also strengthen the academy, because when you come into our fold, we want our academy to be further strengthened, and many of the fellows, once they become a fellow, after a while they lose interest. So keep your interest alive and keep on contributing to the academy. Thank you so much. Thank you.
Yeah, good morning. Congratulations and welcome to all the newly elected fellows to the NAMS. This NAMS family is growing with the selection of new fellows every year. So it's very good to get the NAMS fellowship. It's not that easy. I remember 17 years back when we get the fellowship, So show the belongingness, participate in the NAMS activities and be part of this. It should not be that you got the fellowship and that's the end and write in your signatures NAMS fellow, but be part of this, show belongingness, continue to participate in the NAMS activities. That will be the biggest contribution. And once again, I congratulate all the newly elected fellows and welcome. Thank you.
Good morning, everybody. I think it's just a repetition what my other colleagues have said. One thing I want to say very clearly is that fellowship you have to earn. It is not given. You have to put lot of efforts. You have to make yourself eligible to get fellowship. The gray area is that the number of fellows, they are increasing, but actually the participating fellows, the number is still very limited. And it is our endeavor and duty to promote in the medical fraternity so that they can join the National Academy of Medical Sciences, which is the apex body doing a wonderful job in research, teaching, and making policies for the government of India. Thank you very much. Congratulations.
I have been told to be brief, so I'll be very brief. I echo the sentiments of the eminent people who are on the dais, and I congratulate you all. But I wish to add 2 points to what has been said already. Number one, that this fellowship is open to medical and all biomedical scientists, which makes its scope very wide. So please encourage your colleagues in different disciplines of health sciences to be part of this, because it's a health sciences fellowship. That is one thing. The second thing I wish to say, that the NAMS also publishes a very good journal. Dr. Anil is next to me, sitting here on the left side. And this journal is 61 years old now. So this journal is being published with a very good publisher. It's an open access, and I would encourage you to please contribute to the journal and think that you should consider this as a first priority of a publication of your good work, so that our National Academy Journal stands out not only at an international level, national level, but also at the international level. I think with these two additions, I once again like to congratulate you all, and I can say that I am very much honored to be part of National Academy of Medical Sciences, which gives you an immense different kind of outlook to your whole discipline, because sometimes you remain focused within your own work, but once you join this organization, you will see that how your spectrum of vision also would be big and large. Thank you very much.
Thank you. So we'll request Dr. Katots, the the former DG of ICMR. So sorry, if you say a few words.
Thank you, Professor Bera, for the invitation to sit on the dais now. Well, I think I'll join all of you in congratulating the newly elected fellows and the members. But one point only which everybody else also said, I'll reiterate. Your action begins now, actually. What you do afterwards, how much you contribute to the growth of medicine in this country, it's academics and also the outreach. That's actually the real fulfillment of the purpose for which the academy has been created and for which you are elected, either a member or a fellow. So I think it's a new phase of journey starts for all of you. So best wishes. Jai Hind.
So now we will request the fellows. Some quick mic de do. Some fellows, if they want to tell something, some newly elected fellows. Some newly elected fellows, if they wish to just raise your hands. Yes.
Jai Hind, very good morning to one and all present here, and it's a privilege to be a part of this NAMS as a fellow. I am Nikhil Srivastava. I work as a Dean of the Dental Sciences at Swami Vivekanand Subharati University, Meerut, and currently working as a principal by profession or by specialization. I'm a pediatric dentist. and it's really honor. And as said by all the eminent guests here, that I will try to contribute whatever I can do in the field of research and outreach programs. Thank you very much.
So thank. So yes, anybody from that side? Yes, please give him mic. Yes, yes, madam. Yeah, please.
Respected person sitting on dais and esteemed audience, it's an absolute pleasure and honor to be granted the fellowship of this, and I can vouch that if people like me, I am an additional professor of orthopedics in PGI Chandigarh, and if I can get this fellowship, any deserving candidate can get it without partiality. This is an impartial body, I can vouch for it. And secondly, I am triple FRCS, probably the only orthopedic surgeon in the country to be triple FRCS, but this FAMS stands beyond those all three FRCS, and I really acknowledge it and I honor it.
Yes, madam. Yes, madam.
Good morning, everyone, respected colleagues on the dais and off the dais. My name is Dr. Shabnam Bhandari Grover. I'm a professor of radiology, ex-vice principal and head of department at Safdarjung, currently working at Sharda University in Greater Noida. And I'm absolutely honored and delighted to be getting this fellowship. And I have worked for 6 years as associate editor of Indian Journal of Radiology and Imaging. And the Indian Journal of Radiology and Imaging is PubMed indexed, and I want to put forward my services to the editor-in-chief so that we can take the journal forward to PubMed indexing, and I would be very delighted to work with you. I'm grateful to the honor bestowed on me by all the colleagues here and the senior colleagues on the dais. And I think I'll be able to contribute. I'm also a member of the International Committee for Radiology Education of the Radiology Society of North America. I think I'm the only Indian on that committee, and I have been given a second tenure as well. So I look forward to contributing to the journal as much as I can. So I would like to meet with Dr. Jain personally. Thank you so much.
Thank you, ma'am. I think so we request that you please give your introduction in one line.
Okay.
Because we have to close the
Yes,
session by 9 o'clock. So we know you are great. You are great scientists. You have contributed a lot, right? And your CV has been circulated to all fellows also. So you give only one line, this thing, that you are from Devgar, you are from Patna, you are from any other place. Okay, that's all. And your specialty.
Okay, good morning, namaskar. I'm Dr. Ujjwala Ghoshal, currently working as professor in head AIMS Kalyani, and just shifted 2 years ago. Before that I was professor in head. For past 25 years I was in SGPGI. And I have been associated with both the PGI and NAMS. NAMS I have come earlier many times because of membership, because of fellowship of my husband, and my husband is from PGI and search student. So I know them all, and as you all said, yes, I believe it is our duty to, since we have been awarded this fellowship, so it is our duty to contribute something, and I am ready for it, and will do whatever in my capacity. I am associated with many societies as a secretary, as a president, and so I will do whatever I can in my capacity for NAMSCON and in medical literature. जय हिंद, जय भारत, and I believe हम सब हिंद देश के निवासी हैं, तो हम इंग्लिश में तो बात करते हैं, हम थोड़ा हिंदी का भी, जैसे आजकल we all are, मतलब हमको हिंदी में भी जैसे आजकल मेडिकल एजुकेशन का बात होता है, तो हम यहाँ पे भी उसको थोड़ा प्रमोट करेंगे तो बहुत अच्छा लगेगा. थैंक यू, नमस्कार, जय हिंद, जय भारत.
Respected faculty, distinguished members and distinguished guests on the dais, I am Dr. Chandni. I am from Kerala. I am professor of medicine and I have been HOD of emergency medicine, currently principal, Government Medical College, Wayanad, and I have been part of the most of the infections that was happening in the Kerala.
Thank you, ma'am. Thank you. Thank you. I appreciate you being brief, so I will request others also to be just brief.
A very good morning to the eminent scientists on the dais, colleagues of the dais. I am Mohammad Salim Khan from Government Medical College, Srinagar, J&K. I am a professor and head of community medicine there and president of J&K Medical Council also. I am the second fellow from the institution, the first being Professor Saeed Nasir Ahmad Shah in 1979.
Thank you, sir. Thank you.
There has been a long gap. I believe it will add
Thank
more.
you very much. Thank you. Thank you. Yeah, please be brief because the meeting has to close at 9.
A
Yeah.
very good morning. I'm Dr. Pratima Gupta. I've been the Dean Research and Professor Head of Department of Microbiology at AIMS Devgarh and Dean Research at AIMS Rishikesh. Now I was on deputation, now I'm back at AIMS Rishikesh. as
Thank you, ma'am.
head.
Thank you. Excellent.
Good morning, everyone. My name is Dr. Anshuman Sevda. I am the Associate Professor and Head at Symbiosis International University. And for my background, why I'm selected, I hope, is I have done my master's at University of Texas, Houston, and I worked on ERIC study and worked at MD Anderson, and I was in the Department of Pediatrics at Columbia University, as well as Mount Sinai Hospital in New York.
Thank you.
Working
Thank
on
you.
genetics and genomic projects.
Thank you.
Thank
Actually,
you.
the biodata has been circulated to
Thank
all
you so
of
much, sir.
us.
It's a pleasure to
We
be here.
only want to see you face to face.
Thank you.
Because we don't know you by face. So the council members would like to interact with you face to face. Just give your name, the city, and the specialty. 3 things only.
Good morning. Good morning. I'm Shormishta De, Professor, Department of Biophysics, AIMS. It's pleasure and honor to be a fellow of the National Institute of Medical Sciences.
Thank you, ma'am. Excellent. So please. Yeah.
I'm Dr. P. A. Mahesh. I'm from JSS Medical College in Mysore.
Just a minute, sir, just a minute. A little interruption here. Dr. Abhijit Sheth is with us right now. He's the chairman of NMC. And I request sir to please come up on the dais. Now you can carry on, please.
Yeah, thank you. I am Dr. P. A. Mahesh. I am a professor of respiratory medicine in JSS Medical College in Mysore.
Thank you.
Good morning, everyone. I am Dr. Rajiv Garg. I am professor in Department of Respiratory Medicine, King George's Medical University, Lucknow. Thank you.
Thank you. Thank you.
Good morning. Good morning. Namaskar. I'm Dr. Vandana Roy from Maulana Azad Medical College, Delhi. I'm extremely humbled and privileged to be a part of this August gathering and hope to contribute in any way possible towards improving the public health and medical education.
Your specialty, ma'am?
Pharmacology, sir.
Thank you.
Good morning. Dr. Shaikat Das.
Hello. Hello, very good morning to all of you. I am Professor Madhu Khanna. I am in the Virology Department of Vallabhbhai Patel Chest Institute, University of Delhi, and I am honored to be part of the NAMS.
Thank you. Good morning. Dr. Shaikat Das, Radiation Oncology Department, AIMS Bhopal.
Just a minute. Another interruption here. Now we have Professor K.K. Talwar amongst us. Sir, the person who was our former director for 7 years, and he changed the face of PGI, truly speaking. I request sir to kindly come up on the dais. A big hand to Dr. Talwar. For us, he is God in PGI, honestly speaking.
Welcome, sir.
Good morning, everyone. I am Dr. Anand Pandey, Professor of Pediatric Surgery at King George's Medical University, Lucknow. Thank you.
Thank you, sir. Thank you.
Good morning, everyone. I am Dr. Viveka Jyotsna, Department of Endocrinology, AIMS New Delhi. I am honored to be here
Thank
and
you, ma'am.
selected. Thank you.
Good morning, everyone. I am Dr. Bhushan Shah. I am Assistant Professor at AIMS Bhopal, and I am the in-charge faculty over there. Thank you.
Thank
Good morning, everyone. I'm Professor Jaya Chakravarti. I'm from the Institute of Medical Sciences, BHU, and I'm in the Department of Medicine, specialized in infectious disease.
Thank you, ma'am.
Good morning, sir. I am Dr. Sanjay Tiwari, Dean Faculty of Dental Sciences, University of Health Sciences, Rohtak. I'm humbled. I'm really honored to get this fellowship, and I really appreciate the selection process. My H index is 29, IT index is 44. I'm first time I applied and really appreciate the selection process. Thank you, sir.
Thank you, sir.
Good morning. I'm Dr. Anshu Rajneesh Sharma. I'm from Co-Club and Dhirubhai Ambani Hospital. I think I feel elated, and it is I can see how tough it to be here in the Legends, because how my candidature has passed, and I'm from private sector, and be part of this great scientist. I'm really thankful to NMS for selecting us and giving us opportunity with the fellow. Thank you so much, NMS.
Thank you, sir.
Good morning, everybody. I am Dr. Neeta Radhakrishnan. I am additional professor and head of the Department of Pediatric Hemato-Oncology at Postgraduate Institute of Child Health in Noida. It's an autonomous institute under UP government, and I'm really privileged to be part of this August gathering. Thank you.
Thank you, ma'am.
Sir, myself is Dr. Ankit Gupta. I'm an associate professor in Department of Biochemistry from All India Institute of Medical Sciences, Raebareli. So it is honored and privileged me to be a part of this society. Thank you.
Thank you, sir.
Good morning, each and everyone.
Only fellows, no?
I'm Dr. Sarang Shetty from Belgavi, North Karnataka. I work as Associate Professor and Unity in charge for knee and hip surgeries. And thank you all the esteemed faculty for honoring us.
Good morning to you all. Myself, Dr. Akhilanand Chaurasia. Currently, I am working as an additional professor in Department of Oral Medicine and Radiology, King George's Medical University, Lucknow.
Respected dignitaries on the dais, I myself, Professor G.B. Jena from National Institute of Pharmaceutical Education and Research. I work as a professor in the Department of Pharmacology and Toxicology. In 2016, I become the member, and now I elected as a fellow, but I know how tough it is. At that time, I met many eminent people, those who were elected as a fellow.
Congratulations to you, sir. Congratulations and thank you.
Thank you, sir.
Please give chance to others.
Okay, sir.
Good morning, dignitaries. I'm Aditi Sinha. I'm Professor of Pediatrics at the All India Institute of Medical Sciences, New Delhi. I do pediatric nephrology, and it's a privilege to be associated with the Academy of Medical Sciences.
Good morning, sir. Thank you very much for choosing me as the member and fellow of this academy. I am Dr. Shuman Karungo. I am the director and scientist G of ICMR RMRC Dibrugarh. Thank you, sir.
This session now comes to an end. Thank you, everyone. Thank you, the elite, the cream of India, in fact. Thank you, sirs and ma'am, on the dais. Thank you, everyone. Now, the next presentation is by NAMS Women Scientists 2025. Now, it goes without saying that it's commendable to see the women of this country. Sir, the Jayashri is there. Is Dr. Manjari here? Dr. Savitri is here. I met her. So we can start with that. Yeah. So it goes without saying that it's commendable to see the women of this country reaching heights. Not to forget the recent World Cup that our little girls won. So for this session, I invite Dr. Y.K. Gupta, NAMS Council Member, Dr. Mahesh Verma, NAMS Council Member, Dr. Sanjay Jain, Dean Research, PGI Chandigarh, and Dr. Bijantimala Mishra, Professor and Head Department of Microbiology, AIMS Bhubaneswar, to please be the chairpersons for this session. A little introduction to the chairpersons. Professor Y.K. Gupta is the NAMS Council member. He is the president of AIMS Jammu and the former president of AIMS Bhopal. He is the principal advisor, Indian Strategy Development, National Scientific Coordinator, Pharmacovigilance Program of India, and the chairman of National GLP Technical Committee. Professor Mahesh Verma, he is the NAMS Council member. He is the B.C. Roy Awardee, National Science and Technology Awardee. He is the Vice Chancellor of Guru Gobind Singh Indraprastha University, New Delhi. Dr. Sanjay Jain, he is the Professor and Head Department of Medicine, Internal Medicine, PGI Chandigarh, and he is also the Dean Research of our institute. Dr. Mishra, she is the Professor and Head Department of Microbiology, AIMS Bhubaneswar, and a Fellow of the Infectious Disease Society of America, Fellow of Royal College of Physicians of London, Fellow of Royal College of Physicians of Glasgow. Thank you. Now I request the chairpersons to please take over.
Thank you, Nandita. Good morning, everybody. In fact, it's a great honor and privilege for me to be here. I am Sanjay Jain. I am Professor and Head of Department of Medicine at PGI, and I am the Dean Research as well. It's a great program which has been laid down by NAMS, and the first program actually is on women scientists in India. As we can make out that the topic for the discussion right now is that on it's a cusp between physics and biology, and we'll be talking of biophotonics, and we have with us Dr. Jayashri, who is an expert in the field. She has worked a lot, and she'll be telling us the basics as well as the utility of this field. Dr. Jayashri is Scientist G and Associate Dean, Adjunct Professor at Mahi Manipal. She has multiple fellowships, multiple awards, and she has more than 150 publications. Over to you, Dr. Jayashri.
Very good morning to all, and thank you for introducing me, sir. So I'm really honored and privileged to be selected as one among the three women in medicine. Actually, I am basically a physicist, but now I am called as women in medicine. So it is so glad to be women in medicine among all the prestigious doctors in the country. So I thank all the committee members and jury members who have selected me, and also NAMS for selecting and also introducing this particular award for women, especially women like me. Always award is very much encouraging, and it is motivating as well. When I say that I have joined the career after a break of 20 years, so for me it is really a privilege to have this, and thank you so much. So with that, I will go to my talk. So I have given the topic as biophotonics and nanobiophotonix, lighting the way for medical innovation. I am from Sri Chitra Tirunal Institute for Medical Science and Technology. I think being a doctor's community, you all may be knowing about the institute. This is in Trivandrum, Kerala, founded by the previous legacy, Professor M.S. Valiyathan, who has passed away last year in 2024. So initially the talk was given for 30 minutes, so I had all the introduction about the institute. Now I have removed all those things. Now I will directly go to my topic because it is only 15 minutes given to me. So my talk will consist of, it's not working, okay. So I have made it into, I am working in these fields, biosensors for IVDs in vitro diagnostics and bioimaging systems, then some theranostics, that is diagnostics plus therapy, and systems to cross blood-brain barrier for imaging as well as for therapeutic applications, the optical pathology and liquid biopsy. So in all, and laser-based therapy. I started my career as a laser physicist in the radiology department of Sri Chitra Tirunal Institute when we had National Laser Program chaired by Professor Bhavalkar early in 1990s. So many of those procedures we are now practicing in our institute. So I'll touch upon all those things, some of these. So these are the research focus under in vitro diagnostics. There are nanosensors, optical biosensors, lateral flow devices, electrochemical devices, electronic sensors, and surface enhanced Raman spectroscopy devices, and nano-bioimaging, multifunctional nanomaterials, fluorescence imaging agents, Raman imaging systems, MRI contrast agents, angiogram imaging agents, and in nanotheranostics, photodynamic, photothermal, magnetic hyperthermia, etc., and also some under optical liquid biopsy where we use spectroscopy as well as chemometrics and AI and laser-based procedures. So under this we have done a lot of work. I may bring to your attention few of this. So the first one, under in vitro diagnostics, that we have, most of my work is related to the technology development, and I'll have majority of these work that I am presenting here will have some technology leads. So here it is a technology for identifying or detecting circulating tumor cells from the blood. So here we have developed circulating tumor cells. All of you as a doctor, medical community, I don't want to introduce what is circulating tumor cells. So this is for detecting the tumor cells in the case of metastasis. So we have developed a technology wherein we have developed a filter. That filter is having pore size of 8 micrometer, and the filter is also modified for attaching or detecting and having affinity towards the circulating tumor cells using different antibodies, and we make a sandwich technology over the filter. The filter is this one. Sorry, just gone. This one, and this filter is included inserted in this 3-chamber tube where you can filter the blood, and you can take out the filter and see under the microscope where you can see. Do I have a pointer? So you can see the circulating tumor cells under the microscope, as you can see on the right side. So this is the technology that we have developed for detecting circulating tumor cells. And a lateral flow assay device we have developed during COVID. This was funded by SERB DST. And we have developed a lateral flow assay device for detecting COVID spike protein of COVID, where we have used in comparison to the lateral flow assay device that is available in the market, we have used a different chromogenic substance, and the chemical used on the chromogenic substance is different. So we have used paraphenylamide, and also we have used enzymatic property rather than using the common plasmonic property, so that we got much higher sensitivity and visibility of this positive cases. So that was our achievement, and this has been awarded a patent in the US patent as well. It is done by my PhD students. And we have also developed a mobile-based app for this lateral flow assay device by quantitatively assessing the amount of spike protein available. Usually the lateral flow assay devices are qualitative. We have made it slightly quantitative. And as you all may be knowing that the Alzheimer's disease, it is how dangerous it is, and WHO has identified in 2024 that Alzheimer's disease, the importance of detecting it early, because many of the underdeveloping countries like Africa and all, many of the patients, they do not know whether they are having Alzheimer's disease, so that the management of the disease becomes very tough. So in that case, there is a strategy, out of 7 strategies, they have identified the 5th one as identifying blood-based biomarkers from the patients. So we have also made an attempt to identify the blood-based biomarkers, and with the biomarkers we have identified are A-beta-42, A-beta-40, T-tau and P-tau. And you can see that the concentration of these biomarkers in the blood is comparatively very, very low compared to CSF, where CSF is the currently adopted technology, as well as PET scan, amyloid PET scan. So there is not no technology available to detect these biomarkers from the blood. So we have attempted to diagnose or detect these biomarkers from the blood, and for that we have developed a substrate. You can see the substrate development details. I am not going to, because that may not be out of the scope for this particular audience. So this is the main work involved in this technology. So this one is developed, and we have recorded the spectral features, and we have applied machine learning on this. And so you can see the table under here. You can see the sensitivity and specificity. This is mild cognitive impairment, control, and Alzheimer's disease. 3 category of patients we have considered, and 3 different machine learning techniques also we have used: MLP, RBF, and SVM, out of which the RBF gave better results compared to others. And even then we found that differentiating MCI from AD was a little tough with the sensitivity and specificity coming to only 61 and 50. But we are working on that to improve that. And we have also developed another competitive LFA, that is lateral flow assay device, for detecting the blood-based biomarkers, and we got very good precision and accuracy. Here also we have used machine learning techniques. And finally we have made, because these techniques are a little bit complicated, clinicians always want to have simple procedures and simple handy techniques. So we developed an electronic sensor, a portable electronic sensor. There also you can see the tedious procedure where we have used a interdigitated electrode and modifying it with all sort of things. So finally we get a small change in current when the antigen is in contact with the antibody, that is of the order of nanoampere current. So this nanoampere current is amplified, and we developed a portable system like this so that you get the amount concentration of different biomarkers, and this technology will be coming to the market very soon. So this is regarding the Alzheimer's disease biomarkers, and we have also made several nanotheranostic things. And the one thing that I would like to show it here is we have developed a material that fluoresces on its own, so that you don't have to use any other fluorescing dye. You can see the red color is coming from the particular electronic state of the material. So this has got, we have imparted blood-brain affinity, so that you can see this material crosses the blood-brain barrier. And these are the lab tests where you check the brain potential and permeability and all those things. And we developed a material which can cross blood-brain barrier. Then we thought, okay, we have already the diagnosis of Alzheimer's disease, whether we can look for the treatment of Alzheimer's disease. So we have chosen cysteine, that one of the smallest amino acid, which has got a particular property that it docks exactly to the KLVFFA state sequence of A-beta 40 and A-beta 42. And the docking study states that once it gets docked, it disintegrates this peptide sequence. So we all know that basically, even though there is controversy about this statement, that basically it is understood that the Alzheimer's disease is the outcome of the amyloid fibrils and phosphorylated proteins. So we have shown that this is the fibrils developed in the lab, and we have added these materials at different concentrations to the fibrils, and we found that you can see the fluorescence is decreasing as the fibrils are disintegrating. Finally, at the 40 microgram and 60 microgram, the material has completely disintegrated, so that this material could disintegrate the fibrils completely. So that gave a hope to us, so that this could be used for the treatment of Alzheimer's disease. Then we tried this in the animal models. So we have induced Alzheimer's disease in animals by introducing streptozotocin in the cerebrospinal field, and we have done several tests to study the behavioral pattern of these animals after injecting this material. We have injected two types of groups. We have one is inhibition model and one is dissolution model. In one model, we have developed the Alzheimer's model completely, then introduced the material. In another one, we have treated while the model inducing is in a process. So this is the Y-maze assessment, where we have, these are all established protocols. Maybe neurologists present here may be knowing, to test the memory of the animals. And then open field test, and here you can see, while you look here, the control has almost similar to the treated group. The values are closer to the control compared to the Alzheimer's model. And the pathology and immunohistochemistry also shows that this is the Alzheimer's disease, the second one. And sit time, okay. How many minutes, sir? Over.
Okay, you will take 1 or 2 minutes.
Okay. Okay. So the pathology and the NFL beta also shows it is closer to the control. So quickly I will show few laser treatment that we have established. These are standardized in our hospital. Laser-based assisted revascularization. This is the animal model developed and animal test before going to the clinical. Here these are the clinical example. You can see this is the fully occluded vessel, where we have, you can see the treated vessel. It is you have to sit at different sessions, and we have used for tumor ablation of esophagus and also for bronchial lesions. And another procedure that we have used is for the percutaneous laser disc decompression for disc prolapse. And here again, this is a rabbit model, and you can see this is the disc space. Introducing the needle, and you image under fluoroscopy, live imaging. Then this is the clinical trial. These procedures are being practiced in the institute. I don't know whether this is practiced in other parts of the country, but we are regularly using this for disc prolapse. And also we are using laser for osteoblast treatment and also for varicose vein treatment. And we have used some of the materials for SIR done, I think. Okay, I'll go to the last slide. Okay, some imaging contrast agents also we are developing. So many we have developed. And with that, I end here. Thank you so much, and thank you for the opportunity.
One quick question, if the audience would like to participate, because this is really a wonderful presentation, and I must say that it gives you an overview of what actually is ongoing in the field of diagnosis and the treatment both, because I'm pretty sure about it that there will be plenty of questions, because, yes please.
Yeah, actually the sensitivity part, you can see the number of cells that is as per the remote is as low as 5 cells per ml. So in our case, we could find out one cell per ml. So that is the lowest. So the sensitivity maximum that one could achieve. So we could achieve the sensitivity as high as possible.
Thank you, Dr. Jayashree. I think I have been knowing Dr. Jayashree for the last 20 years as not only is extraordinary women scientist, but as an extraordinary extracurricular activist also.
Thank you.
So many activities.
Thank
So Dr. Jayashree, just one question. Do you have any message to the young women? You're not young, but women's fraternity here. Because I see 80% of the audience are women here.
The women always been young.
My eyes stand corrected. Because if I see 80%, I think more than 80% today in this audience are women. So clap for them. So any message you would like to give to them,
sir,
to be so successful in your scientific as well as other than scientific activities?
Yeah, definitely. I can tell you my own example, as I am working a lot for the women scientists and girls to pursue their career in science field, and also I was the nodal officer for the Gadi program of DST, which made our institute a Gadi achiever. So what I would like to tell you is your hard work and your perseverance only will take you to the heights. For example, if I tell you my own example, I had a break-in career of 20 years. And I have brought up my children. I have 3 sons, and 2 of them are doctors in US. One is a pulmonologist, one is a cardiologist, and one lawyer. And after that, I joined my career at the age of 45. And whatever you could see here is after I have achieved.
So let's give her a big hand. You know, I will like to say thanks to her in our own language. Valya Nanni. Jayashree. Thank you.
Nanni, namaskaram.
So can we have the next speaker? In the meanwhile, I'd like to introduce Professor Manjari Tripathi, who is Chief of Neurology at Orani Institute of Medical Sciences. You know, I looked at her profile. She's a giant, truly giant, a legend in epilepsy, because she got NIH fellowship in epilepsy at UCLA. She also got mini fellowship in epilepsy at Wake Forest University in NC, North Carolina. Alumni of San Servolo School of Epilepsy, Asian Oceanian Outstanding Award for Epilepsy in 2016, ILAE Task Force Member of Epilepsy, Coordinator of National Epilepsy Control Program, Ministry of Health, and also the National Course Coordinator of Epilepsy and EEG workshop all over the country. Professor Tripathi, truly I feel that you have really re-looked and re-energized this area of epilepsy, which is so prevalent. So over to you. We would like you to share your thoughts with us. Thank you.
Thank you. And at the outset, I'd like to thank NAMS and all the members who selected me for this honor. This honor comes from 30 years of work in neurology and with epilepsy. My topic today is a more general one because the audience is mixed. So it's not going to be very basic research, it's going to be humane research. And I'm going to be talking about what are the disparities in health as we sit here. And since it's a women's award, it's based on gender-based epilepsy care. Is there an equity in terms of women getting equal care in epilepsy? Now, we all know women are different, and sometimes this difference does become a hindrance to our growth. And the neurological conditions which they face, again, kind of puts them at a risk for discrimination and getting out of jobs as well as marriage. It is said that being a woman with epilepsy is not the same as being a man with epilepsy. And this is way back, almost 20 years before, by Crawford. I conduct epilepsy camps in rural Odisha, which is my alma mater, which is MKCG Medical College, Odisha. And fortunately, my family is now, from my husband's side, is based in Odisha. And as you can see here, it's not unusual for women not to ever achieve their aspirations. As this young lady in our PHC camp has epilepsy, she has burnt herself several times because she has to do the cooking in the house. You can see the keloid in her jaw there. So the burns have formed keloids. And she is not married, she's bought by her brother. Similarly, you have a 32-year-old tribal woman in the same region, coming 50 kilometers from the site of our camp, and she has 6 to 8 episodes per week. She has never been started on any treatment, and she was advised to take herbal roots. And she has been taking these forever with continuing seizures. So this is the second scenario, where actually they do not take the usual treatment, and they go in for some kind of local treatment because it is inaccessible to them. There are several phases through which a woman who has epilepsy passes through, which is very similar to a normal, non-diseased person or woman. There are aspirations she has, aspirations which cover the lifespan starting from puberty, menstruation, and then you have seizures which get aggravated during the periods, which is catamenial epilepsy. And then you have gender-specific effects of anti-seizure medicines, which, if wrongly started in a woman, can give rise to hirsutism, obesity, polycystic ovarian disease, loss of hair, etc., etc. And we know that's phenytoin and valproate. And sadly, these are still used in many areas. Then, of course, there are issues with fertility and contraception, and pregnancy which they face, and of course sexual dysfunction which they rarely ever get to talk about, and then the onset of menopause and osteoporosis and fractures. However, my message is that research from our institute and worldwide shows us still 95% of pregnancies are safe in women with epilepsy. Now this message does not get out there because sadly even now they are told you cannot have children, you will have to stop your medicines, and this is prevalent now. I really don't have to present statistics about it. So to give you a broad overview, there are biological implications of the disease itself, there are social implications of the disease in women, and of course there are pharmacological implications, and some of the research I have done with Professor Y.K. Gupta, which has been published, can be read later by you all. And then you have this, PCOS is so common. Even if you don't have epilepsy or not on medicines, young girls are getting PCOS. It's much more. It's almost 80% of women who who have epilepsy on anti-seizure medicines have PCOS. Way back when I joined the institute, we surveyed women for 10 years. 98 I joined, this was 2008. And we looked at what are the psychosocial impacts of epilepsy in women. And what we found was, we compared it with migraine, because migraine is a chronic disorder with episodic manifestations, and so is epilepsy. It's a chronic disorder with episodic manifestations. So they are kind of comparable. And it was, this study really highlighted, you know, the reviewers asked us, why is this that the women with epilepsy in India are coming 10 years after the onset of epilepsy to a center to take treatment? So we had to give a lot of explanations. There were a lot of psychosocial implications. They believed more in religious practices when the seizures happened. They did not take anti-seizure medicines. They were more confined to home, never left home because they had seizures which were not controlled because they were not having a good treatment-seeking behavior, because they would be stigmatized by society. So this was the opening window for our research. And hence, psychosocial impact on various factors, including health-seeking behavior, was there. This study found that women with epilepsy had huge amount of stigma. And this stigma was individual, social, and community driven. The individual stigma was, you know, it was married with low self-confidence, withdrawal, and self-imposed isolation, financial losses, and of course, somebody to look after them all the time. We then looked at epilepsy with stigma. And this cohort of 300 odd patients, with our psychologist Ashima, who's also from PGI Chandigarh, now in AIMS. So what we found was that in our 360 women, there were several behavioral and psychological issues, education, marriage, and treatment adherence issues, which led to stigma. But in addition, when we applied the disability scores, they were disabled due to this. Now, this disability does not reflect in your classical disability measurements. Because there is no physical disability, they are walking about, you can't differentiate who an epileptic woman is from a non-epileptic because she looks similar. Maybe she'll have some hirsutism or gum hypertrophy. But otherwise, in a hall of 100, you really won't know who has epilepsy. But that woman was disabled in terms of the criteria of WHO. We designed multi-intervention designs, which were again published, on the root causes of stigma based on the attitudes and beliefs, and also the caregiver attitudes. And we employed cognitive behavior therapy and caregiver counseling. So really this led on to another study as to what is the intervention in stigma. As of now, there is no known class 1 evidence as an intervention for stigma. The evidence which is there is of case control studies where knowledge, attitude, and practices, which are the CAP studies which have been done in India. There is no direct intervention study to say my self-stigma can go. We first looked at the role of expressed emotions. You know, in our life, we often talk, and very often we talk loose. So we looked at what the family was talking to the woman who had epilepsy, which is known as expressed emotions. Now, expressed emotions can be of two kinds, positive expressed emotions and negative expressed emotions. So you can say the same thing with the levitating effect and the same thing with the depressing effect, which was then published. That is, do expressed emotions result in stigma? And yes, they do. Caregivers, where it was found that the caregivers were expressing negative attitudes, mind you, even the mother was expressing negative attitudes like, ye to kuch nahi kar payegi, iski shaadi nahi ho payegi, ye pad nahi payegi. All those things were accumulating in the child's or the lady's hidden stigma and disability. Then, of course, we had to plan an addition of a host of services in the institute, which involved our psychologists, which involved our psychotherapists, which also involved our yoga practitioners. The goal of which was to promote independence in adult life in young women with epilepsy. This further led on to our next study, which got published in Impact Factor 11 journal, and this was yoga in epilepsy. And thanks to our yoga center at AIIMS, I had a brilliant PhD who's now in London, and she looked at the primary outcome was a reduction in self-perceived stigma. Remember, I told you there was no level 1 evidence for stigma. The secondary outcome was a reduction in seizure frequency. Now, this is the only study which is having level 1 evidence in the world, and first of its kind, which showed that self-perceived stigma based on 2 stigma scales was reduced by regular use of yoga in a woman with epilepsy. And this was published in a journal which has impact factor 11. Then we said, okay, now these people have PCOS, they are obese. Is there anything we can offer? Many patients, caregivers ask us, can you do something? Do I need to give some special diet to the child so that she doesn't gain weight or she loses weight? And then we looked into the role of diet in epilepsy, particularly in adolescent girls. And this book is driven, it's there on Amazon. The book is driven by a young mom whose child had epilepsy. So you can see her, Damanpreet Kaur. She designed all the Indian recipes for ketogenic diet. And this was again published as the first of its kind trial in modified Atkins diet in people with epilepsy who are adolescent and adults. Till now, diet was used in kids, in infants with refractory epilepsy. Then, of course, we worked in a publication where we looked at what are the lifestyle measures. You know, many of us are leading haywire, hippie lifestyles. So usual things of sleeping for 8 hours, which is normal. All of us should be sleeping for 8 hours. Avoiding alcohol, not taking stress. Is my time up? So apply for epilepsy. I would like one take-home message for you all. That is, please do not tell women with epilepsy that childbirth is unsafe or they cannot have children. The message which has to go down to any young girl is, of course, to get educated, have a job, employ successful contraception methods which are available for women with epilepsy. Don't give them COC pills, give them progesterone only. And of course, if they've had one child, go ahead with the intrauterine devices. The biggest challenge which I face as a clinician is the retention of marriage of a woman in epilepsy. And there is no easy solution. Whether the girl with epilepsy has a love marriage or an arranged marriage, it is a big problem. And then we know that arranged marriage is something which, you know, is under control of the parents and the family. The central law was equating epilepsy with lunacy. And the Indian Epilepsy Association removed this act in 1999, and epilepsy is no more a basis of divorce. I'll go through this quickly. We had a meeting which was again in Punjab, where we looked at the issue of marriage, because this is the elephant in the room for girls with epilepsy. And we came out with guidelines as to how disclosure should be done in women with epilepsy so that they are not stigmatized and their marriages do not break. We also have a matrimonial website for epilepsy people where they can, you know, kind of find their life partner with a similar situation. I think I can end my talk by saying that about 30 years of my work of looking at women with epilepsy, I still feel we've done only a drop in the ocean and there's lots more to do. I request each and every girl in the audience to make sure that this message goes that women with epilepsy can lead a normal life. The first step is to get educated, then to get a job, then to decide a life partner, and 95% of them can have a normal pregnancy. Thank you.
Thank you, Manjari Madam. Please give her a big round of applause. Thank you for letting us know that it is different for a woman with epilepsy to be with epilepsy than men, and there are gender-specific issues with epilepsy, but not affecting fertility, contraception, and pregnancy. And you know, the best message you gave: childbirth is totally safe in women with epilepsy. And finally, she said that epilepsy is no more a legal ground for a divorce. So very good enlightenment. Thank you, Manjari Madam. We can have a couple of, just one or two quick questions if anybody has anything in mind. Any questions? I think your delivery has been crystal clear. Thank you, Professor Manjari. Thank you.
Thank you, sir.
So, ma'am, would you like to introduce the third speaker?
Yeah, it's in fact an honor to introduce Dr. Savitri Sharma, who is a legend in the field of microbiology. She particularly works on ocular microbiology. She is Director of Emeritus of Laboratory Services, L.V. Prasad Eye Institute, Hyderabad, and described the first case of acanthamoeba and microsporidial keratitis in India, published more than 380 papers, 90 book chapters and a book. Past President of Indian Association of Medical Microbiologists, past President of Indian Society of Medical Mycologists, past President of Ocular Microbiology and Immunology Group, USA, and in recognition of her contribution, L.V. Prasad Eye Institute has established Savitri Sharma Chair of Ocular Microbiology. Over to you, ma'am.
Thank you so much. Good morning, everybody. At the outset, let me first thank NAMS for this honor. I'm very happy to be here. I came to some of the meetings earlier. So I bring to you greetings from L.V. Prasad Eye Institute in Hyderabad. And this institute is spread across many states. As you can see, we are in 310 locations as a vision center at the base of the pyramid with the Center of Excellence at Hyderabad. We are in Bhubaneswar, Vizag, Vijayawada, and also in Kadapa as secondary centers, tertiary centers. So I'll be taking you to the world of eye, as I've spent my last 40 years in eye hospital at Arvind Eye Hospital and L.V. Prasad Eye Institute, and have chosen to talk on fungal keratitis. All of us are aware that fungal infections are very common in India, and the eye is not spared. The cornea is the front portion of the eye and is very, very vulnerable to infections, including fungal infections. Clinically, you will see many varieties of fungal ulcers in the cornea, as is seen here. On the left side, you have a central, the cornea is supposed to be clear, but on that clear thing, we have the white infiltrates. There is some hypopion, which is pus in the anterior chamber. You also have another one, which is brown in color. It's actually caused by a brown fungus. So a variety of clinical features can be seen. As is shown here in the world of the many reports, the fungal infections are very, very common in tropical areas, including India. And of the fungi that are present in the nature, it is the filamentous fungi which cause the disease in the eye more than the yeast or candida, which is the endogenous. This is data from L.V. Prasad Eye Institute. You can see large number of fungi here. And there is one group which is unidentified mentioned below. Similarly, in dermataceous, black fungi also, you have unidentified dermataceous. Diagnosis of these infections begins in the clinic with the characteristic clinical features, and investigations can be non-invasive, like you have a confocal microscope in the clinic which shows different layers of the cornea, as shown here in the Langerhans cells, corneal nerves, and endothelium. So in such a beautiful machine, in the clinic, the ophthalmologist can actually see the fungal filaments inside the layers of the cornea. And often the diagnosis is made in the clinic itself. We did a study where we compared the microbiological as a gold standard along with confocal microscopy and found a sensitivity and specificity of almost 90%. So what we do in the clinic is actually we take the samples from the eye in the clinic. We do not believe in taking a sample and sending it to the lab and then wait for the report. we take the cornea scrapings from the cornea directly from the lesion and put it on slides and different culture plates and then bring it to the laboratory. In the laboratory, we have, this is just a schematic diagram of several media and slides that are taken, and the tests are done in the laboratory. Despite accurate diagnosis and treatment, the outcome can be variable in these cases. So here is a case who had no history of trauma, and the smears, they showed the septate fungal filaments, and the lesion can be seen here as a raised infiltrate almost occupying 1/3 of the cornea, and while putting the fluorescein, one can see the epithelial defect. The patient smears were positive, culture was positive, and the treatment, the organism was Fusarium species. The treatment given was natamycin with good results. Here is another case where similarly we had corneal infiltrate, fungus was seen in the smears, and natamycin is a drug of choice in such cases. Ketoconazole were also given orally, but the condition worsened. In the first case it healed, and here we have a case where despite the same treatment and fungus confirmed corneal ulcer, we are seeing no response. It worsened. There is fungus you can see grown in the culture, completely worsened, and lots of pus in the anterior chamber. And finally this patient had to go for keratoplasty. We had to remove the cornea and replace with a new one. I bring to you another case which looks like fungus clinically, and in this case it was thought to be a Murren's ulcer, an autoimmune disease, but when the smears were taken, this is a gram stain, you can see broad filaments which are just winding up, and it is aseptate. And this we confirmed, we were the first ones to report from India, a Pythium insidiosum keratitis. This is how it looks in chalcofluor white staining under the microscope. And what's interesting, it does not respond to antifungal drugs. It looks like fungus, but it needs antibacterial treatment, and I'll tell you why in a moment. So it requires linezolid and azithromycin as the treatment, because here is a cell wall structure of fungus and Pythium. You find no ergosterol in the cell membrane, and that's why it is not susceptible to natamycin. It requires antibacterial antibiotics. We were able to identify these organisms easily in the laboratory by demonstration of zoospores, which is very simple technique, and we don't need any sequencing, or which we did initially, but sequencing is not always required to identify this organism. It can also be tested for susceptibility to different antibiotics, as is shown in the Muller-Hinton-Agar on the right side. We have developed PCR. It was done in our Bhubaneswar center, where PCR can differentiate between fungus and Pythium. One can do it in the cornea scraping itself. Directly you can differentiate between these two organisms. Here is another organism which we reported first from India in 2003. It's called Microsporidia, which is very much present in water in our environment, and lots of patients get what is called keratoconjunctivitis, but I am showing you a case of stromal keratitis, which is much more severe, and it requires actually keratoplasty as a treatment, because there is no drug to which this organism is susceptible easily. This is how it looks. It's a protozoa, or now it is supposed to be pan fungus. You can see easily in chalcofluor white and gram stain. Histopathology of the corneal button, which is taken out at the time of keratoplasty, shows the presence of acid fast, a very easily identifiable organisms. So as far as identification of fungus is concerned, we go by the usual methods of colony character and rate of growth, but now we are also depending on sequencing, because of in the list of fungi I showed you unidentified fungi. So it requires sequencing DNA for identification, and this is the region of the gene ITS that we use for sequencing. And we have been able to report many newly described fungi like Macrophomina, and same was the case with Pythium insidiosum, which I had actually first got it by sequencing. People have published algorithms of treating such cases, all fungal keratitis. First we try natamycin. That's the only antifungal eye drop that is available in the market. And now they have azithromycin also, but natamycin is the first line of treatment. And if patients do not respond to that, you add voriconazole, which is also given topically. And if they don't still respond and fungus is confirmed, then you can give intrastromal injections of voriconazole. In the lesion, directly in the cornea, we can inject. And if they still don't respond, then you have to go for keratoplasty. It's very unfortunate that a very large number of fungal keratitis patients do not respond to medical therapy, especially if patient has gone through different types of drugs initially, undiagnosed cases treated with antibiotics mostly for a long time, and then patient comes to us. We often find that it already whole cornea is involved, and it's very difficult to treat medically. The risk factors of non-responding or poor outcome, a large size of the ulcers, presence of hypopyon, and recent literature shows there is something in aspergillus which actually makes it very, very difficult to treat. So we are looking at other alternatives. What else can we do to avoid the surgery and removal of the cornea? And one of the things is that we are trying is called photodynamic therapy. Using rose Bengal dye and photodynamic therapy, green light of 560 nanometers is used. We have first tested this in vitro. This was given to us from Bascom Palmer Eye Institute in the US. The machine itself is a prototype made by them. And we tested first in vitro. The upper two are showing you fusarium. The fungus fusarium, you can see the central part, there is no growth. And so clearly, it was susceptible to the photodynamic therapy. Whereas aspergillus in the lower part shows that it is not susceptible. So aspergillus is resistant not only to medical therapy, but also to photodynamic therapy. This is how we did it in the clinic. The results were matching with what we found in vitro. And this is one case with photodynamic therapy, natamycin has responded. This is my last slide, last but two. Superficial keratectomy, tissue adhesive, and full thickness penetrating keratoplasty are the surgical methods that we use for. And I think all of you know that transplantation is very, very successful in the cornea, especially because the organ is avascular and is immune privileged. Antibiotic resistance is being seen. This is something which are not being tested commonly by people, and therefore we do not have historical data, but we are finding some amount of resistance to the drugs that we are using, and we are still collecting data to understand what exactly to be done. So need of the hour is to find better drugs, water-soluble agents with low toxicity. And to summarize, the fungal keratitis is a common eye infection. In India, Pythium insidiosum requires antibacterial treatment, and penetrating keratoplasty is needed in non-responding cases with fairly good results. Thank you so much for your attention.
Yes, any questions? Any questions on mycotic keratitis management?
Madam, I just wanted to ask you, you don't use systemic antifungals?
When the ulcer is very large, then we do use ketoconazole orally. But we don't really believe, because recent papers have shown that it doesn't really, because it doesn't reach the cornea.
So let's give her a big round of applause. I think we are about to close this session, and the next session.
I think there was a question.
Yeah, sir, please do, please, sir.
I hope it is not damaged. Thank you.
How do you diagnose? Any special stains is required?
No. What the same methods that we use, I showed a picture of gram stain and chalcofluoride. The characteristic features of the filaments is enough to, if one learns that, it's enough to diagnose.
So we always try to miss it with the other fungal keratitis. We missed earlier so much of
So now we are published enough to give the idea how to identify that. Yeah. Thank you.
Thank you so much. I'll just take a minute and recapitulate what we had in this session. Our first speaker was Dr. Jayashree, who developed technology for lab on disc device test for a tumor cell in blood. I think very great intervention, and also a lateral flow device for viral load, which was used in COVID. She also developed blood-based biomarkers for Alzheimer's disease, and also attempted treatment for Alzheimer's disease, and also laser-assisted revascularization of tumor ablation, as well as decompression of disc prolapse in neurological condition. Then we had Manjari Tripathi. The carry-home message was that gender-specific issues with epilepsy affect women. There are psychosocial impact and impact of stigma on quality of life, leading to disability, and ultimately it is affecting the stigma. Yoga for epilepsy, very good, she said, lessen stigma and seizure frequency. Keto diets helps, in such cases, adolescents and kids. Lifestyle modification also helps. And finally, we had Savitri Sharma. She said that sometimes all these fungal cases do not respond with antifungal therapy. Big message. Sometimes respond to antibacterial treatment rather than antifungal. PCR can differentiate between fungus and pythium, and stromal keratitis ultimately needs to corneoplasty, that means cornea replacement, and large number of fungal cases do not respond to therapy, and the photodynamic therapy works as adjuvant therapy. So thank you, we had a good session, and thank you on behalf of everybody. Let's thank all my colleagues, Dr. Jain, Dr. Y.K. Gupta, and Madam Mishra here. Thank you.
Thank you, sir. And after the three stunning talks, now we move on to the felicitation ceremony. For this I request Professor K.K. Talwar to please come up on the dais and felicitate our chairpersons. The women scientists will be felicitated in the evening and during the convocation. Thank you, sir. Thank you, everyone on the dais. There is no formal tea break today, so hence there is running tea outside. So anybody who wants to have tea can kindly take the tea from there. So now we move on to the next session, which is the panel discussion 1, medical education in India. This is, of course, as all of us know, the foundation of medical care in any country. And for this, I invite Dr. Ashok Kumar, Dr. Ashok Sharma, who is the council member of the NAMS, and Dr. P.R. Mahapatra, who is the Dean of All India Institute of Medical Sciences, Bhubaneswar. I think Dr. Rajendra Prasad is not with us today. Dr. Ashok Kumar, he is the council member of NAMS and a consultant pediatric surgeon at the Manipal Hospitals, Jaipur. He is the former senior consultant, Fortis Escorts Hospital, Jaipur. Dr. Sharma is a proficient in managing congenital anomalies such as diaphragmatic hernia, keratomas, and undescended testes, as well as acquired conditions like appendicitis and gallbladder stones in children. His dedication to pediatric surgery has made him a trusted name in Jaipur and beyond. Dr. Mahapatra is the Dean of AIIMS Bhubaneswar. He is the professor and head Department of Pulmonary Medicine and Critical Care at AIMS. He has a large number of fellowships to his name. He is the Fellow of Royal College of Physicians, London, Fellow of the Royal College of Physicians, Glasgow, Fellow of the American College of Chest Physicians, US, Fellow of the American Thoracic Society, US, and the Fellow of the American College of Physicians, US. Dr. Sharma, please. Sir, please take over now. So this is a panel discussions, and there are 6 panelists in this session, and they'll be invited by the chairpersons. So the panelists are Dr. Abhijit Sheth, Dr. K.K. Talwar, Dr. Saurabh Varshney, Dr. Sanjeev Mishra, Dr. G.P. Thami, and Dr. Nitin Nagarkar. They'll be introduced by the chairpersons.
Good morning, everybody. It's a pride moment for me to introduce the dignitaries of the medical sciences, all the panelists, and they are actually the teachers of the teacher, mentors of the mentor. They are institution in themselves. So I welcome all of them, and we proceed with some introduction. That first, Dr. Abhijit Sheth, Chairman of the National Medical Commission, a renowned cardiothoracic surgeon, a former head of the National Board of Examination in Medical Sciences for 9 years. His priorities include improving the quality of medical education, promoting good governance, and easing unnecessary regulatory barriers for the institutions.
Good morning. I got opportunity for introducing Professor K.K. Talwar. He is Chairman of Cardiac Sciences, PSRE Hospital, New Delhi, eminent cardiologist and medical academician and writer, former Chairman and Medical Council of India, and former Director of PGI Chandigarh for decades, and former performed first implantable cardiovascular defibrillator therapy in Southeast Asia, credited with introduction of cardiac resuscitation therapy in India. He is also BCRI awardee and Padma Bhushan awardee in 2006. Thank you, sir.
Dr. Saurabh Varshney is a Executive Director and CEO of the AIMS Deoghar, National Member, IMA Standing Committee on Cancer and Tobacco Control, Indian Contact International Agency on Tobacco and Health, recipient of Tobacco Control Grant, recipient of Lance Armstrong Cancer Control Giant Grant, National Member IMA Standing Committee for the National Initiative for Safe Sound, National Consultant FOPL, and he has 368 publications and written 12 chapters and books, 3 books with copyright. Thank you.
Next, sir, Professor Sanjeev Mishra is Vice Chancellor, presently Vice Chancellor, Atal Bihari Vajpayee Medical University of Uttar Pradesh, and former Director and CEO of AIMS Jodhpur, and since 2000, for almost decades, and in charge of Rishikesh, Gorakhpur, and Rajkot also, and former Professor Head of the Department of Surgical Oncology, KGMC Lucknow, Fellow of American College of Surgeons, visiting Professor to King's College London, Liverpool, Rochester, USA, and St. John Hopkins Medical Center, USA, and University of Pittsburgh Medical Center, USA. Has over 230 publications and 30 chapters, several international and national peer-reviewed journal and books. He is included top of 2% researcher in the world by Stanford University.
Now I introduce Dr. G.P. Thami, who is Director, Principal, Government Medical College, Chandigarh. Focus on improving the institution through initiatives like faster treatment delivery and reduced waiting time, enhancing educational quality and increasing seat capacity. His plans also include exploring public-private partnership for services like CT scans, MRIs, and implementing a new queue management system.
So I got opportunity to introduce Professor Nitin Nagarkar, who is my ex-senior colleague at Chandigarh and former director of AIMS Raipur for a decade, and also in charge of AIMS Bhopal, and Professor of Government Medical College, Chandigarh. And his award and orations are L.H. Hirannani Oration in 2013, Professor Raghav Soran Oration 2013, Dr. M.L. Rathi Oration 2014, and L.H. Hirannani Oration 2014, and V.P. Oration in 2015.
Before starting, we will be running few slides to give a clue that what sort of questions and what sort of problems we are discussing today. So we will run few slides and then ask questions to have their, valued opinion of the experts who are likely to change the scenario in the medical profession. I'm sorry, there is some, will take some time to start the slides. Just to keep the ball rolling, I read out some of that. The Indian hosts the world's
So today's panel discussion is medical education of India. Next slide, please. Next. India has world's largest undergraduate medical education network with nearly more than 780 medical colleges and annual intake that around 1,37,600 medical students till date. Next. Health workforce gaps are a particular contribution to this issue, shortage of doctors, skewed distribution, and mismatch in skills. This expansion is a powerful national strategy aimed at strengthening health workforce, improving with access, and extending the reach of quality of healthcare. It is within the broader context of service and social justice that Indian education should be understood. Our goal is today to discuss this issue and explore actionable solutions. Let's begin with I request Professor Talwar to discuss any reason that any medical profession is no longer a preferred option for some of the brighter youngsters. Can you just have some light, please?
You see, I think this is I'm sure, matter of concern for all we professionals, that today medicine is not a preferred choice among the young, bright students. I'm sure those who have children or grandchildren that today must be also wishing that no, they try to opt IIT, IIM. Why so? I think at one stage medicine was the most, it's a more noble profession. I think there are a few reasons for it. Before I go to the reason, I'd like to focus on one more issue. I'm sure most of you may be aware, last year, the DMMCS seats in cardiology and cardiac surgery, 150 went vacant. Nobody wanted to go into these specialties. Why? These were the most sought after specialty, I think, when these were started. I think one reason is a long career. The second, I feel today, anybody who goes for medicine or medical MBBS, he should be confident and sure that he will go for post-graduation. I personally feel that the seats in the undergraduate post should be parallel. Because today MBBS has lost that kind of place what it used to be in the previous times. So I think any bright student will like to go to, he must look for opportunities. I'm sure, I think now there have been efforts. When I joined Medical Council, I think it was, we had only, 1/3 kind of PG seats. Of course, we try to increase it. Now there are more. But I think it's important for a young, bright person to be careful of the future. The second, I think, is the remuneration issue. And Dr. Sethi is here. I'd like to mention to you, sir, I think you being the head of affairs, in National Board, the resident who do MD or DM, MCS, they get around 85,000, 1 lakh or so. In the government sector, it is fine because they get a accommodation fee, they get no electricity charges, no water charges. In private, somebody has to rent a house. One of our DM resident mentioned, sir, I am paying 25 or 30,000 for my accommodation, which is very small, and the person who is staying above me is a scooter driver. I cannot afford more than, because he is a child. So I think we need to be very, that younger generation, if you have to attract to them, it has to be very attractive. At least they should be getting enough money so they can take care of themselves, and even if some of them have to help their families, they can help them. So I think that is one area we should be sees that they must get at that level also adequate kind of a remuneration. The third issue which I professional feel which is affecting this profession, which has particularly affected the patient-doctor relation also, is the CPA Act. I think probably this is one act, it was in 95 onwards, and if you see the decline in patient-doctor relation has even happened only after that. Every patient now feels, every complication is like a negligence. The young doctor is, he's fearful. He's a little frustrated also. And suppose somebody has to face it, and if the court takes about so much time to decide, even after 20 years he says nothing is wrong, but he has wasted those 20 years. I can quote you example, I think Dr. Behra, I'd like to give you an article that I wrote on this issue, that we should try as a medical community to impress upon the apex court, because this is not by the government. This is not by the parliament only set service. They never mention medicine as part of these services as such. It is the court which has interpreted like that. So I think we need to pursue, because this is one area I think is affecting the medical profession as well as the patient-doctor relation.
Thank you, sir. Thank you very much for elaborating so many points, so many discussions. Next question is to Professor Nagarkar. please can you just think about teachers and training. So quality of quantity trade-off and critical lack of good teachers. What can be done actually in this country?
Thank you very much. When it comes to medical education, actually very rightly mentioned, the very foundation is to have the best teachers. And we've always had great teachers in the medical profession in the past. We all know the stalwarts, so many stalwarts here. But we know that when we talk of bureaucrats, whether they're Indian Administrative Service or Police Service, whenever they'll go, there is still, in spite of the best minds being chosen, they have their 2-year training program and internship, and then only they join the jobs. So I think here, once the people pass out from post-graduation, complete their senior residency, they become medical teachers. But I think now, since the National Medical Commission has made it mandatory, we had been having this National Teacher Training course very well here in PGI Chandigarh. Dr. Devdhar used to lead it, and I think it was one of the finest. Same we had in Jipmar and other centers in the country as well. But now it's become mandatory. So I think this should be the very foundation, even during, I think, PG also, PG training, because the postgraduate training itself, it's part of the teaching. So I think that's very important that we let them understand the fundamentals of basic medical education and medical research, which has been made compulsory now for postgraduates as well, and then during senior residency. So when they become at least assistant professors, they know their definitive job which is there. And yes, because we are expanding our number of UG seats and PG seats, we require quality teachers. Only if we have quality teachers, we'll have the quality students passing out and serving the country and wherever they go to society. So I think that is why this quality teaching, and there should be some extra benefit and remuneration to become a medical teacher. That should always be there. Sir.
Thank you, sir. I think that there should be some sort of regulatory thing, system for judging the quality of medical teaching so that it can get improved over the times.
Sir, just want to ask one thing. How do we fill up the gap in the private sector?
Yes, sir. Now because we have been going for an expansion of the number of seats, definitely we required more medical teachers. You know, the retirement age has been enhanced for the last so many years, from 58 to 60, 62, 65, now even 70. So whoever is fit, we know that the lifespan is more, the active personals which are working with energy efficiency are much more. We will have to tap into them definitely, because it cannot be a mismatch in the numbers otherwise. And anybody who is fit, willing to work, I think we can tap that potential. And there used to be a concept of honoraries in Maharashtra, in Bombay long ago. If that can be introduced back, I think many of the stalwarts here would agree. It used to work very well. So we had some of the finest surgeons and physicians who would otherwise be maybe in the corporate sector and private clinics, but they would definitely give 4 to 6 hours of their prime time to the hospital for taking care of patients and medical teaching.
So in this context, I would like to say that the National Academy of Medical Sciences is running a Professor Emeritus course, and that is also helping in the teaching of the students at various medical colleges and institutions.
Yeah, that can be standard of education, that can give an impact of quality of education so that the younger faculty can follow it. That's sir, please.
So I think the best minds are not going into teaching. They're actually moving to the private. Remuneration, or what they're paid in terms of salary perks, is what the younger generation weighs a lot of things in terms of economics. Somewhere one has to be seeing that how to address this issue about that remuneration should be there. We all keep telling them everything equalizes down the line, but it's very difficult to tell the person who's finished his DM or an MCH in a cardiology, and they would be paid for things which one cannot even think of now. So I think that is one issue which has to be addressed to, I think, once in the post-graduation, catch them and motivate them at that level that to get into it. Because somewhere you have to be there. Plus, the role models for them as teachers are missing. I think that is a very important thing. With the mushrooming of the colleges, the role models are going down, sir.
Thank you, sir. Go to next question. Next discussion is NEET conundrum. So let's talk about NEET. It means there is us in transparency in merit. Yes, we see that the rank of, what is practically seen, the rank of 5 lakh, who is getting rank of 5 lakhs, not getting a seat in government medical college, and where there's a quality looks to be better and affordable. And but look at the condition. Even somebody is getting 5 lakhs getting a seat, and someone getting 30,000 rank in nationwide NEET and not able to get a seat in government medical colleges. Has NEET has sanitized, how to capitalize the capitation fee system. So there is some control. There should be some control. It's not about money. Its merit is important for the nation building. So I believe that is there any transparently unfair system? Is it? I just Professor said, can you have some discussion? Your opinion, please.
Yes, regarding this person with the rank of 5 lakh getting seats because he can afford money, and person of the 30,000 rank because they can't afford money. Now, if you will go to the previous Supreme Court direction, they have already directed the states that there should be 50% of the seats should be available into the open merit. Unfortunately, it's largely the state subjects, and particularly with the state counseling, only one state is following this in the best possible way, is Telangana, which is already spared 50% of seats into open merit, and 50% of that seats goes to the management and the fee-paying seats. Now, here advantage that you release more seats to the open merit, then there will be a good opportunity for the students to take up the these courses, opportunity to take up these courses. Now, if at a national level, if all states will start following the same policy, possibly then there will be a lot of positive impact on this, and this is something need to be done across the country, and it will be very much helpful. They can, money is needed to run the colleges. You cannot, many times it upsets people that seats are selling and buying and all this, but we have to understand that without resources, colleges are not going to run, they'll close. This is the positive side I am telling. There are a lot of negative sides, I don't want to go into it. So what I say that the best balance is release the substantial number of seats for the open merit students, and this should be uniform across the country, and that will possibly control this issue to a more comfortable level than what it is now. Thank you.
Thank you, sir. It's very she has elaborated the things and difficulties, realities. I want to say anything, sir, please.
I think it will take time to standardize the treatment.
Just to add that, sir, I think there was a Supreme Court direction some years back to have a fee structure committee in every state. And the fee structure committee was to regulate the fee in the private colleges. But unfortunately, this was a recommendation. It started in the beginning, but I think now at the moment it's not, no state is following. So I think that's one, I would suppose that direction comes more strongly, may also it will help to regulate the fee structure.
And one more point which we are going to do now is we are going to identify the government colleges across the country which has much better bandwidth of accommodating more UG students. And once we will have our analytics with us, we will urge the state government and motivate them to go up with that UG seats. This will also help the meritorious student to a large extent. Thank you.
Well, next question to Dr. Nagarkar is that need reforms to decrease the overwhelming importance of coaching in academies. Your opinion, sir?
Yeah, need reforms to decrease the overwhelming importance. I think that's the basic idea of most of these entrance exams, that it should not be only such bias such that the training is such that only coaching centers which are churning out these kind of students. It's national eligibility come entrance test. So here the basic knowledge, the original knowledge of the students in the college, in the 11th and 12th, everything should have an importance. It's not just that it's focused towards, those MCQ type of tests, churning out and, which has happened in the past because of the mushrooming of these coaching centers for cracking any of the entrance exams, not just for medical, it was engineering and others as well. So I think those reforms where we can actually include, the marks or in some way or the performance of the previous tests that the student has performed, all that should be taken into consideration, not just the MCQ pattern of tests. It should include the clinical aspects, the clinical based scenarios, the previous performances. I think all should be taken into consideration.
Thank you, sir. Let us discuss the students' experience. Actually, for that, students developing stresses, curriculum problems, and commercialization of this coaching. And this journey of medical states now begins with a coaching factory that Asari discussed, and how high stakes entrance examination culture impacted the quality and mindset students entering the medical college. I have seen, and our institution also, after taking coaching 2-3 times coming, they are unable to write in exam. Sir, I am unable to write the exam, complete the exam, because I am so much of trained in coaching center, so much of stressed out, so much of once coming, they are not interested to read medical college, they are not interested in first year, even they drop out, even once for 100 rank student, 146 rank student, not able to clear 3 years first professional examination. I have personally discussed, and there are these issues actually. These are coaching system. They are unable to do it. I think that's an important area to discuss. I want to say something, Professor.
Sir, if we talk of the student stress experience coming into the first year, I think decreasing the period of first year from 18 adds to the stress of the student. Coming into a new environment, new set of subjects, new terminology, settling down, coming from home, 2 terminal examinations, 1 professional examination, 1 year is practically 9 months. Anatomy, physiology, biochemistry, you're trying to teach him things as you were before, even though we talk of competency based. It's the most difficult. We should be at least be looking at 13-15 months, give him time to settle. I've seen people going to IIT the first month, they're actually trying to get into things that, what are your hobbies, develop your hobbies, social clubs, settle down. In a week, it's just 20-25 hours of studies, and that's how things are. But here, you start and you're just bombarded from in the first year. Sir, we have to look at it somewhere about the stress aspect of it. The first prof is the most difficult. You fail, you go a year back. So I think that's something which, from the medical education point of view, we have to be really looking at, sir.
Sir, I think I still remember that you talked about the IIT. In the first year of the IIT, they again teach the basic subjects of physics, chemistry, and maths in reference to their further studies. So that's a very good question, and I think needs to be considered. And the next question is, has the pursuit of PG NEET devalued the crucial internship year? Is it is an internship a redundant, or is it a waste of time?
Yes, sir. So Dr. Bhaskar. This is actually old discussion, but I think this need to be further.
Sir, as mentioned by Professor Mishra, regarding stress, I think a very important aspect to be taken into consideration, that we are more focused on the exam-centric learning now. Because maybe the professional exam, maybe the PG entrance exam, as sir was mentioning, the first prof, the student start preparing for the post-graduation. They're not focused on the subject, primary subject they have to understand and learn. So their time is divided between the basic subject to be learned and they start preparing for the post-graduation. Now, when they don't have time for the basic, they get stressed during their professional exam. And we are seeing so many burnout, suicides among students because of all these reasons. So that has also to be looked into, and fortunately, I think the chair of NMC is there. So this is that we are not considering MBBS performance into PG selection at all, which were earlier a consideration in some of the states. I very well remember in the Gujarat state, there was certain weightage to the MBBS exam marks. And then it was the PG entrance exam. So MBBS was also taken seriously. Now they're not studying, they're only practicing multiple choice questions. Their focus different. That is the main cause of stress among the students.
Sir, I agree also. Nowadays, not only that coaching, it also there is some online coaching like Mero and so many things has come up. Now they're basically grabbing parents and students, and it means come for a good seat in PG to look at your future. Even yesterday I got a message that for that. These things are continuing. I mean,
Sir, I think the question should be reframed. It's not NEET PG internship. It's about the entire undergraduate curriculum with the NEET PG, because they're not going to their classes.
Yes, sir. That's very important, sir.
So one thing I want to say that during internship, it was, the first chapter of clinical, teaching in the hospital, bedside hospital, which is almost vanished. No, nobody is going to the wards and going to seeing the patients, and they are all the time preparing for their PGs, and they lack any clinical sense. I don't know what type of doctors we are preparing.
Sir, another area is, I think, 3 of directors are sitting up, 4 directors are sitting here. So I think there is a lot of discussion in ministry, and I mean, Niti Ayog, sir, can say something, Dr. Nagarkar can say something. I mean, sir, regarding the issue of family medicine, where practically all aims are ready with the starting of family medicine. I mean, sir, it's need of the hour, I believe that.
Yes, Dr. Mahapatra, sir, I think you rightly mentioned, even I was part of the committee, and many a times we had discussions. We know that MBBS doctors, when they passed out, would become general practitioners in case they didn't go to post-graduation. We also know that in so many countries, seeing the models in UK, for example, to even become a general practitioner, you have to go through the 3-year rotation through different clinical departments. The same thing is true for family medicine in the US. We looked into all those models. We realized that in India in the past, after doing an MBBS, it was okay to become a GP. But with the changing scenario, so many demands, so many expansion of clinical specialties, trauma, a proper rotation for 36 months going to trauma, pediatrics, ENT, general surgery, general medicine, everywhere, plus community posting, all that can be done, and a formal degree of post-graduation, MD and family medicine. Like everybody mentioned, even the student wants to go for a PG degree. So if there is a MD in family medicine, they'll be much more better trained, will be able to serve the society, and that big gap which is there can be filled up.
Yes, sir, there's a big gap. Sir, Professor Talwar, you want to say something?
See, as far as the common actually when the NEET was notified in 2012, we were there. I think Ashok is sitting here. I mean, we knew about its limitation, but that time was because to prevent irregular way of admission, this was the only way to go for the NEET. But we knew that NEET will need reforms, and actually the internship area, we all know that this is being totally now people are preparing, and it's not their fault. It's because you are made like that, they have to appear for getting into the PG. So I think the common exit examination, and then Oxate is here, this is probably also, I'm told that in NMC mandate, that it should be run. I personally feel that maybe the final examination, the question is, the degrees are given by the universities, and we have all kind of universities. When we now talk about giving a BTS to MBBS examination, the difficulty is which university is what kind of standard. So you have to have, there's no uniformity, and I think people can be given very high score in some universities which may affect other even which are good students. So I think a common exit examination, I'm using this opportunity because Dr. Seth is here, that maybe after final year when this university declares that okay, you are passed, before internship, there should be a common all India entrance kind of thing, covering the topics total. And the question of is also what kind of questions are asked. You see, if you appear for these American boards and all that, all kind of clinical questions. So I think the question also matter, what kind of question are framed, but a common kind of thing before starting internship. Those who have passed the universities, maybe a month or so a gap, and then they should be appearing for this so that internship period is protected.
Sir.
That is the only time when you learn clinical skills.
Sir, we're coming to next.
So just one comment. So when we talk of the NEET PG, sir, we've got teachers in the medical institutions, people who teach for the marrow, etc., those courses. They're also doctors who are taking. You said the cream and the best goes to the medical institutions. You are still stuck teaching in that traditional way. Teach them, have your MCQs, let the students practice, teach them afterwards at the end that why this question, why this has to be answered. There's enough flexibility in the curriculum to go about do it. So if you have your in-house teachers talking to them about it, this system of actually going into the coaching, etc., will decrease. Definitely it will make some impact, I feel.
I think it's a very important question in continuation. Professor said, can you say something regarding next, what Professor Toller told, that means that's continuation that.
Yeah, next is without any doubt is a novel concept. Why it couldn't develop to the degree of implementation and execution, there are many reasons. The first important is there are lot of unanswered questions around next. And what has happened that when the central body decides any exam to bring the uniformity at the central level, it won't be possible unless there is a consensus from the stakeholders. And who are the stakeholders? Stakeholders are state universities, institutions, faculties and students. If there are not a built-up consensus with all of them, it becomes a very difficult to float this model on the national level to bring the uniform standard. So that's number one issue. Number two issue when it comes to the students. Now, we need to need to increase the confidence level to the students that next exam is not an additional burden for the students, which at the moment the student communities and even the associations are feeling that this is going to be much more complex and it is going to increase the additional burden on students. I think here we need to ensure that we need to increase the confidence level and perception with the students is whenever the next model will come, the next model will be coming for their benefit only, and in fact it should be better than current NEET PG exam, and it should be better than NEET PG exam in terms of compatibility, and at the same time our primary intention is to enhance the quality of the assessment system. At the same time, the acceptability is very, very important. So there are many points which we still need to resolve it at policy level before we finalize our model to the implementation and execution. The expert part has been done, but the acceptance part and the compatibility part to the stakeholders is yet to be achieved, and unless we achieve these stakeholders' acceptance, it's not going to be that easy to float next exam immediately. That's why during my recent conversation with the Student Association, I said that yes, we need next, but we need it a better examination system than what it is now at the national level. And second, we want to ensure that the exam serves the purpose of its assessment and the purpose of bringing the uniformity and quality. Thank you.
The last question before concluding, I just want to know, looking beyond the challenges, what is the one positive development in the last 5 years that gives you the most hope of the future of the medical education in India?
I think, before that I would like to comment on the previous question. One is that only the internship has not become redundant. In fact, whole MBBS has become redundant. It is a gateway to PG. You're just passing MBBS to become a postgraduate. There is no other meaning. If you would have given you post-graduation by any other means, you would have gone for it, left the MBBS. So MBBS has become so redundant that it is just a gateway. So we need to make it more learning rather than for going towards MBBS, to post-graduation. That's very important. And I think the best thing which has happened in the last 5 years is probably the new curriculum which has come. That's the best thing has happened. Otherwise, if you talk of entrance exams and all that, that has almost remained same. Nothing has changed.
I agree that the competency-based medical education, whether for UG or PG, establishing the basic minimum standards, because they will be treating patients. It's a question of life and death. So I think here we require some very basic competencies by everybody who is in this profession. I think that's very, very important to follow.
So thank you very much for...
Thank you.
Thank you very much,
sir. NAMS is a family, so today we have Dr. Varshney with us, and it is his birthday. So let's all wish him a very happy birthday. I request the moderators to Dr. Ashok Sharma and Dr. Mahapatra to kindly felicitate the panelists. Dr. Abhijat Sheth, President NBE and Chairperson of NMC. Dr. K.K. Talwar, former Director PGI and former President of NAMS. Dr. Saurav Varshney, Director AIMS Deoghar. Dr. Sanjeev Mishra, Vice Chancellor of Atal Bihari Vajpayee Medical University, Lucknow. Dr. G.P. Thami, Director Principal Government Medical College, Chandigarh. And Dr. Nitin, Pro VC, SRM Institute of Science and Technology, Chennai. Now I request Dr. Digambar Behra, President NAMS, to kindly come up on stage and felicitate the moderators. Dr. Ashok Sharma, Dr. Mahapatra, he is the Dean of AIMS, Bhubaneswar, and Dr. Ashok Sharma, he is the Council Member of NAMS. Thank you everyone for this very exciting panel discussion. Now we move on to the next one, the next panel discussion, which is on biomedical research in India. For this, we have 4 moderators. Dr. Y.K. Chawla, former Director, PGI Chandigarh. Dr. O.P. Kharbanda, NAMS Council Member. Dr. Amita Jain, NAMS Council Member. And Dr. Saroj Churamani, former President of NAMS. I request all these members to kindly come up on stage. The panelists are Dr. V.M. Katosh, former Director General ICMR, Dr. Kar, Director of AIMS Darbhanga, Dr. Ashutosh Biswas, Director AIMS Bhubaneswar, Dr. Rajeshwar Dayal, Senior Fellow and former Vice President of NAMS, Dr. Y.K. Gupta, NAMS Council Member, Dr. Smita Patnaik, Professor, Department of Pharmacology, PGI Chandigarh, and Dr. Ashok Kumar, Professor Director, IIT Kanpur. I request all the panelists to also come up on stage and kindly take their seats. My introductions for the moderators. Dr. Y.K. Chawla, he is a Padam Shri awardee and a fellow of the NAMS. He is the former director of PGI Chandigarh. He is the recipient of the Bloomberg Oration on Hepatitis B Eradication by Kalinga GE Foundation, Cuttack. He is a BC Roy awardee by Medical Council of India. He is a Silver Jubilee Research Award awardee 1999 for research in the field of hepatology. ICMR Awards recipient of MNS Sen Oration Award and Amrut Modi Unichem Award, Park Davis Oration Award, Olympus J. Mitra Award, Pfizer Amir Chand Trophy, and Fellow of the American College of Gastroenterology. Dr. O.P. Kharbanda, he is the NAMS Council Member, and he is the Pro Vice Chancellor Health Sciences, Ramaiah University of Applied Sciences. He is the Fellow of the Indian Society of Dental Research and International Association of Dental Research, Indian Division. He is the Fellow of the International College of Dentists. Dr. Amita Jain, she is the Executive Director, AIMS, Rai Bareli, Fellow of the Royal College of Pathologists, former Head of the Department Microbiology, KJMU, Lucknow, a member of the National TB Expert Group and Subject Expert Committee on Antimicrobials of the Ministry of Health and Family Welfare, Government of India, former President of the UP chapter of IAPM. She has edited 2 books, contributed many chapters and reviews, and co-authored many papers. She has contributed to 1,300 unique nucleotide sequences relating to viruses, bacteria, fungi, including 266 from other taxa. She holds 3 patents for viral diagnostic kits and has filed other patent applications. Dr. Saroj, the former president of NAMS, she is a Padam Shri awardee 2013 for her contributions to the fields of medicine and medical education. She is the first woman to get an MCH in the pediatric surgery in India. She worked in BHU for 35 years and retired as its dean. She is and she's also the former vice chancellor of the King George's Medical University, Lucknow, and she is the first woman to head that university. She is credited with many low-cost innovations intended to benefit the financially compromised people. NRDC issued 6 patents for her innovations. She invented new surgical techniques and published the details of 3. And at the age of 79, she continues her pioneering journey, now pursuing a PhD at IIT Kanpur, researching the regeneration of damaged spinal nerves using stem cells from bone marrow or abdominal lining. And she is definitely a mentor of all mentors. Thank you. Over to Dr. Chawla.
Good morning, everyone. We have a very interesting panel discussion on biomedical research in India. We know that biomedical research has increased significantly over the last few years, but there have been some bottlenecks of which we are going to discuss on. But some of them which I need to emphasize right in the beginning is the amount of money given of the GDP is just about 0.6 to 0.7% as compared to what you have in the West of 5 to 7%. So we are much below that, and that may be one of the reasons why research hasn't picked up. Second is we also do a lot of unfocused research. That needs to be corrected, but as part of the panel we'll discuss that aspect also. And third, what I think is most important is the bureaucratic hurdles that our students and our teachers tend to have while they write up the research projects. We have a few questions which have been lined up, and I would request the first question goes to Dr. Katoch. We haven't had those questions. Dr. Katoch, it's often said that research environment in the country is not at par with Western world, mainly due to limited resources, including research funding. Do you think this is the main reason for brain drain?
Professor Chawla, I think I totally disagree with that comment actually. See, as an administrator at some stage, and for at least so many years, I thought, by increasing the money, even creating the units in medical college will work. I tell you, both don't hold true actually. Money has increased, it's not enough, but as you talk of the West, actually compare those percentages. But the innovation is not anyway hampered. There is enough money for the innovation in the good medical institutions like AIMS, PGI, all other institutions, other biomedical institutions, enough money. And that has increased tenfold in 10 years actually, not 1-2-fold. But the main limitation appears to be the people who are ready to do work actually. We wanted to rebuild the medical colleges, and I spent my entire 2 tenures on that only. Even the units which were to be created in the units which were sanctioned 2013, only 50% I did in 2 years itself, and another 50% have come in next 10 years actually. There are no takers in the medical colleges who want to take up the work actually. And wherever the money has gone, nearly 60% of them have not delivered actually. The money for 1 year they spend in 10 years actually. So that is, the systems are so apathetic and the competence is so much lacking. And if the academy wants to take something to help that up, is basically to, let's say, create these research methodology trainings for the medical teachers in the periphery. Because that influences not only the postgraduate training in those institutions, that improves the quality care. Why PGI AIMS is better than the others? It is your research only, because you are thinking every day. Your technologies improve, your patient care improves. This is due to research only. And I think that part, till that happens, the country will remain shambles. The 780 becomes 7,000 also, the story will be the same. Money is not the factor. So I conclude that money has not been the factor. It is the competence in the state systems, and also there are managerial systems. That's the 2 things lacking there. No push, except for one state of Tamil Nadu, where from the day one I found that they dedicatedly their structure monitors, sees the deliverance. No other state has taken that as a policy actually. Assam does to some extent, Tripura does to some extent, the rest are all the individual excellences. No other state, and partially the Kerala also does. So rest are all individual.
We agree on that aspect, but there are multiple factors which hinders the research progress. To my mind, funding was important. You look at the US and UK, the private companies tend to give a lot of money, but in India it's basically the public sector.
There are no people to work. I tell you, that's the point.
That's a very important factor.
I think taking it forward, I think these 2 questions seems to be related to the next panelist, Dr. Madhavan, and the reason why we don't get good research proposal for funding. So I think these questions are interlinked. People don't want to work, money is there, but there are also no good proposal. So probably you have to tell us why good proposals do not come.
Thank you so much. This is a good thing. What Professor Katoch told, that this money is not a cause. But I will answer in different perspective. This is like a multifactorial, as Professor Chawla told. One is I will take in the institutional, then personal, then students, and the system. When we are going to the institutional and educational system, first thing we have to accept that our medical education not innovative. This is not an educational system, is not innovative. We are like last session we are discussing this, we are pushing everything. We are not giving the independence or freedom to students to think. The second thing, all the institutions, they don't have an ecosystem, research ecosystem. What we are, over the years, we are pushing it like that. This is the system, this is the education, we are going like that. There is not giving much importance to the research. We are always service oriented, and this is a mindset, what we were discussing before, that is we are money oriented. Our education, we should have the super specialty training, we should go earn money. Third thing is, this is the person-based, this is the leadership. What I think this is, Professor Carter told, leadership is the most important one factor which can develop all these things. So what I am telling that, this is someone is a good student, is the research, someone who is not having the networking, someone who is the family, they are already known, their students, they are going in that direction. Suppose someone coming from the village, someone don't know first time the medical education system, they don't know how he will do the research, who will pull that to the research environment, and how they will support it. All these things are there. And second, the leadership, how it is effective, he has to pull out the best out of the system. They have to encourage, like I am giving an example, one department, everyone cannot be a good surgeon. One can be a good surgeon, one can be a good writer, one can be a good innovator, but as a department, how they are growing. No, that's why always telling that the personal talent cannot make the championship. Personal talent make a match winning, but the team will do the championship. That's why our educational system is not a champion in the research, because we are giving importance to individual. I am a good researcher, I will get the reward, everything like the Stanford things, everything, but what my department is doing, what my institution is doing, not thinking that line. That way the leadership carries the meaning. Third thing, all the projects what we are doing, the research, taking as a project, we are putting for 1 year, 2 year, there is no programming. Anything we start, take it as a program. Even this is system based, not like one student left, that project stopped, one faculty left, that project stopped, that research stopped. That way, that programming system is not there. We are based only project based. Good student, he will write good paper, good project, then that is stopped. That is not carry forward. These are the multiple factors. And second point, what you are telling, that how will address. In my view, first thing, choose a good leader. Or if the leadership training should be given, like I was telling institutions, how I telling, this is first, like in medical college, assistant professor, first I am focusing the teacher, assistant professor, give full time to the clinicals. She should know what is the problem best we are facing. When he becomes the associate professor, 20% he have to give to the research and rest, and there it is having the personal growth. When he becomes the additional professor, it should be 50-50, 50% to the institute, 50% to year. And when he becomes the professor, 20-80, means 80% he has to give to the institution, means education, research, promoting their juniors. When we are becoming professors, actually feel, see, this is not hurting anyone. We are focusing, still we are, as individuals, we are not living behind our own things. We are not giving importance to the departmental development or institution development. That's why that is the trainings of the trainers, means the teachers. Second, the students, we should give remuneration, support system and ecosystem, how they can do simultaneous teaching, simultaneous research. Like a few institutions, I will tell that Professor Mishra was telling me Jodhpur, MD PhD program. That's why we should do like the joint PhD program. Many institutions are starting. We are always talking about the West. But always not that the West is doing the best. We are having many innovations which we are undermining every time. Not like this, when we were doing this, I am actually sharing my experience when I was doing the residency in NAMS Delhi. When I would go to project paper, the fellow told that surgeon who had to do the research. Means surgeon cannot do the research, only cutting it. Like this is the mindset that you're telling, but yes, it is changing. That's why we have to train the teachers how to develop the system in the medical colleges. Thank you.
So, thank you. taking it forward from here, my question is to Dr. Y.K. Gupta, sir. Sir, we have often said, as Dr. Katoj said, that there is no funding scarcity. Dr. Carr said that we need to motivate and promote research in teachers and students. But still we see there are some publications and patents which come out of the medical sciences. When we look at the engineering sciences, there are a lot of products which are the byproducts of the research they do. However, we find this is missing in medical sciences. We see patents, we see publications coming, but products are very few. Like we are talking these days of Make in India and things like that. At the same time, Indian Council of Medical Research has started a portal which I think is a good move called Patent Mitra. So my questions to you are, sir, two, that what it takes to translate our patents into product, one, and number two, do you think Patent Mitra is the answer for all this?
I think it's an excellently framed question. I must compliment that. And I have a solution for funding, making research relevant and contemporary, which is often ignored, particularly at All India Institute of Medical Sciences and National Institute of Importance, which is very much present in IITs, is industry-academia collaboration. Effective industry-academia collaboration, we have been talking for many, many years, and I was member of high-power shared committee, which was chaired by Pankaj Patel, which was co-chaired by the Secretary Pharmaceuticals, and also DHR secretary was also there. The important thing is, if our research becomes relevant to the nation, if it supports the pharmaceutical industry, which is in turn is need of the country's healthcare system, if we talk to the pharmaceutical, if you talk to the startups, device makers, which is the need of the medical profession, in collaboration with IIT, and then we craft our research proposal that will be relevant, and that will also be subsidized, funded by the industry and other parts of that. That is what important thing is, which is missing. Today, leadership in AIMS also, directors, deans and research deans are not aware of the funding mechanism, governing mechanism, and they are shy, I am very frankly admitting, they are shy of having industry-academia collaboration. I think this must go now. Industry looks for reproducibility, industry looks for relevance, and industry looks for timely delivery of the research and confidentiality. That's why important things are, to make it relevant happening, we must teach, train, and educate and enforce the concept of good clinical practice, the concept of good manufacturing practice, concept of good laboratory practice, and good documentation and archiving practice. And that is what is missing today. The important thing is, we as an academicians, we look for what is the impact factor he is publishing in. Gone are the days where the only impact factor is important. It is reproducibility factor which makes the country's stake. If your data is not reproducible, neither the industry will take it, nor the international community will take it, and that's why reproducibility becomes a challenge, and this has been a challenge for India. If a data is not reproducible, it is a blot not on the scientist, it is a blot on the institution, and it becomes blot on the country, and the reputation of this goes down. And therefore, instead of impact factor, emphasis should be on reproducibility factor. Lastly, I would say, in short, that we must take, whether the Dr. Katoj or any policy makers, and I appreciate what he did, lot of things. We must teach the teachers and the researchers how to do go, no go decision. We get married to our projects or the research concept which we borrowed from our teacher, and he borrowed from his teacher in US. Lost relevance now. And therefore, it is important to painfully divorce the idea which is not productive, irrelevant to India. Work for relevance to India, and that is why important thing. I much appreciate what Dr. Katosh has taken several steps. Don't work for the project, fancy projects, which publishes high impact factor, but no impact on the country's need. I think that is what change in the dynamics of research has to be done. And that can only happen when the leadership sitting here will look into out-of-box thinking process.
Any comment about Patent Mitra?
I was part of framing the Patent Mitra. The issue is that there are two important things. That the pharmaceuticals or say IITs, people working on devices or delivery systems in isolation. The medical institutions, professors, they work in isolation. But when there is a marriage, that has to be a marriage between, and therefore we started in AIMS and I promoted, and in fact, so there is a marriage between IITs and AIMS. That is one. The second thing is, they start working without knowing three important things are important. One is you do future forecasting of what is happening to that. Number two, how we are going to position your product, market competitiveness. Now, number three, you must know what are the valley of death in your product. And valley of death, one of the important reasons is to do not know what is the regulatory process, what will be the regulatory hurdles which you have to do it. And once you do that, अरे यार ये तो हमने किया ही नहीं, ये तो डॉक्यूमेंट हमने इस तरह लिखा ही नहीं, ये तो हमने सेफ्टी असेसमेंट करा ही नहीं, अरे यार ये करने से पहले अगर आपने रेगुलेटर को इन्वॉल्व किया होता तो आई थिंक योर 50% ऑफ द एफर्ट वुड हैव बीन सेव्ड. एंड दैट्स व्हाई आई सेड इसको रेगुलेटर्स को राइट फ्रॉम द बिगिनिंग इन्वॉल्व करो. एंड दैट इज व्हाट द कंसेप्ट ऑफ, ये तो हमने फैंसी नाम दे दिया, मित्र, नॉट मित्रा, इट इज मित्र. मित्र मीन्स फ्रेंड, रामा इज राम. So mitra means simple thing is medical technology का मित्र है जो कि आपको कैसे forecasting कैसे करनी है, market competitiveness कैसे करनी है, उसकी regulatory requirements क्या होगी, उसको कैसे meet करो. और इसके लिए not only those projects which are funded by ICMR, anybody who is likely to face regulatory problems, and we have also created a consortium, independent consortium with retired regulators and couple of our experienced colleagues who can provide them help at any stage. You can approach us through our academy, and we will be able to help to what we can do to support what could be the regulatory hurdles which one can face, so that you are prepared for doing that, and that is something very critical.
I think we are embarking upon research and innovations industry, and in that relationship, I would like to ask Professor Ashok Kumar, who is a biomedical scientist of renowned status in the country, with international collaborations. He is a man who is having 45 patents in pipeline, 36 of them already granted. With that kind of a great experience, I would like to put forward to you two questions. India has been a global supplier of generic medicines and vaccines. We have the horizon of Viksit Bharat by 2047. How would you like to elaborate how can we achieve the target of Viksit Bharat with a conglomeration of clinicians and biomedical research scientists?
Thank you, madam. So I think I'm the only engineer here, perhaps. So obviously, my opinions may be somewhat different actually than what the opinions actually from the clinical side will be, but maybe they will still have a relevance actually. So in fact, Professor Y.K. Gupta already put the message actually which I wanted to emphasize here, is when the engineers, medical scientists and clinicians will work together. I think that is the change actually which will revolutionize actually our, medtech, our innovations in healthcare actually in India. So this is the mantra I should completely tell, mainly based on my experience actually of 35 years. Out of that 15 years actually in the countries actually where this has already been practiced, and last 20 years in IIT Kanpur actually. Yeah. So the steps actually what has been taken up actually, what the madam mentioned about, we are obviously, the landscape is changing obviously of our healthcare. So we are moving a bit from being just drug-centric to the innovation, technology-oriented medical device, things which is also in line actually with our Viksit Bharat, mission 2047 actually, and it's in alignment of that actually. So you may do some re-engineering of some things actually, but it's not a drug actually which you can take generic all the time actually and can produce a large actually and export that. But medical device sector actually technologies are somewhat different completely in that context actually, which needs innovation actually. So which needs from the very beginning actually the things which takes it from the initial phase until the end phase actually, if we have to have a sort of self-reliance actually. So we cannot just be depending actually and only just looking on the technologies actually and re-engineer them and produce them actually in the country actually. But it is very obvious this is not something actually which just the clinicians can do alone, or which can be done actually by the medical scientists or the simply the engineers. I think it is from the very beginning actually, and when I said actually it is my personal experience, many of my technologies I brought to the level, where the opinions from the clinician was taken in that phase, where we had traveled a long way, okay, and then the clinicians at that phase, this is not the way it should be done. Perhaps I should have done actually in this way, okay. It lost a long period of time actually, same clinicians I requested, can you come forward from the very beginning actually, let us now start a new story or something like that. So that is a sort of challenge still, what I should say actually from Indian perspective point of view actually. I have been working 10 years actually only with the doctors when I was in Sweden, in Europe actually. Just as biomedical center, all of you must be aware about actually every university hospital worldwide will have a biomedical center. Even these are very much, you talk about actually I'm going to a biomedical center actually, it is easy to go to the biomedical center actually because everyone has a uniform thing. Where you have the doctors, where you have actually the scientists, where you have the engineers working together actually. At least somebody has recognized this thing actually in our country here, okay. That's the reason actually IITs are coming up actually with the medical schools actually. IIT Kanpur is coming up actually with the medical school. So if maybe the doctors don't invite us, we will invite doctors to our place actually. So that's what we think. But many doctors think actually that engineers should come to them actually, Another thing I tell you actually is doctors, of course, in the society, but in the hearts of the engineers actually are having a very, very high value. But I sometimes see that is not the case actually, vice versa. Okay, engineers perhaps doesn't have that type of actually importance in the eyes of the doctors actually, but they are important. I understand actually from my point of view actually, because they are so critical actually for our growth. Okay, so I think these are things actually where if we feel actually that it can be taken together actually, money is not a problem today. Absolutely, money is not a problem. At least, many people are not able to know actually how to spend the money. Okay, we are absolutely, our innovations and our technologies are really, really high end actually. So we don't have any dearth. It may not be well separate all over the country actually, but yes, the institutions which are doing actually, they are doing the best. But I think it is my request that actually how the medical researchers come forward and can take these things actually. Thank you so much.
I would like to have another question answered from you. India has a huge pool of biomedical scientists and engineers, and yet most hospitals do not integrate them into clinical research. How can India adopt global models like in hospital translational labs or clinician engineering co-innovation teams? Would you like to highlight that?
very simple formula for that actually. Have biomedical labs, have translation labs actually in all the premier institutions, medical institutions. We have all the leadership of new aims and all. So this is the time actually for all of them actually to do that. Okay, we started at IIT Kanpur actually very late bio. And you cannot believe actually that bio, which is just only 25-year-old at IIT Kanpur, we are coming up with a medical school. So we have to take the challenges, of course, actually. Maybe this is a challenge actually if I say just set up a laboratory actually by your OT and bring the technology of the engineering there. But maybe this is a challenge today actually, but that is what actually the, people all over the world does actually. I think in hospital translation labs is the critical factor actually how this can be done. Thank you very much.
Madam, can I comment one thing here?
Dr. Kar, I think we can take it up later because the time is running short.
We are running out of time, so
Yeah.
I request the panelists to please be brief.
Yeah.
So can we have the next question, please?
Yeah, the next question is to Dr. Ashutosh Biswas. What do you feel about the reasons for not getting good quality publications from India on operational interventional research in the field of biomedical research? Do you think providing article publication charges for publication may help?
Thank you, sir. It's a very important, I think, questions for us. For good quality publications, I think we need to have a good quality of research first. What we are going to publish, it has to be a good quality research. Now, for publishing this research, if it's not good, probably we cannot. But if publishing charges, now most of the journals are charging their publication fees, and I don't think that is a very important point that coming in between and hindering our publication process. We should look into that, why the good quality of the research is not taking place. And I was looking into this, and after this, now taking over the charges of last 3 years in NAMS Bhubaneswar, we had a third annual day research yesterday, and DG ICMR, Dr. Bail was there with me yesterday, and we celebrated that our research annual day. So we discussed about the same thing, what is happening in the national level, India, and all, why the fund is not being given to all, and probably India versus international and national, the fund crunch and the fund limitation is a problem, is an important factor coming in hindering these publications and all research quality. But I think we're looking, who are these people, those who can bring a revolutionary change in the research domain. I was looking for who is these guys, who is those scientists. Now in India, the 780 medical colleges, are everyone, they are really interested for research? I was looking for what percentage of these medical healthcare workers, or including the nursing and faculties and all, are they really interested? Actually, they are not interested. Very few, 2 or 3%. Assistant professor, they do for their personal interest, because I need 3 papers to go into the next level of associate professor. After associate professor, I need 3-4 papers for promotion. And when I became professor, 90% of the publication or project is dropped. No professor, Dr. Madhavan said that 80% professors should look for research only, and they should devote all the time. I say 90% of the professors they don't do, they can just help them their project and everything done. So we are interested for only personal interest. Nobody is doing research for the country or for the sake of the research. That is very true. I think everybody will accept it. And I was looking for how many really scientists are there in our INI or AIMS that really they are meant for doing research. Hardly no sanction post for medical scientists. Only names, really few, and no aims, new aims, there are no sanction posts for medical scientists to do. Only we engage the scientists through the project. And who is writing this project? Again, for personal interest, any assistant professor, associate professor and this. So how we could really bring a revolutionary change in the research domain is a very questionable. And funding then, question is also qualified. the faculty members, whether you are really sound enough to understand the epidemiology or research statistic. Hardly 10 to 15% of the faculty members, they understand really very strong knowledge about this research. So if they don't have, how we can really expect from them a very strong research proposal and submission. That's the reason probably is 80% rejection or 90% rejection in funding agencies. And funding agency, how they will give, unless there is any translational value of the research, how it is going to help in terms of prevention, control, public health policy to bring changes, or therapeutic any intervention, new things, and a product, finally a finished product that you are looking for. So definitely whether doctors will invite engineers or engineer will invite the doctors, point is doctors and engineers should together to have a innovation now. It is a time to sit together. So then only we can come. A product is a technology based. Now our development is fully technology, MRI technology. New generations of everything is a technology, is a machine. So machine learning is not the job of the medical scientist or medical, it's the engineers. So we have to have now innovation through this, sitting together, then only you can bring a change, revolution change in the medicine, the practice of medicine. Thank you very much.
So I think we are running out of time, and we have two very, very illustrious speakers left, panelists. So I have a joint question to two of you. Dr. Rajeshwar would probably like to talk about multi-centric versus single-centric studies. So what are the advantages and disadvantages? Sir, please be very brief. And I will not pitch in between. My next question will be to Dr. Smita. So there's a lot said about the regulatory bodies by Dr. Y.K. Gupta, sir. And so when he finishes, you will understand that your question is that why we do not have multi-centric trials. What is the role of regulatory bodies over here? So that you will be doing why, and he'll be talking about the advantages. So thank you, ladies and gentlemen.
Thank you, ma'am. First of all, I'd like to thank Professor Behera for inviting me to this prestigious meeting. Thank you, sir, and giving me a platform with my mentor, Dr. Katoch, to talk about, very briefly, about multicentric research. Alexander Graham Bell said that great discoveries and improvements invariably involve the cooperation of many minds. So what is multicentric research? It's a research study conducted simultaneously at multiple sites or institutions following a common protocol, methodology, and objectives, and each center collects the data independently, but all results are combined and analyzed together. There are two types of them. One is a collaborative research, which is based on researchers who frequently interact with one another and conducted at small sites, and the other is a large-scale research. Now, designing a multicentric study is the most important part of the whole thing. And it involves the research question, the population generalizability, the timeline, the resources involved, the coordination, the funder requirements, and of course, maximizing the success involves careful site and investigator selection, clear protocols and SOPs, central coordination and governance, uniform training programs, contingency planning, and monitoring, and so on. Now, coming to the question which was put to me about the fact of multicentric research over single center research. Now, I thought it best if we could highlight it through a slide. Now, these are the advantages and these are the disadvantages of multicentric research. The advantages that you have attractive research when it captures population diversity. Disadvantage-wise, it could have a complex study design. Collaboration, ability to with diverse clinical expertise, collaborative decision-making, institutions and processes, capacity building. The disadvantages and challenges to coordinate with multiple investigators. We had a project with Johns Hopkins, and we ran into ego problems with the multiple site investigators, and it almost collapsed the study. Implementation limits the ad hoc and unstructured implementation, enables simultaneous implementation. Disadvantage, protocol adherence. Now, the advantages of multicentric research are actually the disadvantages of the single center research. Continuing with it, very briefly again, the sample size, you have quicker recruitment in the multicentric research, better external validity and generalizability, The data management, there is less data manipulation in fishing. It may be cost effective for the time needed to answer each research question. So these are, as I was directed to be super short, the advantages of multicentric research, which turn out to be the disadvantages of single-center research. Continuing with what Dr. Madam Chudamani said, the marriage with basic and clinical scientists. Do we make the best of both the worlds? And biomedical research actually investigates diseases to develop new ways to prevent, diagnose, and treat them in humans and animals, which is the One Health concept. And that is where biomedical research encompasses basic research, applied research, and clinical research. For that, multicentric studies unite the basic and clinical scientists in biomedical research, transforming the laboratory discoveries into clinically validated outcomes across diverse populations, thus creating more opportunities for basic and clinical scientists to work together and help to bridge the gap between these disciplines and foster a more integrated research. To conclude, multicentric studies have a higher potential for clinical practice, program, and policy translation. Careful study design is required, appropriate site and investigators selection, and rigorous protocol adherence. And the future of biomedical research lies in the seamless integration of biomedical and clinical science. Thank you so much. I don't think I could have been shorter.
Thank you, sir, and that was really enlightening. I truly agree that multicentric studies are the future, and the regulatory compliances have to be met, as already been alluded by YK, sir. So the regulatory, of course, any innovation would need to be validated in several centers, and therefore it has, and the importance cannot be more emphasized here. And sitting in here with the luminaries who have who are seasoned researchers, and they have seasoned administrators as well. I am a mid-level researcher, I would say. I have still got 20 more years in research, I would believe, before I retire. So here I would like to emphasize, in the context of biomedical research, I would like to say that we have discussed how to integrate the engineering and the medicine, how to integrate the industry and the academia. Two things I would like to say here is the biomedical research scenario in India is perhaps changing, and changing for the betterment. We definitely see a better future. As I said, I have 20 more years to do research. I definitely see a brighter future. Having said that, I would try to put 2 points in here, where perhaps we have to relook the way we evaluate an academic researcher. One is the number of publications and the H-index. Many funding agencies say that, okay, you have to have a H-index of 20 before you can be considered for a research proposal funding, which to my mind is maybe not appropriate, because that's not the matrix we judge innovation. That's not the matrix we should evaluate a good idea as. Second, and with saying this, I would just like to bring in that the Nobel Prize recipient Mary Bourneau, she has 34 publications with an H-index of 21. So even the Nobel Prize does not ask the peripheral T cell resistance, autotolerance, how many publications you have, and what's your H-index, before they consider that's a significant enough innovation or discovery to be awarded with the Nobel Prize. Second, the second thing we look at is the number of patents for an academic researcher. YK sir already said, Biswa sir also said that the number of patents are important. In one of the meetings, people said that the academic researcher have number of patents sitting on the shelf of their offices. They don't see the light of the market. That's because we have a discordance. YK sir clearly alluded that there is a discordance between the patents that can get into the market, and that's where we need engineers. And that integration has to happen. It is happening. It's happening at quite a satisfactory rate, but we have to catch up. Maybe around nearly a decade far from the real innovation actually come from the medical academic researchers coming to the market. And with that, I would like to say that I am fortunate that I have next 20 years to embark on this. Thank you so much.
Thank you everyone for this real mind-blowing discussion. So at the onset, I would request the moderators to kindly felicitate the panelists. So sir, please. Okay. We are actually running short of time.
Just 2 minutes.
Okay, okay.
This discussion is no good.
All right, all right. Sorry, sir.
Thank you. Good morning again. I know we are running short of time, but I'll be very brief. I will be to the point. This discussion has been really very, very good one with some new dimensions has come out in this group. While Dr. Chawla mentioned the money, Dr. Katov said money is not a problem. The good takers are a problem. And if good takers are there, delivery is a problem. And if delivery is also there, Dr. Gupta said bringing this to the market is a problem. So I think what we need to do is a lot to change the mindset of people in our system where we could tap the researchers, create an environment for them to grow and come out of the traditional method of judging somebody's promotion based on impact factor or number of publication, rather than what impact it has created to the society by translating innovation to a product. And I think I must thank Dr. Gupta for bringing this issue and forward very nicely, and also Professor Ashok Kumar very well forward. I must admire something, that how to marry an engineer and a doctor. I think we have to find some ways. Maybe a doctor should have a girlfriend as engineer or something like this, I don't know, or vice versa. So maybe, I don't know. I think engineers can give us a solution, or AI will give us a solution, I don't know. So that question remains. The other aspect which I feel is, which has been very well highlighted, is that some of the time we are doing research only to get promotion, and when we get promotion we stop there. And what we need is a mindset which continues to do research, and I think that should be beyond a personal gains. It should have a national objective or departmental objective. We should have, every institution can focus, sit, debate, create a group to develop priority for that institution to do research, pool the resources, bring the right people, and then carry forward to an outcome-based research. So outcome is very important. The regulatory compliances are there, so perhaps if we are marrying with the industry, industry should come from the very beginning, not after we have done halfway research. So that is, I think, very, very important aspect. And don't look at the H index. That's what have been told by one of my colleagues. Look at its impact, look at its idea, and even the Nobel Prize winner had an impact H index which was not very high. So in nutshell, I would say I like to thank everyone on the dais and the president, and there is a need to relook how we look at research. I think in short I will say that. Thank you very much once again. Yeah.
Thank you, sir. And your marrying take was actually mind-blowing, because I have always felt that why doctors always marry doctors. So I think there has to be a change now. So we can start from now. So with this, we go on to the felicitation ceremony, where Professor Chawla, sir, and the other moderators, please facilitate the panelists. Please. Dr. V.M. Katoch, former Director General, ICMR. Dr. Kar, Director, AIMS, Darbhanga. Dr. Ashutosh Biswas, Director, AIMS, Bhubaneswar. Dr. Rajeshwar Dayal, Senior Fellow and former Vice President, NAMS. Dr. Y.K. Gupta, Council Member of NAMS. Dr. Smita Patnaik, Professor, Department of Pharmacology, PGI, Chandigarh. And Dr. Ashok Kumar, Professor, Director, IIT Kanpur, the only engineer who is with us today. Now we move on to the next panel discussion, which is healthcare in India. So for this, the moderators are Dr. Mahesh Verma, Council Member of NAMS, Dr. B.R. Mittal, Council Member of NAMS, and Dr. Meenu Singh, Executive Director, AIMS, Rishikesh. I request all the moderators to please take their seats on the dais. The panelists are Dr. Vinod K. Paul, Member, NITI Ayog, Government of India, Dr. S.M. Bose, NAMS Council Member, Professor Vivek Lal, Director, PGI, Chandigarh, Dr. Shakti Gupta, Director, AIMS, Jammu, Dr. O.P. Kharbanda, NAMS Council Member, and Dr. Anil Kumar Jain, NAMS Council Member. Introducing the moderators, we have with us Professor Mahesh Verma, who is the Council Member of NAMS. He is a Padam Shri awardee, Vice Chancellor of Guru Gobind Singh Indraprastha University, New Delhi, Chairman, National Accreditation Board for Hospitals and Healthcare Providers. He is a Dr. B.C. Roy awardee as well. National Science and Technology awardee, Global Oral Health Progress awardee, Elmer S. Best Memorial Awardee, award by Pierre Fauchard Academy, US, Aryabhat International Award 2015, President of International Association of Dental Research, India, Indian Division, International Association for Disability and Oral Health of the Indian Chapter. Dr. B.R. Mittal, he is the NAMS Council Member, Nuclear Medicine Expert for the International Atomic Energy Agency, UICC-sponsored ICRET Fellowship Award, President of the Society of Nuclear Medicine, India, Editor-in-Chief of the Indian Journal of Nuclear Medicine, and he is the former HOD of Department of Nuclear Medicine at PGI Chandigarh. Dr. Meenu Singh, she is the Executive Director and CEO, AIMS Rishikesh. She is the President of the Telemedicine Society of India, Editor-in-Chief, Journal of Pediatric Pulmonology, Co-Chair of Cochrane, India, former Professor, Department of Pediatrics, PGI, and former Head, Department of Telemedicine, PGI, Chandigarh. Over to you, sir.
So, can we begin?
Yes, sir.
Okay, thank you. I know we are behind schedule, but this is a very important session. We are talking about health care in India, which is so dear to all of us. We are all healthcare professionals gathered here. So I would make some opening comments, and then followed by that, the plan of this session is that a couple of minutes will be given to each the panelist, and at the end of it, we can have some discussion, and then we can summarize it and talk about the carry home messages. So India is done very well. We've truly improved in key public health indicators over the past decade. That's a good field factor. The infrastructure footprint is expanding both in center and state. Government hospital beds have increased tremendously from 4.7 lakh in 2005 to almost 8.5 lakh today. The public health spending has increased. Our GDP is spending is 2.1%, although we are expecting to go still higher. In terms of workforce, we are anticipating that we would have 5 lakh doctors, from 5 lakh doctors to almost 12 lakh doctors by 2047, and also a huge number of nurses, about 1.5 million nurses by 2047. The number of medical colleges have tripled in the recent times. The country also has seen a big growth. Heal in India, how our medical tourism is doing, and India also ranks very high in pharmaceutical industry. Our digital health adoption is a major enabler for Ayushman Bharat, and also we by 2047 we want to establish a medical college in every district. So that's a good field factor. So, and to debate over it, all these factors and what are the challenges and what we can still do, we have giants, we have legends, we have leaders in this session. I'm very happy that I am joined by two of my colleagues here, Professor B.R. Mittal and Madam Meenu Singh from AIMS. So the first speaker I would like to introduce is Dr. Vinod Paul, who's done us all proud. He's a member of Niti Aayog, who leads health, nutrition and education vertical at Niti Aayog. He's his son Dogmai Family Health Foundation Prize by WHO, which was given at World Health Assembly some time back. He is also a recipient of Dr. B.R. Ambedkar Centenary Award for Excellence in Biomedical Research by ESCMR. He chaired the National Task Force on COVID-19. He is a former chairman of MCI, which was after the MCI was reenacted, and he is also former head of Department of Pediatrics at AIMS Medical Sciences. So with this brief intro, over to you, sir, for your opening remarks for about 5 minutes, and then we can have another panelist. Thank you, sir. Thank you.
Thank you very much. Honored to be here. Thank God there's no question, only opening remarks, so I'm safe. Well, I'm honored to be here among Tedoyans, among leadership of the medical education, sciences and care in India. Healthcare in India is a very broad topic. Other panels are also in a way directly or indirectly covering it. But let me go a little more direct into this discussion. The context that we all have embraced is the goal of Viksit Bharat at 2047. If you look at that goal, then the one or two expectations are the following. First and foremost, we are aiming to have a life expectancy from the current level of 71 years to 85 or more. So हम सब के लिए सोचना है कि इसको अचीव कैसे करना है. Causes of death, NCD, non-communicable diseases, communicable disease. So that's one. And how do we bring the health system for that, healthcare for that? Healthy life expectancy currently is 60 years, because we can't afford to be unhealthy and on ventilators at 85. Healthy life expectancy, current level 60, want to be 75 or more. 75 and 85 are respectively the current benchmarks of the developed nation, and that's what we aspire. And our time starts now, or has started now. Second, we are looking at an infant mortality rate of less than 5. We are looking at doctor population ratio about 3 or so. Of course, paradigm may change with AI, paradigm will shift to home care and so on. Notwithstanding that, this is 2 to 3, at maybe about 3 would be the goal. Our current, so I'm just giving the health system, quick run up on the health system. Currently, we have, our beds are currently just about 1 per 1,000 population. Developed nations have typically always more than 2, typically 3, and at times more. So we have a journey to take forward. What does it mean? Let's pick up on some of these aspects. Doctor population ratio with Ayush, if we add, is 1.4. Allopathic about 1, just above 1 in fact. And we have a huge pipeline of specialists as well as general doctors in the making, and you had a panel on that. So one imperative for us is we have to move in the direction of 2 doctors per 1,000 and hopefully 3 doctors per 1,000 for healthcare. From infrastructure, from about 1 bed per 1,000 population, 1 bed per 1,000 population, safely to go to 2 and then perhaps 2.5 to 3. It would mean, for example, because that point was made by Maheshji, it would mean raising the beds from about 12 lakh public and private to at least 30 lakh. So there is a scope for 15 lakh more beds to come. Let's hope 5 lakh will come from the public sector and 10 lakh or so should come from that these are the quick imperatives that I'd like to highlight. Moving to another direction. But I think on medical education, I want to say that the R gradient for achieving specialists, right ratios for specialists, is now emerging the core problem. Where we have 1 psychiatrist, we need 5, if not 5, 3. We have surgeons, we need 3 times that number. So while MBBS graduate population will increase, 1 will become 2 per 1,000. Effort on specialist training and super specialist training is so very important. Let me move to the aspects of healthcare now. Healthcare, primary care. Above all, I wish to point out to this August gathering that a huge work is underway, and I would like that to be spoken more often, to be talked about, to be watched, to be facilitated, to be supported by all of us. We are revamping, re-energizing, re-engineering primary healthcare of India as never before. It's a silent revolution in the making. We had sub-centers, primary health centers, they were delivering maternal newborn child health, they were delivering communicable disease and some problems. That paradigm has now moved to a comprehensive primary health care, 177,000, 1.77 lakh health and wellness centers are in the making. I want us to be very mindful of this because the most important layer of any nation's health system is primary health care. We are not talking about enough. We are not from academia contributing enough to make that happen, to learn and to contribute to the packages that build up this one, build up the primary health care. For example, senior care, supposed to be given through primary care above all. Have we got our primary care version of senior care delivery? No. Have we done it for breast cancer? Not yet. Have we done optimally for diabetes? No. Have we done it for hypertension? To an extent. So I wish to remind this, and I think perhaps in the evening again I have to say this, that NAMS, please be a champion and a facilitator for establishing strong, resilient, comprehensive primary health care that people of India would be proud of. And one day I would like to see family physicians being in charge of, this is a conspiracy with Dr. Abhijat Shetty, that we will need family physicians to be manning it. Second, and the last one, given the time, I think we should be aware of how the health assurance is moving in our country. So primary care, secondary, tertiary, things are happening, new medical colleges, you talked about beds, no time for that, but I want to remind you how the scene with regard to health assurance has moved. Pradhan Mantri Jan Arogya Yojana today covers 60 crore people itself. Participation of the state and the union, 60 crore. We are 140 crore. 60 crore. If you add to this what the states have done on through their own full budget, not the shared budget, that's 60 crore. They have added at least 10 crore more. Many states have added a whole lot of extra population. So that goes to 70. Another 10 crore come from ESI, they have a health insurance. And then if you push it further, you would see that we are 80 to 90 crore people today have health insurance. And a lot of it is working, a lot more should happen, and that's another area where we should really bring our efforts together. We also need increased coverage of insurance in the private sector, and please help us design that. The IRDA has recently brought about changes which we want to build on with the help of all of us and hold us accountable on the part of the insurance companies on the one hand, so that they increase the net and give us a product that we can afford, products that we can afford, and also on the part of the private sector to honor those assurances and so on. Universal health coverage is about access to services, and you worked on that, you heard from me a little bit. It's about having no financial stress, and the nation is working on this. It's work in progress, it's not perfect, but I think the leadership, this is the leadership which should help design it. This is the leadership which should talk about it. You should devote so much more time on these bigger issues. I suggest humbly and like us to work together in this regard. Thank you.
Thank you very much. Thank you, sir. It's very nicely and succinctly you have put up these points. So, Professor Mittal.
Yeah, thank you, sir. Now, next lead panelist we have Professor S.M. Bose, who is the former senior professor and head of surgery at PGI Chandigarh as well as AIMS New Delhi. He is the national president of Association of Surgeons of India. He had been the national president of Indian Association of Surgical Gastroenterology and Chandigarh Surgical Society. Received 3 national awards from President of India and several from global surgical associations. Dr. Bose, please.
Good morning, friends. We are here to discuss some very important thing which is there for all of us. Good health for all is of utmost importance. It is more important than the financial status of the government or individual, also for the defense preparedness of the nation. Because if a person is not healthy, neither he can earn nor he can defend the country. And this is very important. In the healthcare delivery system, there are facts, what are the problems and what are the solutions. The facts is our population is 1.42 billion people, and it is said that very soon we will overtake China and our population will increase. Whereas our healthcare facilities have not kept pace with the population, and this is what is important. It is a formidable task, and our efforts are being made in this. Currently only 1.13, it is not 2.25. That was, we wanted to have 2.25 GDP in 25, but we have not been able to do it. Our is only 1.13% of GDP, which is meager and peanuts. India ranks among the bottom 5 countries. Rupees 3 per day is spent per resident per day, and 80% are not covered under any scheme. 60 to 80% spending is personal from our own pocket. Even I cannot afford to spend the money at my age for me or for my wife. I had a knee replacement surgery. Although I am supposed to be getting all free treatment in PGI, but as I am located elsewhere, I had to spend 5 lakhs for my one knee replacement, and I am not getting a single penny reimbursement for that. And so this is what is 60 to 80% is spent from, and I have seen patients, they are spending money from there after selling their land, selling their jewelry. The hospital bed density is 0.9 per 1,000 patients, in contrast to WHO guideline, which should be at least 3.51. Private healthcare, the healthcare is by private healthcare providers, and an upper hand, 78% of the OPDs and 60% of IPTs are in private hospital, whereas rest is in government. I'm going to share the public includes PSC, community health center, district hospital, medical colleges, super specialty tertiary tenure like AIMS or PGI Chandigarh. There are also health care given by Ministry of Defense, Ministry of Railways, and private includes clinics, nursing homes, hospitals, and corporate. Majority of the government hospitals are sadly lacking the infrastructure. You don't have to go anywhere. I have worked in PGI Chandigarh for almost 40 years. And then for 15 years, I have worked in a corporate hospital. And if you even now go to any government hospital, the rush is so much. Politically, we may say anything. But if you ask a patient how much of problem the patient is having in getting treatment, then you will understand. 10,000 new patients, like say for example PGI, my alma mater, where I have worked for more than 40 years, this was my alma mater and I still love it like anything. But if you think, it has become almost a common hospital. There are more than 10,000 patients, new patients are coming to PGI OPD every day. And if you add to this the follow-up patients, the number is enormous, and I don't think one can tackle this. And similarly, it has so become that even my colleagues or people who are working in PGI have to go to private hospital to get treatment for themselves or their family. I'm telling you very correctly, I know the names of my colleagues who have retired, who prefer to go to the corporate hospital rather than to go to PGI. And private hospital, you know how much is the expenditure. Beds, you can see 2 patients lying in one bed, even in the labor room, patient lying on the floor, on the trolleys and under the trolley. And so the PGI has become almost a common center, because the hospital around this have not improved. So everybody from Himachal, Haryana, Punjab, UP, Rajasthan, they flock to PGI, and PGI cannot look after these patients. We have to take care of this. We have to control this, and how they will do it, I do not know. Paradoxical, thousands of patients from all over India and from abroad continue to come to PGI for treatment. But it is shocking that patients from every corner of India is still coming to PGI. There are foreigners who are coming to PGI Chandigarh for treatment. If I have to refer a patient, I will refer a patient to my friends working in PGI, but then it is not giving the life of treatment what for it was made. It should have been a tertiary hospital, a temple for the teaching and research, but unfortunately, whatever they may be doing it, they are always falling short of expectation. The operations, patients have to wait for months together. PGI requires many more number of operations. You will be surprised that one surgeon gets only 1 day for operation in a week. Whereas when we were there, we were doing at least 15 to 20 operations each of us every week. But now the operation theatres are always busy. It is not possible. So these are the basic issue of healthcare which have to be looked into, and we must discuss this. Okay, how to make the tertiary hospital the temples for education, research and patient care. Whatever is there, it is short of it. Whether we control population or whether we have to increase the infrastructure. Like PGI, it has almost become a jungle of concrete. There are so many centers. There are so many centers up there. I do not know why they expanding horizontally, why they cannot go up. But whatever number you may add, it will fall short unless the surrounding hospital improve in them. Thank you very much.
Thank you, sir. Thank you for insights.
Good morning, all the members of this august body and all those who are present here in this particular hall. It's my privilege and a great opportunity to introduce Professor Vivek Lal, who is the director of PGI Chandigarh, one of the great INIs and the largest hospital in the north of India, always having a very high rank, mostly second to AIIMS Delhi in the NIRF ranking. And as Dr. Bose has just spelled out some of his comments, I would say that this is not a debate about PGI. I would request Professor Vivek Lal to give his comments about tertiary healthcare and other factors of developing institutes of national importance.
So, first of all, मेरा आप सभी को हाथ जोड़ के नमस्कार. I am as a chairperson of this NAMSCON. I am very grateful to all of you to have come and who are enlightening us with these discussions. I hope that कमियां रहती हैं, अगर कोई कमियां रहेगी तो I take the blame. And credit is combined. Credit goes to the joint the organizing secretary, Dr. Ratho, who's not here, who's busy behind the scenes. But अगर कोई कमी रह गई है तो I take the blame. I'm apologetic and I try and improve upon it. So I am not here to debate what is right and what is wrong. I call a spade a spade. जो सच है सच ही रहेगा. No matter आप जितनी मर्जी window dressing कर लें, और जो झूठ है वो झूठ ही रहेगा. So let us not live in a world of dissociative, flamboyant thinking. I'm using two strong words. Dissociative, flamboyant thinking. I was just, talking about healthcare in India. That's the topic I'm supposed to talk on. In one line, I'm going to summarize. We have the best healthcare in India. My brother and my sister are citizens of the United States of America, bona fide citizens, right? My brother did his MD from PGI, a cardiologist, minting money. He went to Baylor. From Baylor, he went to Texas Heart. From Texas Heart, he went to Mayo. Big names. He then realized कि सच और झूठ तब पता लगता है जब आप ग्राउंड जीरो पे होते हो. यहाँ से तो सब कुछ, everything is green from a distance. America, America, America. That's what we do. That's what we worship. He quit academics. He thought money is the best way forward, and he's got a leading practice. My sister's a pathologist in Boston. She is working for a renowned chain of hospitals. And to be very honest, the less said about the American system, the better it is. I'm not saying this because I'm a government servant. I'm saying this because America has a health system without a conscience. No health system can function without a conscience. Professor Harry ne bahut acha. Professor Harry went to, he was from Patiala Medical College. Professor Duke Elder came to Patiala, picked him up and took him along with him. He was a renowned ophthalmologist in the United States, one of the leading lights of neuro-ophthalmology. He said the American health system, what is the difference between the American health system and the Indian health system? The American health system is like a Rolls Royce. If you can afford it, it's luxury beyond sin. The Indian health system, he said, is more like a bus. Bus आएगी, सभी को लेके जाएगी, सभी का इलाज होगा, टाइम के साथ होगा. It's just a question of the quality of the bus. We need to improve the quality of the bus. That's all. We don't have to go after Rolls Royces. I don't need a luxury suite for myself if I get pneumonia. I'm happy to be in the hands of safe doctors. I will rather be on a stretcher and in the hands of a safe doctor rather than be in a luxury suite and be at the hand of a doctor who's snoring in front of the ventilator. Right? I'm very clear about one thing. And our doctors, believe it or not, are the best or easily amongst the best in the world. Easily amongst the best in the world. I can say it with confidence because I get inputs from ground zero in America. My brother and sister are there. They're American citizens. Both are doctors. Everyone's a doctor in their family. And the stories they have to tell me, and they are not wrong, are gory stories of what their healthcare is all about. It's very easy to blame India. Very easy to say, "Hamare paas ye nahi hai, wo nahi hai." That is a negative mindset which actually we have not come out of. We have not come out of a negative mindset. We need to come out of a negative mindset. You tell me, we have a hospital. The annual footfall in our hospital, sir, registered footfall is 3.5 million annually. That is the registered footfall. That is 35 lakhs come to PGI. That was last year's statistics. आप ये सोचेंगे अगर इतने लोग आते हैं तो litigation बहुत होगी PGI में. 3.5 million is the annual footfall. Can you guess what is the bona fide litigation? Any guesses? Any guesses? I mean, how many? What are you saying, Dr. Puri? Only less than 20 bona fide cases against PGI in the courts. 3.5 million people coming to PGI, a government hospital where people are on have to wait for a ventilator because we have 100 ventilators, there are 400 waiting. I can't help it if 400 are waiting. But we ensure that whatever can be done in our limited circumstances is done for their benefit. And they also appreciate it. PGI, I always say, and I take a bow in front of my founding fathers. When I say founding fathers, I mean founding fathers of Medicare in India. That includes everyone here on the dais and includes so many of the dais. I take a bow in front of you all because of the standards, the visionary standards of Medicare that you set in India. We are going forward. हमारे में कमियां हैं. If you have a population of 1.5 billion, that's not my fault. And if that population says मैंने PGI जाना है, that is not my fault. That is the price you pay for your competence. So what you consider as a burden, I consider as a responsibility. That's the difference. If you think your responsibility is a burden, your shoulders are going to droop, you're going to crib. But if you think your responsibility is a responsibility, you're going to be like this. That's it. Ask General Velu Nair how things are in the Indian Army. I mean, yesterday I was talking to a officer who was posted in Sachin, sir, and I will not name that officer. He said the Indian Army treats its soldiers like sons at Sachin. I wish the same was true for the government treating our doctors also. I want it that way. I want it that way. That is what we need to do. That is what we need to inoculate the government about. कि हमने medical colleges तो खोल दिए, but we have to respect talent. They are amongst the best in the world. You think our boys and girls are inferior to those in the best? No way, sir, no way. You talk to our boys and girls, they think we are dinosaurs, which we are in some ways. Because of the dissociative mindset of socialism, Brownian motion of X, Y, Z, I just fail to understand. You were talking about integration of research and, marrying research with the industry. Yes, that's the way forward for Medicare in India. That's the way forward for research in India. That's what our students need to be trained in. Research which has a NAV, net asset value for the society. net asset value for the society. And net asset value for the society can only happen अगर हम उनको शुरू से ही इंडस्ट्री के साथ शादी कर देंगे उनकी. Don't wait सगाई करके, don't wait for the शादी to happen 20 years later, it'll break by then. It has to start from day one. Someone said that industry has to be part of a research right from day one. The industry knows what the market wants. Industry is looking into the future. We are not. Actually, we are not. Doctors are very poor when it comes to looking into the future. Industry knows what is the way forward. So if you have AI, which you know is going to be the nuclear bomb of the future, why nuclear bomb of the future? It's the next nuclear bomb of today. It's going to be worse than Hiroshima and Nagasaki if we are not prepared for it. So we straight away incorporate industry. We straight away have these boys and girls talking to the industry so that our way forward is in the right and in the enlightened direction that our people want us. With that, sir, I understand I overshot my time. I wish you all the very best. Thank you so much for coming. Namaskar.
So we have a next speaker, renowned Professor Shakti Gupta, old friend, who's Executive Director and CEO of AIM Jammu. He's been founder president of RFHHA and editor-in-chief of the same journal, FICCI Healthcare Personality of the Year 2025, Pratibhashi Samman, Chikitsa Ratan Samman, Shram Shri Award, International Part of the Year Award from Cologne University, Germany, Capital Foundation National Award, Times Healthcare Achiever Award, and he's really known for pain-free approach, patient-first philosophy, and Apna AIM Jammu, initiative. Over to you, Professor Gupta.
Thank you, sir. Thank you. I feel actually everybody will agree with me that India's healthcare story today is the story of transformation with intent and impact. Through Ayushman Bharat, we have ensured financial protection and reduced the burden of the catastrophic expenditure on lakhs and crores of families. Through Ayushman Arogya Mandirs, we are strengthening primary health care at the root level, improving early detection and continuity of care. With new aims being established across the nation, high quality tertiary care is now accessible to all, particularly in the underserved regions, reducing the need for patients to travel outside the state. Ayushman Bharat Digital Mission is connecting health records and enabling interoperable digital care, bridging data gaps and expanding teleconsultations. The Prime Minister Healthcare Infrastructure Mission is addressing long-standing deficits in critical health infrastructure, ensuring preparedness and emergency response. And of course, the medical tourism showcases India as a global destination for affordable and advanced healthcare, bringing the world to our expertise. So each step has been filled. They have filled a crucial gap. By the financial protection has been filled through the Ayushman Bharat scheme, frontline access through the Arogya Mandirs, geographically equity through the new aims, digital integration through the Ayushman Bharat Digital Mission, infrastructure resilience through the Pradhan Mantri Health Infrastructure Mission, and global positioning through the medical tourism. The foundation is very strong. The direction is right, and the pace is encouraging. Now, India's health journey has shifted from vision to execution. We are no longer catching up, we are leading the change. Now, with the solid tracks laid, we must accelerate from the speed of a Vande Bharat to the speed of a bullet train, because India's 1.4 billion people, they deserve nothing less. No, there are some issues like tired healthcare which is prevailing in our country, that is the strong framework but uneven functioning.
The challenge is that we have an excellent three-tier system. The primary healthcare centers, the community health and district hospitals, the tertiary care centers like AIMS, but tiers do not talk to each other properly. And there are certain gaps in the form of patients bypass primary health center and district hospitals, tertiary care centers getting overcrowded, urban clusters have multiple facilities which the urban centers have multiple facilities while the many rural blocks they have the none. Now what could be the solution? The solution could be hand-holding of the healthcare. That is, medical college should mentor district hospitals, the district hospital should mentor the primary and community health centers. Now there is a need for a structured referral pathways, just like National Health Scheme, but it has got its own strengths and weaknesses also. Routine specialist OPDs in district hospital, maybe that can be mentored by medical colleges and the institutes of national importance. Only referred cases should reach AIMS, and that should be faster and efficient care. Now what is going to impact? The impact will be a better equity, reduced travel cost, less burden on tertiary hospitals. Now human resource shortage is another issue, quantity versus the quality gap. The challenge is, yes, many new medical colleges are being opened, but faculty shortage, particularly in super specialties, nurses, paramedical and technician deficit, reluctance to serve in rural and difficult areas, but the solution could be intensive based postings, maybe 20% extra salary allowance for difficult postings, 20% PG seats reserved for doctors serving rural areas. In PGI, provision was there long back. Nursing and allied health capacity expansion is a need of the hour. Mandatory rotation for young specialists in peripheral centers. Now, how it is going to impact? It will impact on the skill distribution, which will improve, and the tertiary load decreases, which will result in rural trust, which will increase with the passage of time. Now, there is a regional disparity, that is a same country but different healthcare. The challenge is that some districts have five dispensaries in 5 to 50 kilometers, but others have no specialists within 50 kilometers. The solution could be geospatial mapping of the facilities, redistribution of the resources, and prioritize underserved zones for infrastructure and manpower. And what impact it is going to have, that healthcare becomes geographically just, not the privilege based. Out-of-pocket burden and mixed system dynamics. The challenge is that public healthcare, which is free, but it is a basic. Private healthcare, advanced, but it is very expensive. India still has one of the highest out-of-pocket expenses in Asia. The solution could be strengthening the government institutions to reduce private dependency, expand and timely reimburse insurance schemes and standard treatment protocols to prevent high cost variations. And how it is going to impact? The impact will be the care becomes affordable and it is predictable. Now, digital divide. Technology exists, connectivity does not. The challenge is digital health adoption is very patchy. The data fragmentation is there, specialists not available everywhere. So what could be the solution? Solution could be in the form of digital bridges. Ayushman Bharat Digital Mission for health record portability, telemedicine plus artificial intelligence for screening and triage, e-ICUs, teleradiology, AI-based diagnostic in rural India, mobile labs plus outreach screening units like cancer screening and other areas. And how it is going to impact? The impact, it will impact the care which is the patient, not the patient traveling to the care. Now, financing and infrastructure, that are challenges, health spending still required level. Just I'll take 2 minutes, sir. Then equipment plus infrastructure maintenance gaps are there. Then cancer and non-communicable disease surge requiring modern facilities, and solution could be the Prime Minister Ayushman Bharat's health infrastructure mission, strengthening emergency and critical care infrastructure in our country, partnership with CSR, private sector and academia, develop regional centers for excellence like AIMS and other institutes of national importance, and how it is going to impact. It will impact that hospitals will become future ready and self-sustaining. So this is a signature policy formula on disparity, HR crisis, out-of-pocket expenditure, overcrowded AIMS, and digital divide. Now, what are the challenges and road ahead in healthcare? The challenges are that we cannot handle the load, the poor diagnostic facility, difficult terrains, but result could be modern equipment, radiology, advanced, these type of things needs to be done. Now, our vision is very simple. Right care at the right place and right time and right cost. When an Indian falls sick, it is not just the body that suffers. The family suffers, livelihood suffers, education suffers. Healthcare is not a service, it is a national promise. A promise that the poor will not become poor to stay alive. A promise that quality care will reach the last mile. A promise that the place of birth will not decide the quality of treatment. Healthcare is not about buildings or machines. It is about dignity, hope, and belief that every life in India matters equally. India has the knowledge that will and the heart. We must deliver the promise by building a healthier India together. Thank you so much.
Thank you, sir, for touching upon few important points like challenges and gaps. So next in the panel is Professor Dr. O.P. Kharwanda, who is NAMS Council member also, Pro Vice Chancellor Health Sciences, Ramaiah University. He is a former Professor and Chief Center of Dental Education Research, AIMS, New Delhi, and Fellow International College of Dentists. Professor Kharwanda, please.
Thank you, sir. I am taking you to a little different perspective, having worked in AIMS for 40 years and then creating the Center of Dental Diseases and eventually building up to the National Institute for Dental Research. I would give you a little background and I will be within my time. The burden of oral disease is very high, and if you go to the GBD, oral diseases remain high, other diseases have changed. So hierarchy has changed, but they remain high. And even in the most developed country, the poor people still suffer from dental conditions as bad as we suffer here. So three main conditions. Dental caries measured by DMF. DMF index is on very steep rise with consumption of sugar added drinks and of course for oral hygiene. We lose teeth mainly because of the gum disease, and India is the world capital of oral cancer and the major cause of death with cancer. So now what is happening in the national level? So under National Oral Health Program, which we started many years ago, 2014 I think, and the AIMS was the nodal center, it has done a lot. We have expanded and also created an app called Edan Seva, education portal and everything. With ICMR, a big project on school health scheme where we are promoting toothbrushing, supervised toothbrushing after the meal. NAMSCON is also on the way, it's working. But the question is how we can make this dental diseases a dream, because we want to give a nara called 20-32, 20 दूध के दांत और 32 पक्के दांत और 2032 में कम से कम मुंह में 20 दांत हों. So that is what we want to bring on. So we was working very closely with the government and WHO, which led to when Dr. Harshvardhan was the health minister. So one proposal was passed in the assembly. WHO went to the United Nations, and now oral health has become a part of the universal health coverage, which was never listed ever in any goals of the United Nations. So that one thing, important thing has happened at political level. And in 2025, the Global Oral Health Work Plan from WHO has already come, and which is also being adopted by Federation Dentaire International, and to which most of the dental associations are member, including Indian Dental Association. So as a government as well as the association, we are committed to implementing the Global Oral Health Action Plan which is a plan for 2030 actually, not 2032. So by 2030, we are going to work on very hard on it. But I have some humble requests since Dr. Paul is here and all stalwarts are here. I want to make few requests. One of the major requests, which very good thing has happened in this last budget, government has reduced the GST on toothpaste from 18% to 5%. So that makes it affordable. And I think it should be 0%. Not only on toothpaste, but on oral hygiene products. If you want to make it affordable, then only it will be reachable to the masses. So equity and access, these two things become very important here. Other thing I wish to add is that there is a need for very stringent policy on surrogate ads of tobacco-free products which are used in the oral cavity, and many of our very stalwarts are promoting it. And the major cause of oral cancer is including supari. It is not just tobacco. Tobacco is also there, but supari is also a component. And there is no law to prevent use of supari in oral cavity. So that is another thing. There need to be law to be labeled all high sugary drinks, that how much sugar they have and how they cause oral health problem and the systematic problem, because there is a common factor etiology with dental caries and diabetes and other NCDs. In addition to that, what request I am going to make to our stalwarts and the leaders in the profession who look after also the Niti Aayog, Dr. Paul, that while the most dental diseases are preventable, so it is a low cost thing, which will have impact, very large impact on the overall cost of the exchequer in the country. If the country has to provide good dental health to the people, the dental health provision is at the moment in the hands of private sector. So my humble request would be, while this preventive aspect should go on, the high-end treatment should also be provided at AIMS, like institutions or other AIMS, like what we have created at Delhi, because other AIMS have only minuscule dental department. So that will spread the high quality care to the masses across the country. Thank you, sir.
Thank you very much, sir. Last but not the least in our panel is Professor Anil Kumar Jain, who is the Editor-in-Chief of Annals of National Academy of Medical Sciences. He's an orthopedician, a former Director Professor of Orthopedics at the University College of Medical Sciences, University of Delhi. He was trained for spine surgery at Harlow Wood Hospital and Queen's Medical Centre, Nottingham, and also at Royal Hospital for Sick Children in Edinburgh. He's been in the University College of Medical Sciences as Dean of Faculty of Medical Sciences, as well as the former principal, and he's also the past president of Indian Orthopedic Association. Professor Jain, please, for your comment.
Thanks very much indeed. I think lots have been talked already, so I'm just not going to talk about that. I first, at the outset, would agree with Professor Lal that yes, this health services is the best. I recently been to US 6 weeks ago, had some medical issues, and the ordeal I faced, that explains this, what you said. We have not only to increase the quality of bus, we have to increase the frequency of bus. I think as far as the health services structure, just my initial thought, country had very good, well-structured plan, whether different sub-center, PHC, CHC, district, tertiary care, evolving and continuously evolving, will continue to evolve, and designated manpower. It's very clear how the governance will work, center or state, sector, public sector, private sector, both. Well, government has lots of scheme how to give money to the family, whether it is Janni Suraksha Yojana or any other Yojana or Ayushman Bharat. I think that is not beyond this discussion. We know that everyone is working, but we must know that we have to provide health care to 1,500 million, which is very difficult. No one in the world can provide free health services to 1,500 million. We are trying to provide. Well, central government funding, we know whatever it is, less or more, it is that. I think let's first see what we are doing with that. Are we using it optimally? Are we delivering the health services with that funding optimally? And keeping that in mind, that our target is to deliver universal health care and optimum minimum standard of care to each one of all. In that, keeping that in mind, I think we need to introspect. Are we getting the results what is intended, whether it is the Yojana, whether it is the center, PHC, CHC, are they delivering the health services? Are we able to deliver those optimal health, optimum standard of care universally, or else universal basic health care? Are we able to treat all of them well? Are we able to avoid complication due to late, delayed treatment? Or are we creating, despite all efforts, the disability rate is increasing? Are we able to provide preventive care? Are we able to prevent occurrence of rickets, vitamin C deficiency to our growing up children? In nutshell, unless we reduce out-of-pocket expenses of our family, their wealth is not going to increase. So are our health facilities working to their potential? We could do better with the available infrastructure. And in 2014, I analyzed the Delhi hospitals, and I found that almost 1 lakh operation can be done in Delhi without spending a single penny in those government setups. So it means our government setups, they are not working optimally to their potential. They have to work because we have already spent money on it. So we need to see that those institutions are working to their available infrastructure, to their potential. So what the solution is, we need serious discussion on delivery of health services on ground, whether it is a village, whether it is a primary health center area, whether it is district. Is there the vicious cycle? Is there complete, doctor is there, X-ray is not there. Orthopedic surgeon is there, OT is not there, anesthetist is not there. We have purchased a C-arm, but then the table, operation table is not compatible with it. So we are just wasting lots of money, and that is what need to be assessed at the level of ground, and we need to fix the responsibility so that delivery of health services on the ground is better. Our institution, whether it is tertiary care, secondary care, primary care, they have to work according to their infrastructures. All sick institutions must be wiped off because that will require a minimum effort. We need to, and both the things can only occur if we include accountability in our governance. We need to fix the responsibility why this structure is working suboptimally. And the last is that we need to tailor research and education to our need. And that can only happen if all health services, all health facilities, they maintain electronic health record. If the electronic health record is available, then only the quality of services can be evaluated, then only we can tailor research and education to our need, we can know the actual problems, and then only that very data can help us in not only in the health planning, but in healthcare delivery as well. So with that probably my dimension, my thought was, other than thinking from the top, at the bottom, let's improve the bottom as well, so that both the things, when again the word marriage comes, so if both the things marry, then we definitely the number of buses will increase and the quality of buses will increase. Thank you very much indeed.
So we will have some concluding remarks by Dr. Mahesh Verma. I just wanted to say that in the recent, it is in the lighter vein, the recent mayoral election in New York was won on increasing the number of buses and also improving the child care and about freezing the rent rates. So I think India is the best.
Yeah, thank you. I think we love that statement, and as we have all the legends here, we had a very good session, and I would very briefly talk about the carry-home messages. We started with Dr. V.K. Paul, and he gave us a clear goals of Viksit Bharat, how to increase the life expectancy, IMR, doctor population ratio, patient beds to be increased, scope of 15 lakh more beds coming from public and private sector, effort on specialty and super specialty training, revamping, re-engineering, re-energizing primary health, comprehensive primary health care. So that was a very good thought, and he also said we need to also strengthen senior care delivery, including cancer care delivery. And second thing he said, how health assurance is moving in the country, which is a very good field factor. And he said a lot of work is being done through PMJ, for pushing it further through the state governments, and further IDBI bringing a lot of reforms so that we can have products which will not only include services but many other treatments also. Then we had Professor S.M. Bose, who said good health for all is most important, more than money, more than defense of a country, and he portrayed some of the limitations. Population expanding, healthcare spending is meager, private players still has upper hand, government facilities need a infra choked with patients, and he emphasized how to find solution to these issues. Then we had Professor Vivekla. He said, I call spade a spade, and he said, सच तो सच ही रहेगा, ground zero पर पता लगता है कि सच्चाई क्या है. Or no scope of any dissociate, flamboyant thinking. We have the best healthcare in India. Many countries abroad, I'm not naming a country, have health system without conscience. We are not talking about any particular country. We only need to further improve what we have, like government bus carrying passengers. We need to respect talent. Government should remember, in addition to expanding infra, and he said, net asset value to society by doctors only when research and industry is associated in training right from the beginning. I think that was a good message, Professor Lal. We had Professor Shakti Gupta. He said, India's healthcare story is exemplary. It has filled many gaps in the recent times. Foundation is strong, direction is right, and he talked about Ayushman Bharat, where early detection care. However, the quality care is not accessible in a far-flung area. We need to speed up. The three-tier healthcare system need to talk to each other. Hand-holding healthcare has to be there. Tertiary care centers only treat referrals. There are HR issues, extra salary, rural posting. Has to be given incentives to the doctors, out-of-pocket burden has to be reduced, build digital bridges, which is a big issue, and he said vision is right care, right place, at the right cost, and that is healthcare. Healthcare is a national promise, not just a service delivery. We had Professor O.P. Kharbanda, and I echo the sentiment with him. He said the burden of oral disease is very high, even in the developed countries, poor are suffering, and he said national level health program 20-32 नारा है, 20-32 तक 30 ये उनका नारा है. और he said it very historic move when 2021 or 22 the World Health Assembly passed a oral health resolution which was moved by Sri Lanka. Now oral health is a part of universal health coverage. It's a big move for us, and what he said, what he desired is equity and access need to be increased. There has to be GST free for all the oral care products, and also no surrogate ads promoting drinks, sugary drinks, and diseases. Dental diseases are largely preventable. We need efforts to be made to reduce future impact, and high-end treatments be available at all aims. We have 22 or 25 of them now. Then we have Professor A.K. Jain, final speaker. He agrees with Professor Lal's statement. We have full structured plans and schemes. Limitation is to provide free care to 1,500 million people. Question is how to provide optimum care with minimum standard universally or universal health care. There has to be a preventive care, reduce out-of-pocket expenses, and need to fix the responsibility, accountability, so that delivery of care is proper and optimal. Need to augment the research via EHR. And finally he said, let us improve the bottom. That means we improve the bus stand. बस भी चलेगी और बस स्टैंड भी ठीक होना चाहिए. Thank you very much. Thank you.
Thank you everyone for this real eye-opener. Now we will move on to the felicitation ceremony. For this I request the moderators to please felicitate the panelists first. Dr. Vinod K. Paul. Dr. S.M. Bose. Dr. Vivek Lal. Dr. Shakti Gupta. Dr. O.P. Kharbanda, and Dr. Anil Kumar Jain.
If you all have a group photograph, please.
Just a minute, sir. Just a minute, sir. So we would also like to felicitate the moderators and also the moderators of the previous session. So for this, I request Dr. Vivek Lal to do the felicitation. Dr. Mahesh Verma, please. Dr. B.R. Mittal. Dr. Meenu Singh. Dr. Y.K. Chawla. Dr. Amita Jain and Dr. Saroj, please come up on stage too. Dr. Chawla. Dr. Amita Jain. And Dr. Saroj Churamani. Thank you, everyone.
We take a picture, sir.
We now move on to the next 10-minute session, which is the Annals of National Academy of Medical Sciences. I think it would be a talk on that by Dr. Anil Kumar Jain, and for this I invite him up on the stage. He is the Chief Editor of Annals of NAMS.
Good afternoon, friends. Thank you very much, Professor Behra sir, for giving me this opportunity. And I think what we have this Annals of National Academy of Medical Sciences for last this is 61st year. So we have completed 61 year. And in 2016, we increased the frequency to 4. And now that's the current status. So I'm presenting this report 22 to 25 because in that we are on a mission mode. So I'm just presenting these joint journal metrics, data and progress in last 4 years. Now there are certain qualities of a good scientific journal, and they are like for indexing as well, that journals should have a high quality content, publishing high level of evidence studies, should have a strong reputation by the good publisher, editorial board in the academic community, should have very defined clear scopes, rigorous editorial standard for all matters pertaining to editorial processes, and high impact journal should have a high impact factor because once these articles are cited, so at the moment we do not have impact factor, so but still ethical practices clearly states its ethical policies regarding issues like plagiarism, conflict of interest, human and animal research. Now, peer review process should be well communicated and with rigorous, fair and objective reviews, should be transparent about its policy, and it should have a good accessibility and visibility. Our visibility, accessibility to the target audience, which could be researcher, professor, student, so we are in open access, that's not an issue. And the indexing, the journal is indexed in reputable, bibliographic and abstracting databases. Now what is important when you apply for indexing, what you write is a publication quality and reliability, which should be consistent publication schedule, should have a good peer review process and a sound dedicated editorial board, which we all have. Ethical standards should have a clear ethics policy about all issues related to authorships and follow the COPE guidelines. Should have an ethical statement on after every article, and that is what we also practice. So this is what, and we have a consistent publication history, it's coming regularly. Now, if you look at the administrative and technical requirement, should have an ISSN number that we have, should have a DOI number, that is digital object identifier, that we have, and it should be international audience, that our journal is readable, so that we have, so it's in English language, so that's not a big issue, and it should have a good clear copyright policy, and we follow all that. So now there is a indexing cobweb. If you have seen the last slide, that sound editorial practices, timeliness, publishing history, this all we can maintain, and we are maintaining for many years. But the question comes when it comes for indexing, should have a good content or should have an indexing, and that is two-way situation. It is something like a round and round and round. If you have a good content, then they will index you. If you are not indexed, they will not, the authors will not submit the manuscript. So how, from where the good content will come? And that is what the cobweb, that is what the vicious cycle we have to break. And I think I can give you one example. In 2007, I worked for Indian Journal of Orthopedics, was not indexed, and I wrote to 80 global leaders an email that I want an article from you on this subject. Almost 10 to 15 of them wrote back that are you journal indexed? So my reply is, the next mail went that yes, it is not indexed, but I am still soliciting, because you can see that how serious I am. You can look, search my name in the PubMed, you will see that I am serious about it. So everyone submitted, almost out of 80 mail, almost 40-50 people have submitted an article, and in 2010 that journal first came into Science Citation Index, expanded, got an impact factor, later on it came into PubMed. So this is what we have to work, we together only, we have to work on maintaining a good content by your submission, and then only will be indexed. So just try to help out at this point of time. Now what is the current state? We have published the 4th issue in October. It is the October-December quarter, and the next issue will come on day 1 of the quarter. So we are ready with that. January 1, 24 to September 29, 2025, our website had 550,000 hits, and that is a very significant growth as far as the visibility is concerned. We are registered with Google Scholar, Crossref, RedCube, and Portico. The journal indexing application is currently under review with Embase, and we are likely to expect the decision in January. Now this is what is our current citation report, and you could see here this citation report, since we went online very late, so we have whatever citation reports that started coming. Out of 395 published, we have 348 citation. Average citation per year is 38.67, and average citation per manuscript is 0.88. That's pretty good. 24-25 published manuscript will citation will reflect in the times to come. Now this is what is our peer review. Our submission to acceptance was 164 days in 2024. It is now 99 days. Acceptance to publication was 141, now it is 83 days. And total submission to publication was 272 days, now it is 129 days. Our acceptance rate has come down to 14%, and which is a very healthy acceptance rate, and that suggests that we are working well as far as the review process is concerned. And this acceptance rate suggests, 14% acceptance rate suggests that we are focused on publishing top quality content. This is what is the submission. This submission was 303 in the last year. This year it's almost 256, and we are likely to touch by December 300. But I still request you all, to all members, to all fellows, that please submit more and more so that our submission increases. This is what the number of pages published, and we are constantly increasing. This year we have published over 436 pages. And this is the number of articles being published. In this year we published 48 articles, besides the task force reports which we are publishing. Last year we published 7 task force report. This year we published 6. So we are constantly improving as far as the rates. Now this is the download, and you could see that these are the taller building for all kind of download in 2025. Our PDF download, our full text download, our total download is constantly going double and triple. So summarily, ANMS has been progressively developing in past year with focus on indexing. Our peer review turn time has come down from 164 days to 99 days. That reflects the efficient editorial team. Acceptance to publication 141 has come down to 83. That shows efficiency of publishing team. And overall publication time has come down from 272 days to 129 days. So that is the 53% reduction in overall time taken from submission to publication, and that reflects our overall efficiency. Now, if you compare to 24, 57% growth in terms of downloads, and that reflects visibility. Even today, we have 8 ahead of print article on our website and 49 articles in production. So it means we have 57 articles already accepted. So we are in a very sound situation for next 2 to 3 issues, and that suggests our timeliness. And I promise that from next year, you will get the new issue on first day of the 3 months quarter. What we need support and trust of stakeholder of National Academy of Medical Sciences. Then only annals can reach to the helm of national and global recognition. Why should annals should be the most progressing journal? Because it is owned by National Academy of Medical Science, a body of most elite, decorated leaders and researchers in medical science. Our fellows and members can support many journals by their submission and reviewers. My appeal, give at least one good article, whether it is original, review and perspective, every year to annals. The journal content will improve automatically. And please review at least 2 articles per year. That's not a very big task for your parent organization. And by the time we meet next year again, we should have an index journal. Friends, it is only together, only annals of National Academy of Medical Science can achieve greater height. Single target is indexing. Thank you very much indeed for your time and patient hearing.
Thank you, Dr. Jain. Now we move on to the last session, but before that I have a few announcements to make. All emeritus professors, members of NAMS and associate members are supposed to register outside. That's very important, as that's the message that has been given to me by the Secretary of NAMS. And all emeritus professors are supposed to give their names to the Secretary of NAMS, Dr. Umesh Kapil, because there's going to be some felicitation ceremony at the end of the day, and he needs the names for that as well. And there's going to be a council meeting of the NAMS council members during the lunchtime, and that will probably begin at 1:25 p.m. So now we go on to the last session. This is the presentation by the international guest speakers. For this we have the chairpersons, Lieutenant General Velu Nair, PVSM, AVSM, VSM. He is the President-elect NAMS, and Dr. Ashok Kumar Gupta, he is the council member of the NAMS. I request them to please come up on the dais. Lieutenant General Velu Nair has already been introduced. He is the head and chief consultant, hemato-oncology and bone marrow transplantation at Apollo Cancer Center, Gandhinagar, and is the former Director General Medical Services of the Army and the President's honorary surgeon. He is the former Dean of FMC Pune and the President of the National Society of Hematology and the Delhi Society of Hematology. Dr. Ashok Kumar Gupta, he is the council member of the NAMS, and he is a Padma Shri awardee. He is a renowned plastic surgeon of India affiliated to Grant Medical College, Mumbai, and Institute of Medical Sciences, Bombay Hospital and Research Center. He's got number of awards to his credit: the Sheikh Hamdan International Award, the Queen Victoria Award, the Guzzi Peace Prize International Award, Lifetime Achievement Award in Health and Philanthropy in 2015, and that. So I request them to take over the mic, please. Thank you.
Thank you very much, ma'am, for that kind introduction. We come to the much awaited session where we have distinguished international speakers who come a long way to actually talk to us in fields where a lot of progress has been made in the last few years, and I think we are already short on time, so we will start the session immediately, and I would ask my co-chair, Dr. Ashok Kumar Gupta, to introduce the first speaker, who is Dr. Somnath Mukhopadhyay.
Hello, thank you. It's indeed a pleasure for me to introduce Professor Somnath Mukhopadhyay. I mean, he doesn't need very big introduction. He's chair of the Pediatrics and co-head Department of Clinical and Experimental Medicine at Brighton and Sussex Medical School, UK. He's a consultant pediatrician, Royal Alexandra Children's Hospital, University Hospital, Sussex, NHS Foundation Trust, UK, Fellow of the Royal College of Pediatrics and Child Health in UK, PhD from University of Dundee. He's originally from Calcutta Medical College, and after finishing his MD, he moved to UK. And I invite Professor Mukhopadhyay to share his talk. Thank you.
Thank you very much, and it's a great pleasure to be here. Can you all hear me okay at the back?
Yeah, loud and clear.
Loud and clear, that's brilliant. Thank you. So it's a great privilege to be here, and I have thoroughly enjoyed the morning session, in particularly the debate about healthcare in India, and it's so interesting to hear. And for people like us who have been trained in Calcutta, trained in India, and you've been away for 40 years, we can see the amazing change and the growth and the improvement in standards in healthcare, which is not just subjective, it's very objective, because World Bank is reporting this. It's all over the international press now. And I read an article in The Guardian that has always criticized India for the last 30 years, writes amazing articles about Ayushman project and all its successes. So it is an absolutely transformational moment, and that is why I feel so excited about bringing new technologies. In the past, we used to say, oh, these are technologies that are not bread and butter, they're not relevant for India. That's no longer the case. Every technology that is practiced, that is cutting edge across the world, is absolutely relevant for everyone in India. Precision medicine is something like this. It is of a tremendous impact across the world. The NHS says it's going to make a paradigm shift in healthcare over the next 10 to 20 years. So I want to share precision medicine with you, particularly the younger ones at the back, who are going to be the future leaders of healthcare in this country. And for those who might not be familiar with precision medicine, I'm going to take a little bit of time to talk about what precision medicine essentially means. And there are several definitions. There is one here that I just brought along from the European Union Health Ministers Council. So precision medicine is a medical model which is essentially looking at the phenotype, which is the clinical presentation, the radiological features, for example, and the other clinical aspects, and biomarkers, which again could be some of the radiological markers, but it could also be genotype, it could be molecular profile, and so on. And this is guiding individualized therapy. So the overall principle of healthcare, and we'll come to it later on, particularly for chronic disease, has been the same kind of protocol, the same kind of guidance influencing medical management, and maybe a step-by-step increase according to severity, difficulty in control. The modern system is to take more of an individualized, one-size-fits-one approach. And this has been made possible because of the Human Genome Project, because of all the progress in biomedical research. So it's something very, very important and very, very revolutionary for the future of healthcare right across the world. Why asthma? Why asthma? Well, this kind of personalized medicine, precision medicine, is practiced already for, say, certain forms of cancer. We know that. We know that's happening. But when it comes to common chronic disease that affects millions of people, it is not quite happening. It's still the very standard system of management. So that is the paradigm shift. That is when these incredible benefits coming out of the laboratory can come to the bedside. And that transformation we have to depend on the young people to bring about in the small villages in India, in the smaller towns. Now, these are some of the statistics, and I'm not going to read it because you can read them quite easily on the slide, of the magnitude of asthma, particularly the magnitude of asthma-related disease in childhood. And that is why asthma is so important. And this is the spread and the depth of asthma, is the depth of the suffering. And these are some quotes from some of our patients. And I think they show in a way that we can never capture through quantitative data. They show how powerful the impact of asthma is. And I think, again, this tells us that this is suffering that has to be relieved. And we know that even in cities like London and Leicester, where there is a relatively high quality of healthcare, we know in the NHS, they have spent a lot of money on asthma education and high-quality randomized controlled trials. For many, many years, we know that about 35 to 40% of children in a city like London still suffer from inadequately controlled asthma. So there is a problem. It's not working. Now, why is it not working is a question that we tried to begin to address about 20 years ago, slightly more than 20 years ago, during my time in Scotland. And we felt, it's not just we in that me, people who are significant, who are major experts in the field of asthma, immunopathologists who head the Medical Research Council, like Stephen Holgate, have made it very clear that the way forward is to look at molecular profiling, at genetic profiling. And naturally, when you look at asthma, one of the first molecules that you think of is the beta-2 receptor. Why? Well, the beta-2 receptor binds with the beta-2 agonist. You're all familiar with this? Medical students mostly, junior doctors mostly here? So the beta-2 receptor, which is salbutamol or salmeterol, short-acting or long-acting beta-2 agonists bind with the beta-2 receptor. Now, on position 16 of the beta-2 receptor, you can have arg-arg, arg-gly, or gly-gly. These are the three possibilities. And very high-quality laboratory tests, laboratory experiments, mainly conducted by Stephen Liggett at Yale University in the final decade of the 20th century, showed that if you have gly status, you respond better to salbutamol and salmeterol, and you respond less well if you have arg-gly, and you respond the least well if you have got arg status. These are purely laboratory experiments. Do they work in clinical practice? This is called bench-to-bedside medicine, and I'd like to strongly encourage people like you to follow this, because we hope such bench-to-bedside medicine will happen right across many areas of clinical practice, from myocardial infarction to stroke and so on, and in the context of India, of course. This shows how important the beta-2 receptor is, because the new guidelines from GINA, which is the premier asthma guidelines recommendation body worldwide, suggests that long-acting beta-2 agonists will be prescribed now to a much wider proportion of patients. So you've got a stepwise approach for the treatment of asthma. And you start with step 1 and 2, where you give as needed low-dose ICS, inhaled corticosteroid, and formoterol combination. And then you step up slowly to maintenance. Formoterol is a long-acting beta-2 agonist. So almost every patient who has got significant asthma, never mind severe asthma, will be on formoterol or a similar long-acting beta-2 agonist right across the world. So this is how important beta-2 agonists will be. I know already short-acting beta-2 agonists like salbutamol are used very, very widely, but this is going to be the future of asthma care. So this is why it's important to find out whether or not long-acting beta-2 agonists will work in all the patients. This big randomized control trial from the United States about 20 years ago, it was published in 2010, about 15 years ago, compared the effect of inhaled corticosteroid step-up, long-acting beta-2 agonist step-up, or Montelukast step-up in the management of asthma. So what essentially happens is that if you've got a child, what is essentially used to happen, and you can see it's changing now, what essentially used to happen is that you've got a child who is on inhaled corticosteroids, and then you step up treatment, and you've got 3 ways of stepping up treatment across the world. You can either step up by giving Montelukast, or by increasing the dose of inhaled corticosteroids, or by giving salmeterol. And overall, the feeling is that inhaled salmeterol is the better choice. However, you can see that most patients improve on the long-acting beta-2 agonist, which is the LABA, and which is the dark gray line. But some patients improve better on Montelukast. This bar chart is comparing the relative improvements of these different populations, and the smaller bar chart indicates that those are the patients where actually Montelukast worked better, and also there is another bar chart below that indicates those are the patients where inhaled corticosteroid step up worked better. So the important message coming out from this study is that the effect of step up is not consistent. Some patients respond better to one medicine, and other patients respond to another medicine. And why is that the case? This is what we began to investigate, and we began to look at genotype, and obviously the main clue lay in the Arch-Glide variation, which had already been demonstrated at the laboratory level. So we genotyped a large number of patients, a large number of children with asthma, and we looked at whether the daily use of a beta-2 agonist led to a greater risk of asthma exacerbations. And we found that this was happening. And this led us towards the first of the randomized control trials that we did, where we picked up only patients with R-Jarge. So these are the ones who are likely to be most affected. And we randomized them to either salmeterol or to Montelukast. And we tested the hypothesis that in this population, because they are all R-Jarge, remember R-Jarge is the population where salmeterol is less likely to work well. Remember that overall salmeterol works better than Montelukast, and that has been shown in other large randomized control trials. So we tested the hypothesis that in this population of genotypically compromised individuals, you could say, you will get a better response with salmeterol. And that is what we saw with almost every index of lung function and symptom measurement that we looked at, that we assessed. This was a small trial. It was an artificial trial with just R-Jarge patients. So we moved on subsequently to do large randomized control trials where we assessed the use of personalized therapy versus standardized therapy as we normally treat in the NHS or in any other place where we don't do any genotyping, and we prescribe according to primary care choice. And again, we found that in our study, after follow-up for about a year or so, and I'm not going to go into the details because of the constraints of time, we found that there was a consistently better set of clinical outcomes with using personalized therapy, where you prescribe salmeterol if the genotype is favorable, and you prescribe montelukast if the genotype is not right, and you know salmeterol is not going to work. And this led to a meta-analysis of data from the UK and the Netherlands, where we showed that there was a clear effect on the rate of asthma attacks in this population as well. So I'm going to skip the next few slides and just go to the final slide. Well, maybe the slide just before the final one, just to make the point that I have told you the story of beta-2 receptor genetics. However, there are many other similar genetic stories which we can talk about. And the vision for the future is for a genetic panel which could lead to a much broader profiling of patients and a much more clearly demarcated system of personalized care for our children with asthma. Thank you.
Thank you, Professor Mukhopadhyay. Thank you very much.
That was so nice and relevant, especially for a country with the air quality being what it is in many parts of our country. Please take a seat. Yeah. So we come to the next two speakers, which is going to be on actually myeloma, and they are the doyens, I know, who are the leading experts globally, and over the years we have learned so much from them, and they've come all the way to share what they are doing on two frontiers with us today. So the first speaker is Professor Vincent Rajkumar, who is an alumnus from CMC Vellore, and he went on to do his residency from North Dakota, and then did his residency and fellowship in hematology and oncology from the Mayo Clinic. And he, besides that, has been bestowed with a whole lot of awards and various, prestigious journals which he heads as editor-in-chief and members. And believe it or not, he's got an H-index of 183. So, and he has got over 520 peer-reviewed publications. So it's the way you view the H-index that matters, I think. And he is hugely, into an avid researcher, very practical approach, and I think he has been very helpful to the Indian myeloma workers. We have an Indian society called the Image, which he and the next speaker, Dr. Shaji, have been instrumental in helping us actually put in place, and we are nearly 10 or 11 years as a society. And he's actually going to talk to us today on actually the paradigm changes in myeloma, a model for cancer research. Everybody in India says cancer बढ़ गया है. It's more cancer सब जगह ज़्यादा हो रहा है. Not knowing that, we live longer, the environment is not so kind to us anymore. So what is happening in form of mutations, God alone knows. And obviously we pick up things earlier and you live longer. And when you do all these variables, you're bound to be having more mutagenesis. So with that, I won't stand between you and Professor Vincent. The stage is all yours. Vincent, please.
Thank you so much. Really an honor to be here. And I really want to thank Dr. Nair for inviting me. Yes, I am a product of India. I did my medical training at CMC Vellore. This is my first trip to Chandigarh. I've always wanted to come here. A lot of my friends back home are from here. And it's also great that my colleague, Dr. Shaji Kumar, is here. And he and I are partners in crime. We work together. A lot of what I'm going to say is work that the two of us have done together. I know it's a mixed audience, so I won't go into the details of the cancer that we both work on. It's called multiple myeloma. Multiple myeloma is a cancer that affects probably 30 to 40,000 people in the US each year. In India, it's probably much higher than that. When I entered the field, the survival of multiple myeloma was only about 2 to 3 years median. Today, the survival is probably more than 10 to 15 years. And I've been glad to be part of the progress and witness this progress from the front seat. So what I wanted to share with you is at least many lessons that I learned in this journey of how a cancer goes from a 2 to 3 year median survival to a 10 plus, 15 plus year, probably even a curable condition. And these lessons, I hope, would give you some insight into whatever field you're working on, whether it's cancer or other areas. The first one is drug discovery. As we just heard, one of the main ways of drug discovery is bench to bedside. That's the classic. You have to understand the disease, and then you find the treatment that overcomes that problem. The second way that pharmaceutical companies are really good at is, once you know one drug through the bench to bedside, they can then make similar drugs which have higher efficacy, lower side effects, like ibuprofen and then naproxen, or omeprazole and then pantoprazole, and so on. The third way that scientific progress happens, which I've been fortunate to be part of, is just pure serendipity, just chance. If we keep our eyes open, we may find things. And we have to not only keep our eyes open, but also be receptive to suggestions. And that starts with the age-old drug called thalidomide. Thalidomide was first discovered in 1954 in Germany. It was first synthesized in 1954. Later on was used as a sleeping pill, was promoted as probably the most safe, effective sleeping pill for women, particularly women who are pregnant and suffering from the nausea of the first trimester of pregnancy. But we know what happened. Thalidomide caused significant teratogenicity, and more than 10,000 infants were born with phocomelia, deformities of the limbs, and was taken off the market. But thalidomide never went away. Thalidomide stayed on. It was used for many different conditions, including leprosy, graft versus host disease, Behçet's disease, and so on. And then in the 90s, Dr. Judah Folkman hypothesized that the reason thalidomide caused the teratogenicity was because it was anti-angiogenic. It was targeting growing blood vessels. And his hypothesis was that if you could exploit something like that in cancer, target the blood vessels, using thalidomide and other drugs as anti-angiogenic therapy, then you could treat cancer. Here's a picture of me with Dr. Bart Barlogi, who listened to a patient who came to him with this idea, hey, Dr. Folkman thinks that you can use anti-angiogenic therapy to treat cancer. My husband, who's a physician, has cancer, multiple myeloma. Can you please try something anti-angiogenic because all the other treatments are not working? And Bart Barlogi listened to the patient and the wife, and he went on to use thalidomide, and thalidomide produced dramatic effect in patients with multiple myeloma. It was the first drug to show activity in a cancer like myeloma, in multiple myeloma, in over 50 years. Thalidomide's effect was then published in the New England Journal of Medicine. My role was very small. I investigated the role of angiogenesis in a blood cancer, which seems counterintuitive, and showed that angiogenesis was indeed increased in multiple myeloma, and then went on to lead the trial that got thalidomide FDA approved for the disease. Both lessons are important. You need the serendipity to find the drug, and then of course you need to do the randomized trials to prove that it actually works to get the drug approved. Today, thalidomide is not used as much for multiple myeloma, but we have two analogs of thalidomide, lenalidomide and pomalidomide, which are the real foundations of myeloma therapy and have played a huge role in why we have seen the improvement in survival. The second is also another lesson that I learned, which is you can have drugs that work, but if you don't optimize them, you might get results that are not as good. This is Michael Katz, a patient with multiple myeloma who was a patient advocate with me on my Eastern Cooperative Oncology team. And a patient with multiple myeloma, he told me the dose of steroids. We use a lot of steroids in the treatment of myeloma. As you know, steroids are toxic to lymphocytes and plasma cells. And he told me that if you're going to use steroids at this dose, you're only going to hurt patients. And this is how we have done. Patients are suffering. But now that you have some new treatments, why don't you try and see if you can lower the dose of steroids so that you can reduce the side effects for the patients and still get the same benefit. So thankfully, we listened to him. We listened to him, went on to do a trial with 400 plus patients, randomized controlled trial, that compared patients with multiple myeloma who got high dose of dexamethasone versus low dose of dexamethasone. All we wanted to show was that by using a lower dose, we can reduce the side effects. What we found, though, was that the lower dose was associated with significantly better survival. We could save almost 10% of myeloma patients in the first year alone by using a lower dose of steroids. So sometimes these insights come to you from patients, and listening to patients can help you identify problems that you may not find a new drug, but you can certainly make a drug work better, and you can certainly improve the life span and life and the quality of life of patients. The third thing that I've been witness to has been that we have many conditions for which the definition of the disease is already set by somebody before. Whether you take rheumatoid arthritis or lupus erythematosus or cancers, you have a list of criteria, and these criteria are not written in stone and they are subject to change. When I joined the field in multiple myeloma, it was the only cancer in which you couldn't call it a cancer unless you actually had symptoms. Other cancers like breast cancer, colon cancer is just a pure pathologic diagnosis. A pathologist tells you this is adenocarcinoma and that is it. However, with multiple myeloma, you need to show that the patient actually had renal failure or lytic bone lesions. And that is a problem because it's okay not to treat patients when they're asymptomatic, but if they have a real cancer, you cannot wait. And it also means that while we don't want patients to get renal failure or lytic lesions or compression fractures, we cannot prevent that if we are going to insist that those end organ damage symptoms are needed to make the diagnosis. So I was part of an international effort by the International Myeloma Working Group to change or completely revise the diagnostic criteria for multiple myeloma so that we could prevent these things from happening. And what we did was we added 3 biomarkers, which I've shown in the blue font on the right side, and said that if these biomarkers are present, even if you don't have symptoms, even if you don't have end organ damage, it can be called myeloma. This effort was led by Dr. Dury as well, Dr. Brian Dury. I want to recognize him because Dr. Dury just passed away. He is one of the pioneers of multiple myeloma. We have the Dury-Salmon staging, and both Dr. Kumar and I have been very fortunate to work very closely with Dr. Dury for 30 years. It was a big loss that we lost him last month. But this paper, the International Myeloma Working Group revised criteria for myeloma, was published in 2014. It has already become the most cited paper in the field with more than 5,000 citations. I was fortunate to lead this effort, and it has really made an impact for how we treat our myeloma patients. The next step is early intervention. For many cancers, the hypothesis is that if you treat early, you will get better outcomes than waiting and treating. But that's not always true. For example, if you take chronic lymphocytic leukemia, if patients have CLL but no anemia and no thrombocytopenia, that's still considered something that we should just watch. Watch because treatment could cause more harm than trying to than doing nothing and waiting for the anemia to happen. And the paradigm is, if you want to treat early, you need to prove that early treatment actually is better than waiting and watching. In multiple myeloma, we have a condition called smoldering multiple myeloma. And smoldering myeloma was coined by my colleague at Mayo called Dr. Bob Kyle. And it was considered to be something like an intermediate stage between the benign polyp-like monoclonal gammopathy and the full-blown multiple myeloma. What we then hypothesized was, based on a lot of data, is that smoldering myeloma is actually not in between stage, but really it's comprised of two groups of patients. So if you take 100 patients, some of them are just benign and some of them are full-blown malignancy. You just don't know who is who. And that's probably why we had mixed results. This is a study actually led by Dr. Kumar, where he found that you could identify these malignancy, the fire type of patients, by using a classification, the Mayo 2018 20-20 system. I won't go into the details, but by using biomarkers, we can identify these patients who have the high risk smoldering myeloma and who are probably the ideal people to intervene, to try and see if early intervention in a cancer like myeloma can improve overall survival. I've been part of many, many trials for smoldering multiple myeloma, but two of them that I'll highlight was the ECOG trial that was co-led with me by another physician of Indian origin, Dr. Sagar Lonial. Dr. Lonial's study showed that high-risk smoldering myeloma, if you use just lenalidomide, the analog of thalidomide, you could improve outcome. Last year, we used daratumumab, and this is an international trial that showed improved progression to myeloma as well as improved overall survival if you use daratumumab early. Just yesterday on my way to India, I found out that the FDA approved daratumumab as the first ever treatment for smoldering multiple myeloma in the world. And this again, the lesson I learned is you need to hypothesize that early intervention is important, but you also need to do the hard work to prove that that is indeed the case through the help of randomized controlled trials. If you know that early intervention works, the question is, how are you going to find these patients if they're asymptomatic? Can we screen them? Screening is a very, very high bar, and so we are recommending screening only for patients who have high-risk features. There is a study going on in Iceland where they're randomizing the whole of Iceland to look at whether early screening can save lives. Right now, we know that there are some high-risk groups like patients who are African American, patients who have first-degree relatives, and these people have high risk of having the precursor stage, and this is the group that potentially we can target for screening. I'll close with the last two slides. One is that we are starting to hypothesize, Dr. Kumar and myself, along with many others, that myeloma may not be one disease and that it may be multiple diseases. And we have classified this, that this is no longer myeloma, but probably multiple myelomas. And we hope to take this concept forward. And this is a paper that we wrote together in Nature Reviews. And again, willing to challenge the paradigm. The path to cure, I think, for multiple myeloma might be by using already existing drugs. We have a huge number of drugs that are available. We want to be able to use these drugs effectively in a combination, effectively at the right dose to try and see if we can cure it. Another way is to do cure by early intervention. And again here, one approach that we've taken is to take high-risk smoldering myeloma and treat it aggressively to try and see if in a year or two of aggressive therapy we can cure it and prevent the myeloma from happening once for all. The final thing is that all of this is not possible by one person. It's a huge team effort, and usually it's a huge international team effort. And mentorship. I have been fortunate to work at the Mayo Clinic where we have more than 30 people who are interested only in multiple myeloma. Fortunate to work with stalwarts in the field. Here are 6 of us, all of us of Indian origin, and we are very active in this disease, and each of us help each other out. And this is my mentors here, Dr. Nikhil Munshi, Jesus San Miguel, Bob Kyle, and Ken Anderson, photograph taken at the myeloma workshop several years ago in New Delhi. Thank you so much.
Thank you very much. That was such a comprehensive, wonderful lecture. It was like a story. You just sang your way through. That was so good. But this disease, when I was training, was a killer disease, 2 to 4 years. Overall survival around 3 years. Now we are talking of a PFS of 10 to 15 years. And so we're moving, towards a chronic disease, towards cure, which is amazing. And I think the tools available today, the topic was not to cover that, but the next talk you will hear that how immunotherapy has been innovatively used to strengthen your own immune system to actually clear your cancer. So actually the next speaker we have is Shaji Kumar, whose name Dr. Vincent has already referred to a few times, who is a graduate from All Institute of Medical Sciences, Delhi. And he did his internal medicine and then also a rotation in the Rotary Cancer Center before moving on to Rochester Mayo Clinic, where he did his residency and fellowship in hemato and oncology. And as a matter of fact, he also has extensively published over 900 publications, over 150 H-index, and he heads many various bodies in the field of myeloma as a chair or as a vice chair, and also has contributed very handsomely to helping his Indian colleagues here, bringing it back here. They both have done so much, and I want to thank on behalf of not only Image, our country, what you've done for India. So keep doing it, please. So with that, I would ask Dr. Shaji to actually talk on the next part, which is immunotherapy for multiple myeloma. Is this the final frontier towards cure? Maybe, maybe not. Let's hear the story. Dr. Shaji, please.
Thank you, and good afternoon, everyone. I would like to start by thanking Dr. Velu Nair for the opportunity to be here this afternoon. And it's indeed an honor and a privilege to be here. And it's really a hard task because I'm the only one standing between everyone and lunch, and even harder because it's a difficult task to follow Dr. Rajkumar. But what I'm going to try and do the next 15-20 minutes is to talk about how the immunotherapy is probably going to change the face of myeloma as we know it today. Dr. Rajkumar nicely went through how much we have learned about this disease over the past 3 decades, and understanding the biology obviously is critical to improving the therapy for this disease. And we have gone from a disease where we always told patients that this is uniformly fatal, median overall survival of 3 years, to where we are today, and hopefully a cure tomorrow. So these are my disclosures. So when you think about the treatment paradigm in multiple myeloma, we already heard about the diagnosis, the risk stratification, but the treatment itself, the major part of what we do for myeloma patients comes as part of the initial therapy of multiple myeloma. The way the disease behaves today, these patients all have the disease come back, and they go through multiple relapses, all of which are managed through a series of different treatments using the different tools that we have available. But the focus has, for a long time, has been how can we optimize the upfront treatment of multiple myeloma? Can we treat patients to a point where the disease just won't come back and we will never have to deal with it again? And to understand that, we have to start from where we were 3 or 4 decades ago, when we only had melphalan and prednisone or steroids for treating these patients. And this is a meta-analysis of large randomized trials done that was published back in '98, showing that the median overall survival at that time with the best treatments available was 2.5 years. And then came some of those new drugs, especially the immunomodulatory drugs that Dr. Rajkumar talked about. And we have, over the years, have understood how these drugs work. It was certainly serendipity that led to us to identify thalidomide as a treatment, but the scientific studies since then have told us how this drug works, which have in turn allowed us to create new molecules which work much better. Same is the case of bortezomib, which is the first proteasome inhibitor that was approved for treatment of multiple myeloma. And again, a way of garnering the power of a intrinsic biological system to try and treat the disease. And this led to the development of this three-drug combination called VRD, where we use the combination of a proteasome inhibitor and a immunomodulatory drug to actually really improve the outcomes of patients with myeloma. So we went from an overall survival of 2.5 years to using these 3 drugs in combination with a progression-free survival that is about 3 to 4 years, and an overall survival well in excess of 8 years. But clearly, as you can see from these curves, patients continue to have the myeloma come back after the initial treatment. So the question is, how can we make it even better? And we know that from multiple studies that myeloma, we have made significant progress across the all spectrum of the patients in terms of age, the underlying risk characteristics, and to the extent we can actually say that older patients with standard risk disease can actually live as long as a person without multiple myeloma. But unfortunately, that's only a small proportion of patients. And what we really want to get to is to actually provide that kind of an outcome for every patient with multiple myeloma. So there is still a lot more work that needs to be done. So this is a study that we did a few years ago where we looked at the outcomes of patients with other common hematological malignancies, Hodgkin lymphoma, diffuse large cell B-cell lymphoma, follicular lymphoma. If those patients actually survive for 3 years, their risk of the cancer coming back is relatively low. Unfortunately for myeloma, that was not true. And the question is, how do we get myeloma to behave the same way? And I think that's where the immunotherapy comes in. And the immunotherapy is important not just because it is harnessing the patient's own immune system, the fact that it's highly effective, but most importantly from the setting of a country like India, it actually enables us to, again, we'll hear about it from the point of view of CAR-T, we can actually do this in every part of the world and improve the outcome of patients with disease. So let's start off with the naked antibodies. That is where we started off from, and we learned that we can combine these monoclonal antibody, the anti-CD38 monoclonal antibody, with that 3-drug combination, the VRD regimen we talked about, to create a quadruplet regimen that actually can improve the outcomes of patients. So this is extrapolated data from some of the more recent phase 3 trials that have been done, looking at the 4-drug combination for patients with newly diagnosed myeloma. And as I said, this is a projection at this point because these trials are not mature enough, but we are looking at a projected progression-free survival of about 18 years. It may not pan out to be 18 years, maybe it will be 12 years. But think about the fact that we went from a 2.5-year overall survival to a first-line therapy, keeping your disease under control for 12 to 15 years. And that is a dramatic progress over a 3-year period. And these are patients, younger patients who can go through a stem cell transplant. Even if you cannot get a stem cell transplant, and you're older patients, then these are patients who often don't do as well as the younger patients. You can see even here the projected progression-free survival is about 8 years, which is again a lot longer than what we had before. Now, as I said before, these patients often tend to relapse. Now, what can we do when the patients relapse and become refractory to these different treatments that we have? And one thing that we have learned over the years is, of course, we know that already the cancers are often smart. They are able to evade the therapies that we throw at them. And this is true even for multiple myeloma, where we have seen that when we use multiple treatments over years, each of the treatment eventually becomes ineffective. And there are a lot of elegant biological studies that have been done that have shown that this happens because of the genetic modifications that happens in the tumor cell, allowing those clones to become refractory to the therapy. And we know from these studies that these original clone that probably contributed to the demise of the patient was present at baseline and gradually became the dominant clone. And we have done a lot of natural history studies trying to understand how do patients' disease behave once they become refractory to some of these common medications that we just talked about. And the overall survival for patients, once they become refractory to the proteasome inhibitors, the immunomodulatory drugs, it is often less than a year. So what can we do for these patients? So that's what some of the newer immunotherapies, and we'll talk about the antibody drug conjugates, and this is a mechanism that has been evaluated in a variety of different cancers. So in the setting of multiple myeloma, we know that we can use antibodies that are conjugated to toxins that target a molecule called B-cell maturation antigen that's universally present on the myeloma cells. So there's a medication called belantamab mafodotin that was recently approved for treatment of myeloma and is approved across the globe for treatment of relapsed disease. And this is a drug that is quite effective, and in fact as effective in the sense that it is even more effective than the drugs that we just talked about, like the monoclonal antibody daratumumab and some of the immunomodulatory drugs like pomalidomide. And in head-to-head phase 3 trials, it has shown to be much more effective. So again, we are trying to incorporate the ability to use immunotherapy in this disease to improve the outcomes. But I think the area that has really made a dramatic difference for this disease is our attempt to harness the T-cell based immunity in patients with multiple myeloma. For the longest time, the belief was that the immune system is so badly compromised in myeloma that there's very little that we can do to improve the innate immunity in patients and improve the cancer control. And we have, in some form or fashion, been using the T-cell based immunity by, for example, by using allogeneic stem cell transplant in this disease, which is in a way a crude way of using T-cell based immunity, but obviously comes with a lot of side effects and toxicity associated with that. People have tried in solid tumors, tumor infiltrating lymphocytes by harvesting them and then reinfusing those cells after expansion, and has been shown to be effective in certain cancers like prostate cancer. But what we have and others have done in this field is to try and create CAR T cells, which are basically chimeric antigen receptor T cells, where the T cell receptor is modified in a way that it can target one of the antigens of interest on the tumor cells. So we have the CAR T cells, there are at least 2 of them that is approved in the clinic today, and many more that are going through clinical trials. And it's a very elegant design, and if you think about it, basically you are using the T cell receptor that has been modified to target a tumor antigen of interest, and you have basically a intracellular signaling domain that basically sets into action the activation of the T cells, which then lead to the tumor cell death. So if one of the very first CAR T cells that are available for treatment in the clinic was cilta-cel, and when you think about the patients who went on this trial, all of them had about 5 lines of therapy, all of them were refractory to all available treatments, and if we were to continue to use the treatments we had before, their survival would have been less than a year. And here we can see that the CAR T cells actually cause a response to the disease in almost 95% of these patients, and the majority of them actually very deep responses. This PET scan can tell what words can't. On the left-hand side, you can see somebody whose PET scan is vividly positive because of extensive disease, and 30 days after receiving a CAR T cell, you see a PET scan that is completely negative, again highlighting the power of the immune system. In fact, some of the earliest studies that have been done with these CAR T cells show that almost a third of the patients, despite having stopped responding to all the previous therapies, are now treatment-free for 5 years plus after having received a CAR T cell therapy, and almost 5-year median overall survival for a group of patients where the expected survival should have been under 1 year. So clearly the CAR T cells are making a significant impact in this disease. And the reason why the CAR T cell is important, because it is a technology that can be implemented across the globe. In fact, there are several CAR T cells that are currently in development in India by several institutions like IIT Mumbai, as well as several companies. And I think this is actually going to change, I think, the face of myeloma treatment in India as well, because the cost of CAR T cell in India is a fraction of what it costs in the West. And there's continuous work that is going on trying to see if we can actually enhance these CAR T cells even better by incorporating more domains into or co-stimulatory domains, or by making these T cells even secrete some of the cytokines. And there's also ongoing work trying to see if we can take normal T cells from a healthy donor and try to enhance their activity as well. Finally, I think the class of bispecific antibodies is something that I think will also change the face of myeloma therapy, because unlike CAR T cells, the bispecific antibodies can be administered in smaller hospitals and don't need a cell therapy facility as the CAR T cells would need. And we have again several bispecific antibodies that have been approved, and many that are being tested in clinical trials with technology that's going to make it much more safer and much more easier to administer with increasing efficacy. But the principle behind bispecific antibodies is very simple but very elegant. All we're taking is a naturally occurring antibody and modifying it or changing it so that it actually has 2 specificities, one for a tumor-associated antigen and one for CD3 that's on these T cells, essentially playing the middleman by bringing these 2 cells together and leading to the tumor cell death. We have a BCMA-targeted bispecific antibody called teclistamab that has been approved. Again, you can see that almost 2/3 of these patients actually respond to treatment when none of the other available treatments actually work for these patients. And these treatments often last for a year or more. We have another one called talquetamab that is targeting a very different antigen on the myeloma cells, but also produces very similar results with almost 2/3 of the patients responding to the treatment. So thinking about this as a platform, we have several new bispecific antibodies that are being developed. And the efficacy of this is being enhanced by adding them together. This is a study that looked at combining these two and leading to a response rate of almost 95%. What has been really remarkable is that these bispecific antibodies can be added to the traditional therapies, and here's the results, early results from a trial where newly diagnosed myeloma patients were treated with the bispecific antibodies in combination with those three drugs, the anti-CD38 monoclonal antibody, the proteasome inhibitors, and the immunomodulatory drugs. And now you can see that newly diagnosed myeloma patient can get a 100% response rate, but most importantly, almost 100% minimal residual disease negativity. But we still have a lot of questions that need to be answered, but what we have witnessed over the past decade has been almost nothing short of a miracle, because we are seeing a disease that was always being coined as incurable to a place where we definitely can say it's become a chronic disease. And I think we are at the cusp of saying that this is going to be cured, and I'm sure we will see that in the next decade. But there are many studies that needs to be done. We need to do additional studies to see how can we optimize the treatment with these immunotherapies. Should we be using a CAR T cell first? Should we be using a bispecific antibody? Should we be using them one after the other? Do we combine them? And are there certain stages at which we need to intervene with one versus the other? We already heard about the early interception strategies, and we are starting to do clinical trials with bispecific antibodies and CAR T cells in patients with high-risk smoldering myeloma, with the hope that maybe we can nip the disease in the bud, and that the one-time treatment with a CAR T cell or a limited duration treatment for a year with a bispecific antibody will eradicate the clone, and the patient will never have to worry about myeloma. So that's our hope for the future, but I think we are almost there, and it's just a matter of time. Thank you.
Thank you very much, Dr. Shaji. So you heard fiction being converted to a real story. So, this sounds like the T20 team. We have 5 batsmen vying for 2 opening slots, and only 2 get to play. And here we have so many tools available to us, and you heard Dr. Shaji and Dr. Vincent saying, is it sequential or is it tandem or is it simultaneous? So we got so many tools and players available to play with that yours seems round the corner. And I'm sure you all are going to give that soon. And you'll be happy to know that many of these things are already available in India. So the bispecifics we are using. CAR T cells for myeloma, trials are on. For ALL and for NHL, lymphomas, we are already using it. It's now available in the market. We are actually using it. Most of us have already used it. So I think we are keeping pace, but they're always a step behind for various reasons. But with the help of collaboration and communication, this is bridged, and bridged to a very practical level where we can actually make an impact on outcomes. So with that, I've got all of the speakers here. Madam, I just want to ask in the audience, anybody wants to ask a question or a quick comment, you're most welcome. The speakers are all here.
Comments are only very nice presentation, and it gives me a lot of pleasure, and I feel proud that our Indians are doing so well over there.
Can we have a round of applause on that, please?
I have got a lot of my students and colleagues in Mayo, and all of them are doing very good. Keep up the good work.
Thank you, sir. Thank you, sir. So if there are no questions, I won't stand between us and lunch.
So we move on to the felicitation ceremony.
Thank you very much, all of you.
So
Thank you very much.
The chairpersons to felicitate the speakers. Dr. Somnath Mukhopadhyay. Dr. Vincent Rajkumar. And Dr. Shaji R. Kumar. I would request Dr. Meenu Singh, Director AIMS Rishikesh, to kindly come up on the stage and felicitate the chairpersons, please. Dr. Ashok Kumar Gupta. Lieutenant General Velu Nair and Dr. Gupta. Thank you, ma'am. And thank you, everyone. The lunch is ready just behind in the lawns. So you can move out there now. Thank you, everyone, for your patient hearing.
Yeah, come. Very. Come, please come. Come, man. Come, Vincent, take a photo, all of us. Come. Very. Yeah.
Dr. Shikhir Malhotra, please come forward. Dr. Supriya Thakur, please come. You can come in first few rows, okay? Dr. Puneet Kumar Shah, please come forward. Dr. Shah, please come here. Dr. Namrata Makkar, okay, fine. Dr. Amtoj Singh Lamba, sir, please आगे आ जाइए. Dr. Kaushik Mahajan, okay, you are also there. Dr. Patel, sir, आप इधर आ जाइए please. Dr. Preeti, Dr. Preeti, please. आप आ जाइए. Dr. Mandeep आए, उनको भी आगे बुला लीजिए. Dr. Bindu Bright, Dr. Bindu, हाँ, please आ जाइए. Sorry, Binu, Dr. Binu, please come. Dr. Tiwari Shani, आप ही?
ग्रीन वाली उधर.
अच्छा, ओके. Dr. Hardik Sharma, please. आ जाइए, आगे आ जाइए प्लीज. Dr. Aman Thakur, Dr. Aman Thakur, Dr. Aman Thakur, काट दो फिर इसको.
नहीं काट नहीं दी.
गोल कर
साइन किया है, गोला कर लो.
Dr. Vinod Kumar Sharma, ठीक. Dr. Dibya Jyoti Pathak, हाँ सर आगे आ जाइए प्लीज. Dr. Sakshi Negi, Dr. Sakshi Negi, please. आगे आ जाइए. Dr. Sherry Banerjee, please come. Dr. Anshul, please. Dr. Anshul, नहीं है, इनको भी गोला कर देते हैं. Dr. Khushbu Chauhan, आगे आ जाइए मैडम. Dr. Ajit Solanki,
साइन नहीं है ना.
अच्छा ये नहीं है, छोड़ दो, गोला कर दो. Dr. Ritu Kalra, please, okay. Dr. Pragya Ahuja,
ये भी नहीं होंगी.
काटा कर
गोला
दो.
कर दीजिए.
गोला कर. Dr. Suhas Murli, आ जाइए.
इन्होंने गाउन कैसे ले लिया?
Dr. Chakrabarti, Subodh, क्या नाम है? Subodh Priya Chakrabarti, please. Dr. Subodh Priya.
गाउन के लिए मना करो.
हाँ, अच्छा आगे आ जाइए सर. Dr. Subhash Das, सर आगे आ जाइए प्लीज. Then associate members, Dr. Ranjan Kumar Behra, हाँ डॉक्टर साहब आगे आ जाइए प्लीज. Dr. Mohit Dhingra, ठीक है. Dr. Kamalpreet Kaur, Dr. Kamalpreet, Dr. Sarath Kumar, please. Dr. Sarath Kumar, Dr. Ratan Singh, Dr. Somdat Patra, Dr. Sarath Kumar, is he here? Dr. Sarath Kumar, thank you. आप आ जाएंगे तो Dr. Kaushik Mahajan. Dr. Kaushik Mahajan. Up. Dr. Aman Thakur. Dr. Aman Thakur. Dr. Anshul. आप आगे आ जाइए.
आ रहा है पक्का कि थोड़ा और इधर करो इसको जो बंदा यहाँ खड़ा है उसके पीछे ये आना चाहिए. उसको थोड़ा सा इधर करिए, थोड़ा सा इधर करिए। फिर तो ज़्यादा हो जाएगा इधर। ओके, अब वो टेबल नज़र आ रही है। जाओ, छोड़ो ना, तो उसके बुलाओ उसे।
Good afternoon and namaskar to all of you. Our most sincere apologies for delay in starting this program. There was a council meeting and we had some discussions which continued more than what we thought of. So hence there is a delay over here, and again my most sincere apologies. So this session is essentially we have kept to show our respect and recognition to our colleagues who had joined the NAMS family after completing their DNB examination, and as per the rules of the Government of India, we honor them by conferring them member of National Academy of Medical Sciences. So we have about 30 of MNAMS members who will be joining us. So I'll be saying one name each. So all of you should come and receive the scroll from the President, Dr. Digambar Bhera, and our Vice President, Lieutenant General Velu Nair. Yeah, okay. He's the President-elect, Dr. Lieutenant Velu Nair. So, with your permission, sir, I can start the proceedings, and I'll request both of you to come here. So the first is Dr. Ritu Mittal. Dr. Ritu Mittal, are you around? Please. Second is Dr. Tina N. Varghese. Third is Dr. Shikhir Malhotra. Fourth is Dr. Supriya Thakur. Congratulations. Fifth is Dr. Puneet Kumar. Sixth is Dr. Namrata Makkar. Seventh is Dr. Amjot Singh Lamba. Congratulations. Welcome to the NAMS family. Thank you. Dr. Kaushik Mahajan, please. Dr. Patel Keval Arvind Bhai. Dr. Preeti. Dr. Mandeep. Dr. Binu. Dr. Bindu Bright, Dr. Tiwari Ashani, Dr. Hardik Sharma, Dr. Aman Thakur, Dr. Vinod Kumar Sharma, Dr. Deba Jyoti, Dr. Sakesh Negi, no sorry, Dr. Sakshi Negi, Dr. Shairi Banerjee, Dr. Anshul, then we have Dr. Khushbu Chauhan, Dr. Ajay Priya Solanki, no sorry, he is not here, Dr. Ritu Kalra, Dr. Suhas Murli, Dr. Subho Priya Chakravarti, Dr. Shubha Das. That's okay.
डॉक्टर मनदीप शर्मा का नाम एक बार और कर दीजिए, इसको डमी देंगे।
हो गया सबका?
एक मनदीप शर्मा का।
Dr. Mandeep Sharma.
खत्म हो गया, मैं ये ले लूं।
अभी one more. So all the DNB pass candidates are welcome to the NAMS family, and we request you to contribute to the NAMS academic activities. We are most grateful to you for your initiative and coming all the way to Chandigarh to receive your scroll. Now, we have another group of people who have, we started a new family member that was done last year. All the colleagues who have passed out their MD or MS examination, they are entitled to become associate member. And these associate members, they can fill up the form, online form, and then they can become the associate member. We have 4 of them who have come and selected or elected or opted to come over here. First we have Ranjan Kumar Behra. The second we have is Dr. Mohit Dhingra. Fourth we have Dr. Sharat Kumar. Then we have Dr. Som Dutt Patra. Congratulations.
सर इसके बाद आप बोलिए अगर कोई और प्रेजेंट है तो बता दें।
इसके बाद क्या एक्टिविटी है?
अब हमारी रिहर्सल वगैरह होगी ये बता।
Anybody else who is eligible to become MNMS member, his name has not been shared, or anyone who has been here for the associate membership, please raise your hand so that we can include. Yes, sir. Aye. What's your good name, sir? Aye. are, ma'am?
I'm Dr. Rekha Dutt.
And your DNB pass?
No, I'm MD pass.
Then your now, after this event, we are going to have the practice or mock drill for the convocation. As you all know, we are going to have governor as much we want. Okay. So please help me with the convocation mock rehearsal. So I would suggest that all the fellows
साइड पे खड़े होकर डायस पे
Dr. Murgusen? Yeah, okay, sir.
Good evening, everyone. There are a few announcements, please. There's a request to keep your mobile phones on the silent mode during the convocation ceremony. Second is, as soon as the academic procession arrives, everyone would stand at their respective seats. Thank you. As the host institute, PGI, we would like to play the PGI anthem. Kindly cherish it. Thank you so much.
Pani sa sa sa, pani re re re, pani sa sa sa, ga ma pani sa sa sa, pani sa sa sa, pani re re re, pani sa sa sa. आशाएं जीने की मन में जगाए, असीम ज्ञान की धारा बहाए, आशाएं जीने की मन में जगाए, असीम ज्ञान की धारा बहाए, शिक्षा विज्ञान और स्वास्थ्य का ये सेवा संस्थान हमारा,
दीक्षा भी है यहाँ शोध भी, कर्तव्य का है बोध भी, भारत के हर एक प्रांत से आए हुए हैं हम सभी, हर शख्स यहाँ जो आया है उसे रोग मुक्त कराया है, जीवन यहाँ अनमोल है, सभी की आस संजोया है, सभी की आस संजोया है। विश्व कल्याण सर्व मंगलम उद्देश्य है हमारा, संकल्प है संस्थान का, लहराएंगे परचम। हम हैं PGI चंडीगढ़, हम हैं PGI चंडीगढ़, हम हैं PGI चंडीगढ़, हम हैं PGI सेवा
The chief guest has arrived, so shortly the academic procession would enter the hall. Kindly stand up. Kindly applaud. A very good evening and a warm welcome to everyone present. it is my proud privilege to extend a heartfelt welcome to our distinguished dignitaries. Chief guest, Professor Ashim Kumar Ghosh, Honorable Governor of Haryana. Guest of honor, Dr. Vinod Kumar Paul, Member Niti Aayog. First Lady of Haryana, Mrs. Mitra Ghosh. Dr. Digambar Behra, President, National Academy of Medical Sciences. Professor Vivek Lal, Director, Postgraduate Institute of Medical Education and Research, Chandigarh. Lieutenant General Velu Nair, President-elect NAMS. Professor R.K. Ratho, Dean Academic PGI. Secretary NAMS, Professor Umesh Kapil. Our esteemed guests, respected faculty members, and dear colleagues of PGI. On behalf of the Institute's Function Committee of PGI, and as a privileged fellow of the National Academy of Medical Sciences, I, Professor Ashima Goel, take great pride in welcoming you all to the 65th Convocation Ceremony of the National Academy of Medical Sciences, India, being celebrated here at the Postgraduate Institute of Medical Education and Research, Chandigarh. The National Academy of Medical Sciences, India, established in 1961, is a premier institution dedicated to advancing medical education, research, and excellence in healthcare across the nation. Through its fellowship programs, academic activities, and policy contributions, NAMS India serves as a vital platform for promoting collaboration among medical professionals and upholding the highest standards of medical science and public health in the country. We have gathered to recognize the dedication, perseverance, and outstanding achievements of medical professionals across the nation, individuals who continue to strengthen the foundation of healthcare and medical science. Before we proceed further, let us invoke the divine blessings of Ma Saraswati, the goddess of knowledge and wisdom. May I request the Honorable Chief Guest, Guest of Honor, Madam Mitra Ghosh, and other dignitaries on the dais to kindly light the ceremonial lamp. May I now invite Professor Vivek Lal, Director, Postgraduate Institute of Medical Education and Research, Chandigarh, to deliver the welcome address and introduce the Honorable Chief Guest and Guest of Honor. Sir, please.
Most Honorable Governor Haryana, His Excellency Ashim Kumar Ghosh, His First Lady and the First Lady of Haryana, Mitra Ghosh, the guest of honor, distinguished medical scientist V.K. Paul, President NAMSCON, Professor Digambar Behra, President-elect NAMSCON, Lieutenant General Velu Nair, Organizing Secretary of the conference, Dr. Ratho, and the Secretary of NAMS. Distinguished members and dear friends, it's my proud privilege to welcome you all to today's NAMSCON event. This is a very special event. NAMSCON is the apical medical body, the medical body of medical bodies, as one would call it, and often is constituted by members who are actually the founding fathers of Medicare in modern India, who have enlightened us with their hard work, with their commitment, and have given us a path and a trajectory of action to follow. The chief guest, Honorable Governor Ashim Ghosh, is from Bengal. I am deeply indebted to him and his First Lady for having graced this occasion. Today, he has had a very hectic schedule. He is coming straight from Bhiwani and he is coming by road. Yet, he continued with his program. Sir, with folded hands, I express my gratitude on behalf of everyone to you and your lady wife to have decided to, I would say, brave the roads of Haryana and come to PGI Chandigarh on time. Professor Ashim Ghosh, first let me introduce the man, then I will introduce the giant inside him, is a political scientist. He has served as head of the Department of Political Sciences in a very famous college in Bengal. And after that, as one would expect, he joined the BJP, where he has gone up the ladder to be where he is today. My interaction with Professor Ashim Ghosh is just 1 month old. I felt it my moral duty to go and extend the greetings of PGI, so I went and met him. And what I found was a man who's a Golconda of history. If you understand the meaning of the word Golconda, that is one word which the British borrowed from Hindi, an Indian language. Brilliant would be an understatement. He actually sized me up in no time. Thank you for doing that, sir. And it was incredible to believe that a politician, if I am allowed to use that word, sir, has such a profound knowledge of Indian heritage, ranging from Raja Ram Mohan Roy to Rabindranath Tagore to Swami Vivekananda to Bankim Chandra Chatterjee to B.C. Roy and whatnot. Each with the strength of a man who is thinking and a person who is deep in thought when he talks about Indian history and Indian heritage. Sir, I was touched by your knowledge. I knew you are from the political background, sir, if I'm allowed to use that word. But what you told me that day was just how deep a person can be in, about Indian heritage. And anyone who actually wants to know about Indian heritage must realize one thing. There is more Indian heritage below the surface than it is on the surface. There is more Indian heritage in the stratosphere than it is next to the earth. He is aware of both. He is aware of both. Thank you so much for coming. I have the privilege of introducing the lady with a lamp, the lady who has been holding the ladder for him, Soma Mitra, ma'am is equally accomplished. And ma'am, I'm really grateful that you also took time out to come and grace this occasion. You've added gravitas to this occasion. Thank you so much for coming. The guest of honor, Professor V.K. Paul, another giant. I don't have to introduce Professor V.K. Paul. He needs no introduction. But I will introduce him as someone who has done better post-retirement than before retirement. Am I wrong or right, sir? I'm right, sir. Right? You see, why I say this is, he is one of the pivots who started the Ayushman movement. And I think the greatest gravity-defying program in India, post-independence, has been the Ayushman movement, sir. And the person who started it, the giant who started it, is Professor V.K. Paul. It is not easy to do something new, and it is not easy to do something right, especially in the Indian ecosystem. But the way Ayushman has taken off is an incredible story in itself. I do not know whether you are aware or not, that वो कहते हैं कि apartheid खत्म हो गया and all that thing, but there is a very strong glass apartheid against India still. Let me tell you that, especially when it comes to the West. If you look at Western journals, they are always taking pot shots at what we lack. Even the Western journals, as esteemed as NEJM and Lancet, had no option but to praise the Ayushman movement. All thanks to you and your team, sir. To PGI's humble credit is the fact that we have the largest number of Ayushman Amrit outlets in India, in double figures. We are 12 and we plan to go from strength to strength. More than 70% of admissions in PGI are for Ayushman beneficiaries. So we owe you a debt of gratitude more than others, because this institute is considered often the last port of call for the surrounding states. When we were called into action in Op Sindoor, we got orders, we moved. Our drivers moved, our nursing officers moved, our residents moved, our blood transfusion medicine department sent blood supplements to Jammu and onwards. We did not flinch. When there was this massive cloud burst in Kishtwar, I got a phone call from the Chief Secretary that Vivek, we need your help. Believe it or not, sir, in no time, I thought, where am I going to get the volunteers? Sir, in no time, there was such a big list of volunteers, I have found it difficult to decide whom to send, whom not to send. And I felt PGI has come of age, is going from strength to strength, is doing a fantastic job, and is trying to give back to the society what is expected out of it. But then we also need support. Sir, आप इमेजिन नहीं कर सकते हमें आयुष्मान की कितनी सपोर्ट है. जो आप हमको 1 पैसा देते हैं, हम उसका 1 रुपए सोसाइटी को बना के देते हैं. So for the 5 lakhs that you give us, we easily convert it into 50 lakhs. How we do it is a different story. But we give back 50 lakhs to the society. Free kidney transplants, free heart transplants, free knee transplants. Sir, this does not happen anywhere else other than India under Ayushman. Let's all be proud of that. Let's all be proud of our achievements. I am so grateful to the Honorable Governor, the Lady Governor, and Professor V.K. Paul, and to each one of you to have come and graced this occasion in a dham which I call PGI. Namaskar, Jai Hind.
Thank you, sir, for your kind words. May I now request Professor Umesh Kapil, Secretary NAMS, to commence the formal convocation proceedings.
Good evening, sir. Good evening, all of you. President NAMS, I humbly request you to grant permission to open the convocation. President Sir, I present with you the emeritus professors who have been elected during year 2025 for presentation of scroll. May I request, oh, you want to say something?
May I invite Dr. Digambar Behra, President NAMS, to address the gathering, please, before we start with the convocation proceedings.
His Excellency, the Governor of Haryana, Professor Asim Kumar Ghosh, the First Lady of Haryana, Mrs. Ghosh, Guest of Honor, Professor Vinod Paul, Professor Vivek Lal, the Director of PGI, Chandigarh, Professor R.K. Ratho, the Dean Academics, PGI, Chandigarh, Lieutenant General Belu Nair, the President-elect of National Academy of Medical Sciences, the Honorable Council Member of the National Academy of Medical Sciences, esteemed guests, the NAMS family members, ladies and gentlemen. It is my great pleasure to welcome you all to this 65th annual convocation of the Academy at this institute, that is PGI, Chandigarh, a celebration of achievements of the Academy and a dedication to promote continuing medical education for medical and allied health professionals and to support policy initiatives in the country. On this special occasion, we are honored to have with us His Excellency, the Honorable Governor of Haryana, as our chief guest for this function. Professor Vivek Lal has already introduced him to all of us, but only I can just tell you one sentence that he is a renowned educationist. Professor Ghosh has contributed immensely to Indian academia over 4 decades. About Professor Vinod Pal, actually, although he is actually very much one of us, we always, sir, he has reached to the heights and he has given so many good ideas about healthcare delivery system in the country, which the director has already told you. But always, Professor Bal, you are considered one of us, and we always think you as friends to many of us, and you are also a fellow of our academy. So that is a great thing for the academy. And again, on behalf of the Academy, I also extend a very warm welcome to Dr. Abhijat Seth, the President of National Medical Council and the National Board of Examination, Dr. B.M. Katoj, former Director General ICMR, Dr. K.K. Talwar, former Director PGI and a former President of NAMS, Dr. Y.K. Chawla, former Director PGI and again another good friend of NAMS, Dr. Sanjeev Misra, the Vice Chancellor of Atal Bihari Vajpayee Medical University, Lucknow, Dr. Nitin Nagarkar, Pro Vice Chancellor in charge, Executive Director from various AIMS like Dr. Saurav Varsne, Dr. Madhavanand Kaur, Dr. Asutosh Biswas, Dr. Minu Singh, Dr. Shakti Gupta, then Dr. G.P. Thami, the Director Principal of Government Medical College, Chandigarh, my colleague, of course, Dr. General Nair, I have already addressed him, and the all other esteemed distinguished guests, fellows, newly elected NAMS fellows, members, and their families, and all other dignitaries present here today to grace this occasion. I would like to thank Dr. Vivek Lal, the Director of PGI, and Dr. Ratho, the Dean Academics of PGI, for kindly accepting our request to organize this convocation at this prestigious institute. It is specifically and personally, it is a great thing for me because on the first year of my presidency, this is my alma mater, and the institute has honored me in agreeing to arrange this convocation. And Dr. Vivek Lal, it is a wonderful conference you have organized for us. Ladies and gentlemen, I would like to take this opportunity to briefly highlight the various activities of this academy. In 1960, the following resolution was passed in the Central Council of Health meetings. I quote, "The Central Council of Health, having carefully considered the views expressed by the state governments, universities, and professional organizations on the proposal for the setting up of an Indian Academy of Medical Sciences, it welcomed the proposal for the establishment of an All India institution with a view to bring on a common forum the best talents in the field of medical sciences in India. Dr. D.P. Karmarkar, the then Union Health Minister, expressed that eminent Indian medical scientists, instead of looking for a recognition outside the country, should be honored and their merit should be recognized in the country itself. So the Academy was registered on the 21st April of 1961 and was registered with the Registrar of Societies as the Indian Academy of Medical Sciences. Then this is how the NAMS was born, and it is a unique institution established in independent India to foster and utilize academic excellence to meet the medical and social goals of the country. Sir, the importance of the academy can be gauged by the fact that it was inaugurated at New Delhi on the 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India, and its first convocation was held on the 8th December 1963 at Vigyan Bhavan, New Delhi, which was addressed by Dr. Sarvapalli Radhakrishnan, the then President of India. Unlike many professional associations and societies of various branches of medical sciences, the Academy is a conglomeration of all branches of medicine that brings the medical and scientific fraternity into one platform. In the words of our guest of honor, Professor Vinod Pal, the NAMS that he has told on 7th August 2021 on its 60th convocation, he said that NAMS is truly envisioned as a banyan tree, that is ek bhat vriksha hai, and it encompasses all medical sciences of the Indian nation. The Academy has a council of 23 members, and many of them, almost every one of them, are present here, and they guide the activities of the Academy, and they are the veterans and giants of medical and dental fraternity with vast and they have with vast experience and are elected by the fellows of the Academy. The country had a great expectation from the Academy. I would like to quote few of the wish list from some of the great leaders. Actually, in the inaugural address, the Prime Minister of India had said, I quote, "I hope the Academy would lay stress on the pursuit of research work and simultaneously ensure that high standards are maintained. Research is an inseparable part of any systematic pursuit of knowledge, and therefore it is imperative that the quality should be absolutely first class." Of course, there are many such expectations from many great people of the country, so because of a lack of time, I am not going to quote many of them. I just gave you one quotation. So the NAMS has a glorious heritage with 2 Bharat Ratnas, 19 Padma Bhushans, 53 Padma Shri awardees as its fellows. The Academy confirms the fellowship and membership selected through a peer review rigorous process. As I was telling you in the morning, so the success rate for getting a fellowship is around 15%. Presently, the Academy has 1172 fellows, that we call them as FMS, 12 international fellows, about 2,915 members, that we call the MAMS, and 160 associate fellows, and 11,501 members, those who have completed their National Board of Examination, 61 associate members, and 53 emeritus professors. So the NAMS vision is to act as a think tank for policymakers in all spheres of medicine, including medical education, research for cost-effective healthcare to help the humanity at the national and international level. I'll just name, it is not possible to actually enumerate everything that the Academy is doing. I'll just tell you, we have got, we have got 53 emeritus professors, as we have said. They are selected by NAMS. They provide guidance and mentorship to various institutions to develop specialty and laboratory services. Then the NAMS has 23 state conveners and 9 state chapters. The NAMS Council has approved to honor eminent medical and biomedical women scientists in India, and soon after, actually this year, we are honoring 3 eminent women scientists in the medicine. The last year, actually, we had the convocation at the AIMS Jodhpur, and the Honorable Vice President of India had given his inaugural address. The other activities that we carry out through the Academy, it is the things like mid-NAMSCON, then the MediQuest quiz, and then Academy provides funding to junior and middle level medical and biomedical teachers to go to well-established centers of excellence and acquire newer skills. NAMS also initiated research fellowships for postgraduate medical students. Our Navigate program, that is for the PG students, that is now jointly organized by AIMS, and from this year PGI has also supporting us in this endeavor. All the information about NAMS and its activities is available on the NAMS website, and those who are interested, they can go through that. NAMS has also its own publication in the form of the Annals of National Academy. Just recently, we have renewed our vision for the future, what NAMS should do. It was done under the guidance of Dr. Katoch, and then our aim is to act as a resource group and a think tank for policymakers in all current and future spheres of health. Please, just wait. And it is to act as a resource group and a think tank for policymakers in all current and future spheres of health, including medical education, research, innovation, and incubation for cost-effective healthcare to help the humanity. We have prepared a roadmap to achieve this vision with reorientation and reorienting ourselves with renewed infrastructure and human resources. So the generation and dissemination of medical knowledge by seeking suggestions from NAMS fellows, council members, and medical colleges from all over the country. So then we are also trying to prepare and publish the policy and the other state-of-the-art documents for policymakers at the national and the state level. So I think because of the lack of time, I am not going to elaborate all those activities that we have carried out and that we are planning to do in future. but only I'll just like to tell a few lines about the contribution of NAMS, that is we are going to do about the Vikasit Bharat 2047. You know, today morning we had a discussion about medical education, the healthcare delivery system and the biomedical research in India. We have just with all the who's who of this country, they have taken part. Of course, because of shortage of time, we could not discuss in detail, but that was just the ball rolling. So throughout the year, we will be, analyzing all these things, and in a positive way, we will try to impress upon the government and try to, provide our outputs from the or on behalf of the academy to the government of India to fulfill our national goals for the Vikasit Bharat as regards health is concerned. So ladies and gentlemen, at the end I welcome you all again to this 65th convocation of National Academy, and I welcome all the newly elected fellows, the associate fellows, the fellows from the the USA. We have got two, I think, distinguished fellows, renowned fellows. They are also coming here. They are here with us, and the members and all the associate members. And I welcome you all to this august body, and please be proud to become part of this august body. So thank you and Jai Hind.
Thank you, sir, for your inspiring and motivational address. May I now request the Honorable Chief Guest, the Guest of Honor, and the dignitaries on the dais to come forward for the presentation of scrolls to Emeritus Professors and NAMS Women Scientists 2025. Starting with the Emeritus Professors 2025, I call upon Dr. Mahesh Verma from Dental Surgery. Dr. Savita Malhotra, Psychiatry, please come forward. Dr. Savita Malhotra from the Specialty of Psychiatry. Dr. Bishan Swaroop Garg, please, from Community Medicine. Dr. Sunila Garg, please, follow, from Community Medicine. Dr. Bishan Swaroop Garg from Community Medicine. Thank you. Dr. Sunila Garg, again from Community Medicine. Dr. Avinash, please come on the dais, followed by Dr. Ashok Shah. Dr. Avinash Nivriti Soop from Surgical Gastroenterology and Medical Education. Please give a loud applause, please. All senior members and getting prestigious honors. Like Dr. Ashok Shah from Specialty of Pulmonary Medicine. Next, can I request the NAMS women scientists to be on the dais, please? Can I also request you to have a loud applause for NAMS Women Scientists 2025. The first in series is Dr. R.S. Jayashri. Dr. Manjari Tripathi. And Dr. Savitri Sharma. Thank you, sirs. Kindly occupy the seats. May I now call upon Professor Umesh Kapil to proceed with the ceremony. Just a moment, please. Dr. Jyoti Raman Biswas has just come. Let him honor. Let us honor him as the Emeritus Professor.
Yes. Yeah. Sir, I'd like to present to you the most eminent scientists who have been identified by National Academy of Medical Sciences for the year 2025. So we have 58 of them. So to give individually to each of them would be slightly demanding for you after a hectic day you had. So what I suggest is what has been suggested to me, that we'll call 10 fellows at a time, and they can stand on each side, 5 on each side, and then they can be given the Scroll of Honors. So because hectic day, it will not be possible to individually give it to you. So may I request Dr. Shaji, Dr. Vincent, please make a row. Dr. Ashutosh Vishwas, Dr. Jagdish Chandar, Dr. Akhilanesh Chaurasia, Dr. Rameshwar Chaurasia, Dr. Chandani, Dr. Jaya Chakravarti, and Dr. Chandan Das. उसका ADC से मैंने बात करी, 58 को कहाँ देगा?
हाँ तो फेलोज को सारे दे देना फटाफट। तो प्रेजेंट सर ने बोल दिया आई प्रेजेंट यू।
हाँ हो गया हो गया। मैम शांति रखो
नहीं
सब
सर्टिफिकेट लेके खड़े ना, देना है इनको।
मालूम नहीं, अभी हो जाएगा, धीरे धीरे हो जाएगा। सर उस तरफ से जाइए आप। एक मिनट क्या कह रहे हैं डॉक्टर? ऐसा तो नहीं हमारी we can have Dr. Prasanjit Das, Dr. Saket Das, Dr. Chandrasekhar, Dr. Sharmishta Day, Dr. Bhavuk Garg. 5 can stand on the right side of the chief guest and 5 on the left hand side. Dr. Rajiv Garg, Dr. Ujjwala Ghoshal, Dr. Shubham Bhandari, Dr. Pratima Gupta and Dr. Viveka Josna and Dr. Gopal Bandhu Jaina. ठीक है यार।
बाद में चेंज कर बाद में चेंज कर यहाँ पे चल आप नेक्स्ट बुला लीजिए।
Dr. Next batch we have Dr. Hemanta Kumar Kar, Dr. Suman Kanungo, Dr. Jyotdeep Kaur, Dr. Salim Khan, Dr. Madhu Khanna, Dr. Vishal Kumar, Dr. Anand Mahesh and Dr. Anand Pandey and Dr. K.K. Prasad. The next batch we have is Dr. Anupam Parashar, Neeta Radhakrishnan, Dr. Amit Rawat, Dr. Vandana Roy, Dr. Sandeep Sahu, Dr. Jeeva Shankar, Dr. Vartika Saxena, Dr. Anshu Rajneesh Sharma, Dr. Sadhna Sharma, Dr. Aditi Sharma and Dr. Nikhil Shrivastava.
आप नेक्स्ट फोटो में आ जाओ। अच्छा सर आप अनाउंस कर लीजिए।
हाँ करते यार करते. So next batch we have is Dr. Sonu, Dr. Vaishali Suri, Dr. Sanjay Tiwari, Dr. Vel Pandian, Dr. Ganguly,
You can go to the मैम आप उस तरफ चले जाइए सर आ जाइए सर वन मोर यस थैंक यू जितना बच्चे
we have 100 members who are wearing the black coat.
Sir,
how do we go about it?
और ये हो गया 69 वाला हो गया
हो गया
सर ऐसे ऐसे 5-5 कर लेंगे दैट इज आल्सो 10-10 करके
बुलाने 5-5 करते हैं
बट वो रुकेंगे नहीं सर कंटिन्यूस आ जाएगा
हाँ हाँ कंटिन्यू. So next we have the members of the National Academy. I request Dr. Asghar Ali, Nazia Anzum, Dr. Anshuman Sevda, Dr. Rajiv, Dr. Ashwini, Dr. Aditi Bansal, Dr. Monica Bansal, Harbhajan Barun, Dr. Pratik Sudhakar.
सर यू कंटिन्यू कीप कॉलिंग सर
Yeah, I'll call that. The next batch we have Dr. Chaitra, Dr. Vinay Singh Chauhan, Dr. Ganeshri Chitra Durga, Dr. Sarthak Das, Dr. Rekha Dutt, Dr. Tanima Divedi, Dr. Vibha Gangwar, Dr. Preeti Garg.
थैंक यू
Next batch we have Dr. Archana Gaur, Dr. Manaswi Gautam, Dr. Chanchal Goyal, Dr. Ankit Gupta, Dr. Munesh Gupta, Dr. Shefali Gupta, Dr. Sonisha Gupta, Dr. Mayank Hans, Dr. Abhishek Jaiswal, Dr. Kirti Jaiswal.
सर यू कीप कंटिन्यू कॉलिंग
I'll do that. The next batch we have is Dr. Josna, Dr. Amanjot Kaur, Dr. Anju Khairwa, Dr. Ashok Kumar, Dr. Ashutosh Kumar, Dr. Harish Kumar, Dr. Lalit Kumar, Dr. Nitin Kumar.
मैम वन मोर उस तरफ आ जाइए चलिए
Dr. Next batch we have is Dr. Prabhat Kumar, Dr. Sushil Kumar, Dr. Shiman Kumari, Dr. Rekha Kumari, Dr. Rashmi Kumari, Dr. Rajesh Kumar, Dr. Pinaka, Dr. Sabina, and Dr. Shilpa.
थैंक यू सर नाम उस तरफ जाइए
Dr. Next batch we have Dr. Soumya, Dr. Pradeep Mitra, Dr. Kirti Nirmal, Dr. Ravi Pachori, Dr. Ramesh Paul, Dr. Padurangi, Dr. Navbir Pasricha, Dr. Chandra Prakash Prasad, Dr. Anamika Purohit, Dr. Nikhil Pursani, Dr. Shruti Radera.
मैम बाद में एक अजय प्लीज प्लीज आगे
Next batch we have is Dr. Swati Rajput, Dr. Bhavani Raina, Dr. Raksha Kundal, Dr. Sangamitra Ray, Dr. Reddy, Dr. Ravi Kiran, Dr. Meenakshi Rohila, Dr. Richi Singhal, Dr. Ravinder Sahdev.
आगे पकड़ा दीजिए अजय एक्सक्यूज मी थोड़ा सा आप यहाँ पे मैम आप वेट करिए मैम आप यहाँ पे वेट मैम मैम
Next batch we have Dr. Nathini, Dr. Mehndi Hayat Shahi, Dr. Arun Sharma, Dr. Rachit Sharma, Dr. Geeta Singaria, Dr. Amrita Sil, Dr. Anu Singh, Dr. Dhananjay Kumar Singh, and Dr. Jawahar.
मैम आप यहाँ पे खड़े यहाँ पे थैंक यू
The next batch we have is Dr. Harpreet Singh, Dr. Prashant Siroya, Dr. Suprita, Dr. Tirath Raj Verma, Dr. Vijay, Dr. Shah Mohammed, Dr. Abhilasha Yadav, Dr. Geeta Yadav. Please.
आगे प्लीज बोला इस तरफ आ जाइए थैंक यू
The last batch we have is Dr. Menka Yadav, Dr. Prateek Yadav, Dr. Ranjan Gupta, Dr. Renu Suthar, Dr. Anita Gautam, Tarbej Jafar, Israr Ahmed, Dr. Sarang Shete, Dr. Shitij, Dr. Prasad Sinha.
आ जाइए मैम आ जाइए थैंक यू थैंक यू आगे चले जाइए प्लीज एक दो आगे चले जाइए
Now we have a list of associate fellows. Dr. Supreet Basu, Dr. Khushbu, Dr. Amol Dahale, Dr. Siddharth, Dr. Manik Malik, Dr. Prakash Pandey.
थैंक यू
The next batch we have is Dr. Arun Sharma, Dr. Dev Prakash Sharma, Dr. Varun Venkat, Dr. Vikram Vishwajit, Dr. Menka Yadav, Dr. Renu Sutar, Dr. Nidhi Chauhan, Dr. Bhushan Shah.
आप यहीं पे आप आगे चलिए please, आगे चलिए आगे चलिए थैंक यू अभी डन मैम? हाँ दे दीजिए. थैंक यू. आप यहीं से आ जाइए. आगे प्लीज. Thank you.
So, President NAMS, I have presented you the fellows, members, associate fellows, and so please permit me to admit them into the NAMS family.
In the name and by the authority vested in me as the President of the National Academy of Medical Sciences, I admit you all as fellows, associate fellows, and members thereof.
It's indeed an honor to have with us today Dr. Vinod K. Paul, Member Niti Aayog, a visionary leader whose contributions to healthcare policy, medical education, and public health have profoundly shaped the nation's medical landscape. Ladies and gentlemen, please join me in welcoming Dr. Vinod Paul to address this august gathering.
Good evening, Namaskar. Honorable Governor of Haryana, Professor Ashim Kumar Ghosh ji, Srimati Mitra Ghosh, First Lady of Haryana, President of NAMS, Dr. Digambar Behra ji, President-elect NAMS, Lieutenant General Venu Nair ji, Director PGI, Dr. Vivek Lal, Secretary NAMS, Dr. Umesh Kapil ji, our Dean, Dr. Radha Kant Rathore ji, the members of the esteemed Council of National Academy of Medical Sciences, fellows of NAMS, associate fellows of NAMS, members of NAMS, distinguished faculty of PGI MIR. I'm truly honored to be here in the august presence of the Honorable Governor and the distinguished presence of all of you. The National Academy of Medical Sciences, as you heard from my distinguished colleague, Dr. Behra, is a unique organization. Honorable Sir, it represents all the disciplines of medicine and medical sciences in the country: orthopedics, pediatrics, anatomy, biochemistry, surgery, cardiology. It's one umbrella under which the leadership of this in medical sciences, medical education, and clinical care comes together to serve the nation. I'm honored to be a humble fellow of NAMS for some time now. Our journey for Viksit Bharat at 2047 would pass through India becoming a Swasth Bharat. In fact, this imperative has to be achieved before 2047 because health is enabler for development. And development leads to better health in many ways. Of course, there are risks as well. Viksit Bharat, according to the Honorable Prime Minister, is also about strong, world-class institutions. NAMS is one of those institutions. If you combine these two imperatives, Honorable Sir, then there is a special responsibility on NAMS to enable, in its own way, making this India, making our Bharat, this country, our beloved Bharat, a Viksit Bharat. That's the importance. The Honorable Prime Minister has repeatedly said in multiple speeches that all of us individually and collectively have to make contribution on a daily and a weekly basis toward that goal, because that is the responsibility of this generation for the next generations to create, that is to create a Viksit Bharat. And in that regard, building on the strengths, embarking on the strengths of National Academy of Medical Sciences, and respected President mentioned clearly, think tank, policy enablers, idea, cauldron, and so on. I have 4 humble suggestions to make while we celebrate the achievements of NAMS. Firstly, NAMS has been a think tank producing highly accomplished, insightful documents, several of them every year. But I would now suggest that we take this little further while we continue to do so, because that thinking, encapsulating thinking into such documents, historic documents, must be coupled with specific studies and specific ideas and suggestions that emerge out of studies. I'll give an example. Would you like to study how Ayushman Bharat PMJ has done? We have a network of members in every center of excellence, perhaps in every medical college or most medical colleges. Can we see how the competency-based medical education curriculum, which was launched in 2018-19, how is it doing with regard to the competencies of undergraduate students? Who else will do it? Antimicrobial resistance. How are we doing across our own ecosystem of centers of excellence, medical colleges and institutions at large? Studying district residency program. It's a very major program of the National Medical Commission, under which in the second year of postgraduate program, every PG student goes to serve in a district and a sub-district hospital. How well we have done. What would you like us to do to improve this, and so on. There are other ideas. The nation is building critical care blocks, which will add, sir, 35,000 critical care beds. How are we doing it? What can we do to make this huge resource created with the public money to be most useful, and so on. So I'm suggesting that we create a hub for research and evaluation within NAMS and conduct policy relevant studies of the kind that I suggested, and many, many more. Ayushman Arogya Mandirs, a huge infrastructure that's being created, and I mentioned this in the forenoon. My second request is, President and the leadership of NAMS, it's about organ transplantations. A few years ago, you created a stellar document on organ transplantation in India, but there are challenges. We need 200,000, 2 लाख किडनी ट्रांसप्लांट चाहिए और हम 14,000 करते हैं. हमें 25 से 30,000 लिवर ट्रांसप्लांट चाहिए पर एनम, लेकिन हम 4,901 करते हैं. To me, the major reason is that the expertise to do so in our medical colleges, even centers of excellence, is missing. And this needs to be developed. If you look at the data, for kidney transplant, there are 666 transplant centers in the country. 581 of them are in the private sector, only 85 in the government sector. We need to change this. And can we come together, National Academy of Medical Sciences, to change this? We need to only 10 to 12% of all transplants, kidney 12%, liver 10% of all transplants that are undertaken in the country are done in the government sector institutions, including all our AIMSs, centers of excellence and medical colleges and so on. This must change. So therefore, my second proposition is, can NAMS in the next 3 years, in the presidency of the president and the next president, we create 50 teams for kidney transplant in this country and 20 teams for liver transplant in this nation. Can we work for it? It's about training, it's about creating opportunities, connecting the dots. And I think NAMS is in a great position to do so. My third request is to promote, support, and help create an ecosystem for family medicine training. Family medicine is about individual care across the age, from childhood to the geriatric population, and in fact, I would say, in particular geriatric population, which will move from 15 crore to 35 crore by 2047. It's about a general physician doctor today's MBBS doctor is, humbly I submit, is not fully loaded to be a next door GP of the previous times. Expectations are more. Our program does not provide continuity for chronic care. There are other reasons, I will not go into the detail, but the nation needs general practitioners. And we are moving ahead with specialty programs in a very big way. We will be having a huge, almost 90% plus specialists by 2047 and a few MBBS trained doctors. There is be no space for family physician. It's an emergency. It's enshrined in the National Health Policy 2017 as well as in the NMC Act, the will of the Parliament, but we need to do a great deal. We only have 5,000 family physician, MD family physicians in the country. We have only 17 seats in the NMC system, only 17. And DNB seats put together, total of 500 seat pipeline. This must change. I plead with you that we would like to work with you to translate the will of the Parliament to create a presence of about 20 per lakh presence of family medicine physicians going forward. My last suggestion is with regard to artificial intelligence and health. We know it's upon us. One of the most important sector that will use AI and will disrupt its own system is indeed health, followed by agriculture and so on. 3 responsibilities of academia in this regard. A, create AI solutions. We need to work together. This network should think what is it that we can do to create AI for health. We should not be the consumer of AI for health alone, the biggest consumer in the world, but be the biggest creator of AI for health. That's my first take. Second, we need testing grounds and testing situations, real life situations where AI products developed by our own startups and other people and by our own selves should be tested and validated in terms of, in many ways, but in terms of sensitivity, specificity, and so on. And also lastly, for AI, people who create AI will benefit, but people who will adopt AI will benefit more. Those societies which will move to adopt validated AI technologies will benefit more because they will make a difference on the ground. So we need to work together to adopt AI, those solutions which are validated, which are workable, which are context specific. An example is digital X-rays for TB, for example, and so on. We must be the forerunners for adoption, and therefore I request NAMS leadership to consider this as my 4th suggestion. I thank the leadership of NAMS for the opportunity given to me, and in the end, I would submit the following, and I quote Swami Vivekananda to say, all power is within you, you can do anything and everything, unquote. Thank you very much. Jai Hind.
Thank you, sir, for your enlightening and thought-provoking words. Healthcare and governance share a beautiful common mission to uplift lives, empower communities, and ensure the well-being and dignity of every citizen. Together they form the foundation of a thriving, compassionate society where progress is measured not only by economic growth, but by the health and happiness of its people. It is therefore a moment of immense pride and honor for all of us to welcome a visionary leader whose life and work embody these very ideals. A statesman of wisdom, compassion, and dedication, Professor Ashim Kumar Ghosh, Honorable Governor of Haryana, stands as a beacon of inspiration in the fields of governance and public welfare. His unwavering commitment to excellence in healthcare and his relentless pursuit of equitable development continue to guide and motivate us to strive for greater heights. With great enthusiasm and heartfelt respect, I now invite our esteemed chief guest, Professor Ashim Kumar Ghosh, to grace us with his words of wisdom and deliver the 65th Convocation address. Sir, please.
Mrs. Mitra Ghosh, First Lady of Haryana, Professor D. Behera, President, National Academy of Medical Sciences, Lieutenant General Velu Nair, President-elect, National Academy of Medical Sciences, Professor V.K. Paul, Member, Niti Aayog, Dr. Vivek Lal, Director, PGI, MER, Chandigarh, Professor R.K. Rathore, Dean Academic, PGI, MER, Dr. Umesh Kapil, Secretary, National Academy of Medical Sciences, esteemed faculty members, honored guests, and above all, the graduating scholars. It gives me immense pleasure to join you all at the 65th Convocation of the National Academy of Medical Sciences, India. Today marks the beginning of a new chapter that will test your wisdom, compassion, and commitment to serve the humanity. The National Academy of Medical Sciences has, over the decades, stood as a beacon of medical scholarship and ethical practice. Through the fellowship programs, academic initiatives, and contributions to the policy and public health, the Academy has upheld the finest traditions of Indian medicine and sacred trust to alleviate suffering. I congratulate all fellows, members, and award recipients for upholding this noble legacy. Ladies and gentlemen, as we gather here today, we are reminded of the tremendous transformation underway in healthcare and medical education. The COVID-19 pandemic exposed the vulnerabilities of our system, but also accelerated innovation from telemedicines and AI-assisted diagnostics to global collaboration in vaccine development. The lesson is clear. Medical science can no longer exist in isolation. It must evolve with technology, ethics, and empathy as equal partners. India today stands at a remarkable juncture with growing biomedical research capacity, cost-effective healthcare facilities, and a rapidly expanding pool of healthcare professionals. Have a look at the innovation index of the world. In 2015, index-wise, our position was 81. Today, in 2025, in innovation index, our position is 35. What a tremendous achievement we have been able to make. There has been a surfeit in patents. There has been a surfeit in research-oriented publications in magazines of international repute. There has been tremendous development in the field of technology-driven agricultural and industrial production. We have made huge progress in many fields. Yet, a lot to be done to provide quality ethical and affordable health care to the rural as well as economically disadvantaged population as a collective mission. I urge the young doctors and researchers graduating today to think beyond the walls of the laboratories and clinics. The true measure of our education lies not in the titles you hold, but in the lives you touch upon. Remember that every prescription you write, every diagnosis you make, every experiment you conduct must be guided by conscience and compassion. As a teacher and academician myself, I have always believed that education is not the end of learning, but its beginning. The field of medicine evolves every day. What you know today may become obsolete tomorrow. Keeping yourself updated with latest technology and research is a must for you as well as for the welfare of our patients. I also take this opportunity to commend the National Academy of Medical Sciences for promoting interdisciplinary collaboration, supporting young researchers and contributing to national health missions. Your work resonates deeply with the vision of healthy Viksit Bharat, a developed India rooted in knowledge, innovation, and inclusiveness. To the graduating scholars, I say this with conviction. You are the custodians of a noble profession. The white coat you wear is not a symbol of privilege, but a profound responsibility. Carry it with humility and pride. Let your life's work bring healing, hope, and honor to your patients and to our nation. I once again congratulate each of you and your families. May your future be bright, your curiosity unending, and your compassion boundless. Thank you. Jai Hind.
And visionary address. Your words will continue to resonate deeply in our minds and guide our collective journey ahead. To express our heartfelt gratitude, may I request Professor Vivek Lal, Dr. Digambar Behra, and other dignitaries on the dais to felicitate our revered chief guest, Professor Ashim Kumar Ghosh, Madam Mitra Ghosh, and our esteemed guest of honor, Dr. Vinod Kumar Paul. Thank you, everyone. May I now invite Professor Umesh Kapil, Secretary NAMS, to continue with the formal proceedings.
President Sir, may I request your permission to close the convocation? Thank you very much, sir.
As we come to the conclusion of this special ceremony, I am reminded of Helen Keller. I quote, "Alone we can do so little, together we can do so much," unquote. Today's convocation is a shining example of collaboration and shared purpose, celebrating excellence in medical science and education. May I call upon Professor R.K. Rathore, Dean Academic PGI, to propose the vote of thanks.
Good evening, everybody. As we draw close to the momentous occasion of the 65th convocation of National Academy of Medical Sciences India and the NAMSCON 2025 PGI Chandigarh, I feel honored and privileged to stand before you to propose the vote of thanks. Sir, it is very well said that gratitude is the greatest virtue in life. On behalf of the entire PGI fraternity, as well as NAMS India, we are profoundly thankful to our chief guest, His Excellency Professor Ashim Kumar Ghosh, the Governor of Haryana, for the time and attention you have given to this ceremony, despite your many commitments of the whole day. Your words have not only enlightened the gathering, but also instilled renewed motivation among the NAMS fellows, the awardees, and young scholars to pursue excellence in the medical science with humility and dedication. Sir, your distinguished academic background and long public service embody the ideal of intellectual leadership in action. The Academy is honored by your presence today and looks forward to your continued guidance and support in our endeavors to strengthen the nation's health system through science, education, and practice. So once again, we express our heartfelt thanks and deep appreciation to you for gracing this occasion and for your motivation. Thank you, sir. The organizing committee expresses their deepest gratitude to our First Lady of Haryana, Srimati Mitra Ghosh, for gracing the occasion. You have been a source of inspiration to all of us on this occasion. Thank you, ma'am, for sparing the time and be here with us. With deep gratitude, we extend our sincere thanks to our guest of honor, Dr. Vinod Paul, for gracing this occasion. Sir, your contributions in shaping India's healthcare policy and infrastructure have been extraordinary. Everyone recognizes your leadership in the fight against the dreadful COVID-19 pandemic. Thank you, sir. You have been here and you are the source of inspiration and helpful to everybody. Special thanks to our director, Professor Vivek Lal, and the chairperson of this NAMSCON 2025 for the constant support and encouragements towards the conduct of this prestigious conference in every aspect. Sir, under your visionary leadership, PGI is flourishing as a beacon of excellence in medical education, patient care, as well as medical education research. Our special thanks to Dr. Dibangar Behera, the Padma Shri and the former Dean Research of PGI, as well as the President of NAMS, Lieutenant General Velu Nair, the President-elect NAMS, Dr. Umesh Kapil, the Secretary NAMS. We at the very outset thank you, sir, for giving an opportunity to host such a prestigious conference come convocation at PGI MER Chandigarh. Sir, it is to reiterate that PGI has to wait 3 long decades to have this conference to come to this institute. The first conference was there in 1994 and 95 when Dr. B.K. Sharma, Dr. Ganguly and Dr. R.C. Mahajan were the leaders. And after that, every time we are looking for it, and this time because of the Professor Behera and others, they have bestowed this capacity to PGI to hold this. Thank you very much for giving these opportunities. Presence of former directors, former deans, former vice chancellors, present directors, present executive directors from different universities and AIIMS-like institutions, they remind our tradition and rich heritage. Thank you all for your presence as well as motivation for PGI to go beyond its capacity. I would be failing in my duty if I do not thank each and every recipient of the award, the emeritus professors, the women scientists, the fellows, associate fellows and members, as well as the member of my institute function committee and NAMSCON 2025, especially with Dr. Asima Goel and Dr. Mandita Kakkar and Dr. Sadhana Lal contributing a lot, as well as the principal of 9 and their faculty students making it a grand success. At the last and not the least, my sincere thanks are to the administration, PGI administration, academic, finance and engineering section for their full support and contribution. We are grateful to the print and electronic media for their constant support. Thank you very much. Jai Hind.
Thank you, sir. Ladies and gentlemen, as we bring this memorable convocation to a close, I stand before you with immense gratitude. Thank you all for gracing this occasion and making the 65th convocation of NAMS a grand success. Please rise for the national anthem. Kindly remain standing until the academic procession led by President NAMS, Dr. Digambar Behera, has left the hall. And tea will be served in the area adjacent to this auditorium. All are welcome, please. And just one announcement, there is going to be a general body meeting immediately thereafter, right now. So all the members, please be here. Thank you.